Good morning, ladies and gentlemen, esteemed colleagues, and distinguished guests. A very warm welcome to the Masterclass in Fungal Infection organized by the Department of Critical Care Medicine, Caritas Hospital Institute of Health Science at Kottayam.
Today, we are honored to be in the presence of the finest mind in India, icons in the field of medical mycology and infectious disease. This masterclass has been made possible through the dedicated efforts of the Fungal Infection Study Forum, and we thank them for their vision and collaboration in bringing this exceptional academic initiative to life. I am Dr. Mithun Thomas.
And I am Malu. We will be the hosting section today. We will now have a pre-workshop evaluation. Would like to invite Dr. Shivapradash Rudramurthy sir.
So I request everyone to log on to the link which is provided here so that you will be joined into the WhatsApp group where you will be getting the more information regarding the pre-evaluation. Please log in. If anybody having any difficulty, let us know.
So good morning to you all. I am Professor Shivaprakash Rudramurthy from PGI Chandigarh. And this particular evaluation, pre-evaluation and post-evaluation, we have around 40 questions and you have to answer it within 30 minutes that has been given. So you will have most of the time you have one options correct. In wherever two options may be correct, that has been mentioned in the question itself. So it is our evaluation, so you don't need to give your identity also. So it is just our evaluation to see that the same questions will be provided at the end, how you perform at present now and what will be the result at the end. So you can freely answer your questions. We had made such a thing that all your questions will be answers for your questions will be dealt during our discussion, during our deliberations during this 1.5 days. So I think hopefully you will do the post evaluation better. Thank you all.
It's not coming.
I'll say I'll already shared.
5 minutes will be starting our session. So those who came now, you can scan this QR code and you can do the pre-test. It's also there in the group. Without further ado, let's embark our journey. No matter how much I introduce him, it would never do justice to the depth and the breadth of his contributions. Anything I say will only scratch the surface. So much would be still be left unsaid. So I simply call him what we all know him to be, the father of medical mycology in India, an outstanding global scholar in the field. Dr. Arnalogi Chakrabarti is a world renowned authority in medical mycology. He has authored over 650 publications with more than 29,000 citations. His lab at PGI MEA, Chandigarh, is WHO Collaborating Center and the Houses of National Culture Collection of Pathogenic Fungi. He has led several major global initiatives and currently serves as the president of the International Society of Human and Animal Mycology. Please join me in welcoming Dr. Arnaloge Chakrabarti to speak on epidemiology of invasive fungal infection in India with special emphasis on critically ill patients.
Okay, good morning to you all. Before just going into the topic, I request the mic is there, no? Can I just request everyone to introduce that just name and the subject from which they are. Like suppose somebody is from the critical care, somebody is from microbiology. Similarly, just quickly, first I like to introduce myself. I am Oruna Lokenot. I am Oruna Lok Chakraborty. It's a simple Bengali name, Oruna Lok Chakraborty, and I am from the microbiology area. Next, Atul, you can start.
I'm Atul Patel. I am a physician and practicing adult infectious disease at Ahmedabad, Gujarat.
As I said, I am Professor Shiva Prakash. I am heading the mycology division now. I worked under Professor Chakravarti for the last 24 years, and that's it.
Rajiv Soman, ID physician right now in Pune, but I spent almost my whole life in Mumbai at Hinduja Hospital. Now I'm at Jupiter Hospital, Pune.
I'm Professor Pradeep Bhattacharya, and I'm Professor and Head of Critical Care Medicine at RIMS Ranchi. And I have more than 25 years of experience in critical care.
Good morning, everyone. I'm Dr. Parikshit Prayag. I'm an ID physician specifically practicing transplant ID in Pune at the Nanath Mangeshkar Hospital.
I'm Dr. Uday, a critical care physician.
I'm Dr. Cyril from Kottayam itself. I'm a physician and nephrologist.
Dr. Anish, critical care medicine.
Dr. Deepa, assistant professor in microbiology in Government Medical College, Alappuzha.
Dr. Maya, assistant professor microbiology, Government Medical College, Alappuzha.
Dr. Reshmi, DRMB trainee, critical care.
Dr. Sumi, DRNB trainee, critical care.
Dr. Meenakshi, critical care medicine, DRNB first aid.
Dr. Tangam, gynecologist practicing in Kottayam.
Dr. Sapna, consultant microbiologist, Naima City, Kochi.
Dr. Ranjini, consultant microbiologist, Lourdes Hospital, Kochi.
Dr. Betsy, consultant intensivist, Renai Mary City.
Dr. Amina, consultant pulmonologist, practicing in Thrissur.
Dr. Shrita, ID fellow, Amrita.
Dr. Gina, consultant microbiologist, Matsleo Medicity.
Arya, general medicine resident.
Dr. Cyril, intensivist, Holy Cross Hospital, Kottayam.
Dr. Rathika, DRNB trainee, Pushpagiri.
Dr. Shalini, DRNB trainee, Pushpagiri.
Dr. Kurian, DRNB trainee, Apollo Athletics.
Dr. Vipin, critical care trainee, Apollo Athletics.
Dr. Insla, microbiology first year PG, Government Medical College, Kallam.
Dr. Nimmi, associate professor microbiology, Calicut.
Dr. Chitra, assistant professor microbiology, Travancore Medicity.
Sajita, pulmonologist, Kottayam.
Dr. Makrakti Soma, JR1 microbiologist from Kottayam Medical College.
Yes, I am Dr. Wasif, DM infectious disease trainee at Kottayam Medical College.
I am Dr. Nirmal. I am DM infectious disease trainee at Kottayam Medical College.
Manju, DM infectious disease, Kottayam.
Dr. Haritha, a senior registrar, Lakeshore Hospital ID department.
Dr. Nisha, assistant professor microbiology, Government Medical College, Kottayam.
Dr. Saumya, assistant professor microbiology, Government Medical College, Kottayam.
Dr. Harsha, assistant professor, Government Medical College, Kottayam, microbiology.
Dr. Boni, pulmonologist, Kottayam.
Dr. John, critical care resident, Caritas.
Dr. Anna, senior resident, microbiology, Amrita.
Dr. Anjana, senior resident, microbiology, MOIC Medical College, Kovalancheri.
Dr. Fasna, critical care resident, ICRA Hospital, Calicut.
Good morning, Dr. Joshua John, intensivist at Astra MEMS, Calicut.
Dr. Nisna, DRNB resident, ICRA, Calicut.
Dr. Juby John, Associate Professor, ID, Government Medical Kottayam.
Dr. Sheba, Associate Professor, Microbiology, Medical College, Koni.
Dr. Leah, Senior Specialist, Microbiology, Caritas.
Dr. Shijina, DRNB resident, Lakeshore Hospital.
Dr. Neeta George, HOD Critical Care, Lakeshore Hospital.
Dr. Ansu, Consultant Microbiologist, St. Gregorius, Parimala.
Dr. Tina, Assistant Professor, Microbiology from Pushpagiri Medical College.
Dr. Google, Senior Resident, MOIC Medical College, Ernakulam.
Dr. Ajit from Gokulam Medical College, Trivandrum.
Dr. Ajinath, Physician, Kochi.
Dr. Manajan, Oncologist and Palliative Physician, Caritas Hospital.
Shamol, Infection Control Nurse, Caritas Hospital.
My name is Shani, Infection Control Nurse, Caritas.
Dr. Thomas, DRNB trainee here in Caritas.
Dr. Noel, Consultant Critical Care, Caritas.
Dr. Basil, Senior Resident, Critical Care, Caritas.
Dr. Abdul Tulasi, Pulmonologist, Travancore Medical College.
Dr. Anu, Microbiologist.
I am Dr. Malavika, Clinical Pharmacist, Caritas Hospital.
Dr. Joshua, Clinical Pharmacist, Caritas.
And Dr. Jiten John, Clinical Pharmacist, Caritas Hospital.
Dr. Martin, Clinical Pharmacist, Caritas.
Dr. Alina, Microbiologist, Lakeshore Hospital, Kochi.
Dr. Harida, PG Resident, Sri Gokulam Medical College, Trivandrum.
Dr. Shihana, Sri Gokulam Medical College, PG Resident.
Dr. Kartiga, Microbiology, PG Resident, Sri Gokulam Medical College.
Dr. Rebecca, Microbiology, Caritas Hospital.
Juna, Microbiology Staff, Caritas Hospital.
Shaimol, Microbiologist, Caritas Hospital.
Dr. Juby, Consultant Intensivist, St. Thomas Hospital, Chettipada.
Dr. Kiran, Lecturer, Microbiology, Government TD Medical College, Alappuzha.
Dr. Ashit, Senior Resident, Critical Care, Caritas Hospital.
Dr. Arun, Physician.
Dr. Ranjit, DRNB Critical Care Resident, Medical Trust Hospital. Dr. Anuraj, Intensivist, Government Medical or Kottayam.
It's fine. Okay, good morning to you all. It's a wonderful opportunity. I'd like to thank at the outset Dr. Jacob and his team for giving us this opportunity to come and discuss with you. I'm sure you will understand that fungal infection, just to discuss over 2 days, I'm not making you master. But the thing is that at least within these 2 days, you get to know what are the things which are happening in this particular field. You know, this Fungal Infection Study Forum is a non-profitable scientific, educational, non-political organization specializing in the development of health, science and education in the country relevant to the field of fungal disease. These are the 16 people who are working together and trying to build up this particular science so that in case of India, we come to know about the different educational activities which can be done in this, epidemiological studies which we are planning to do. Of course, any diagnostic test, we generally try to do the validation across our network. And in case of the clinical study, there are multiple clinical studies we have planned and did also published. So from FISF, these are the certain contribution which we have made. Though we know this contribution is minuscule to the area which really we need. India is a huge country in that sense. So if you see the activities which have been done over the years, several master classes has been done and several smaller meetings, regional meeting, and also industry-sponsored CMEs have been covered. A lot of international people had come who are the experts in the field, and these people came on their own money. Really, we didn't have that money to sponsor in that sense, but the thing is that they love for our society, which is really dedicated and trying to do some educational activity. So they have come in multiple things. You can see these are the different training course which we have conducted. One of these, of course, which we are going to have in Kottayam from today. And you see that in case if you go into our website, there is also 16 module lectures are there. You can easily in these module lectures can go through this particular subject, and at the end of this there is some exam is also there. If you can complete it and get 50%, then you get a certificate in this program. You see that in case of the research, multiple research activities we have done. 2 ongoing studies Dr. Atul Patel is conducting, especially in case of crypto, and this is very important studies. Future research, multiple in our pipeline, several things which we have been thinking that it would be important in case of Indian perspective. You know that during COVID time, there was a big outbreak happened during mucormycosis, and this particular outbreak, Fungal Infection Study Forum played very important role in this aspect. You can see there are newsletters which are regularly published, and these newsletters are mainly educational newsletter. Generally, we publish it along with particular conference. Like this time when we have this critical care conference in Kochi, we published the newsletters which have been circulated, which is relevant to that particular discipline. Like suppose transplant group, when they have the meeting, we usually publish newsletter relevant to the transplant infection group. This is the website. You can go to the website, can try to learn more. You can see all our lectures mostly are in the PDF format. You can get into the website, and these are the different lectures which you can download for your own consumption or studies in this particular field. We are running a registry. That this registry is basically in case of the mold infection and also the rare fungal infection. We are not keeping the registry for yeast because yeast is so many, it's very difficult. But the thing is that if you can submit any of your case, and you are compensated with 2,000 rupees per case in this. So please go into our registry, that's still active, and this is very important registry in case of India. We are going to hold next international conference in 2026. That would be in case of Chandigarh, March 27 to 29. You can book the date from now onwards so that you can have the attending this particular meeting, where we have many international people who generally attend this conference. So you are all welcome to join us in our place to reduce morbidity and mortality of fungal infection in India. With this, now I wish to go to my presentation in case of epidemiology. If you have any question regarding this fungal infection study forum, please, we'll be having during tea time or any time where you can interact with any of these people who are sitting in front. These are the people in case of this study forum who are working. You can learn about it more. Let me go straight to the topic: epidemiology of fungal infection in India with special stress in critically ill patient, because Dr. Jacob wanted more of the critical care group to be aware of this fungal infection. So we thought that this topic can be more stress into the area of critical care group. Friends, these fungi generally are not enemy to us. You see, this organism feeds you, heals you, and reveals secrets of universe, because fungus is eukaryote. I hope you know the cell structure. One is prokaryote, another is eukaryote. We all human are eukaryote, animal eukaryote, plant eukaryote. fungus is also eukaryote. And fungus is the simplest eukaryote. So from the fungus, we came to know lot things which we are now extrapolating in case of human. So whether it is in food production, bioremediation, in case of drug production, in case of many industrial technologies, these are relevant in case of the fungi. So fungi is not our enemy, but what happened since 1980s, there is some change which had come, especially with the entry of the AIDS, transplantation and immune suppression. Suddenly we found rapidly there is a formidable change in the field of fungal disease, growing number of cases, new species causing human infection, outbreaks, epidemic, and also it had become a very important public health importance. But at the same time, there are some difficulties which we faced in this. Not only there is an emergence of fungal disease, it is difficult to suspect and diagnose. Very difficult in case of fungal sepsis and bacterial sepsis to differentiate. Antifungal resistance, which was not knowing about few years back, suddenly started appearing. And in case of fungi, another major issue which we are facing is the stewardship issue. You know, many international studies have been showing that nearly 50% cases what we are practicing or giving to the patient are not appropriate. That means a big stewardship issue is there or important in case of fungal disease, and there is high mortality. You know, this is the paper last year published in Lancet Infectious Disease. Dr. David Denning had tried to project what is the magnitude of the problem of fungal disease across this country and across this world. And it had shown that 6.5 million fungal infection which happens every year, invasive fungal disease. And nearly 50% they die of this. Whether it is in case of the social media, Scientific American, National Geographic, even those magazines are saying that fungal infection is spreading. So we cannot neglect this fungal infection at present. We need to take care of it. We are facing certain more important issue in case of our own country. First is that the overcapacity patient load. Especially if you go to the public sector hospitals, you all know what is the situation in case of the emergency. It might be 150 beds, 500 patients are already admitted. So there is always some compromise, and compromise, especially in case of the infection control, if it is there, there is chance of having more fungal infection, especially like Candida auris now is a very important issue which I will discuss tomorrow. India is also the tropical environment. You all know that in your house, if you are keeping the bread outside for certain time, there is fungus which grows on your bread. So fungus is spreading throughout our environment. There is very high spore count which have been there. So this is a very important issue. Susceptible population wise, that Lancet recently has said that highest number of uncontrolled diabetes is in case of India. So friends, whether it is not only mucor and Candida auris, many fungi which are causing threat to in case of human. We try to see what is the magnitude of the total problem of fungal infection in our country. We saw that the incidence is very high. And when I tried to extrapolate our publication data, which had tried to estimate what is the fungal burden, with the world data that is published by Dr. David Denning last year, we found that India is contributing nearly 30% cases of Candidemia, 12% cases of invasive aspergillosis, and mucormycosis nearly 92%. So friends, there is a time now we have to get up and do something in this disease. I'm just giving one example. This is in case of your hematologic malignancy or in case of your this allogenic stem cell transplant group. Generally, we know that the infection rate worldwide showed to be around 10% in case of the AML. And when the same thing had been studied by from CMC Vellore leadership, Dr. I think Dr. George was the study, was that. Well, it had shown that, George had shown in multicentric study that India is having 34%. You see that proven group is 26.5 and probable group is 8.5. So 34% means 3 times than the world which is being there. Friends, another interesting aspect which I like to highlight before going into the defined fungal infection group, million of fungal species are there, but around 300 fungal species are causing human infection. What is the reason? The main reason is the temperature restriction. Our body temperature is 37. Fungi, they thrive at a lower temperature, 27. That's why if you see, more plant infections is because of fungi, because plant temperature is lower, then it is the insect. Human is not having so many fungal infections because of our temperature restriction. But what it had happened that human temperature, body temperature is slowly going down over many years. At the same time, fungi is adopting at a higher temperature. So the temperature difference which was there is going slowly off. And because of that, the triad which we know in case of the epidemiology, you see in case of the fungi are getting adapted to the higher temperature. So many new fungi which were not knowing producing infection in human are now found to be producing infection in human. Environment is also very important factor. Any hospital, I have not seen this particular hospital where there is some construction is going on. But any hospital you go, you will see there is some construction is going on. And the construction site we compromise there is not covered from the patient area. And because of that, whenever there is any construction, the infection rate of fungal infection is going up. In case of the host also, there are certain changes which had come. We used to know that the fungal infection occurs only in immunosuppressed host or neutropenic host. But now we are seeing, even in case of the patient staying in ICU, patient having got COPD, patient is having diabetes, they are also having this fungal infection. So these were the earlier vulnerable patient group, defined group in defined of this malignancy or hematologic malignancy which is there. But now, if we again see that David Dennings, this particular paper, you see this is, I think it would. Okay, what is I am trying to focus on this particular bird. This particular bird is of invasive aspergillosis. The main upper two quadrant, one is of ICU, another quadrant is COPD. Very small portion of the so-called immunosuppressed group, that is in case of your hematologic malignancy. That means you imagine that this non-neutropenic group, they are the much higher in incidence which is there. So invasive aspergillosis, you see, earlier we used to see only in case of the immunosuppressed patient. Now if you see, there are virus associated, especially respiratory virus, influenza, COVID, these are the one of the important issue which are found to be having pulmonary aspergillosis in there. Now you see that a lot of people are using immunobiologicals, especially the modulators which you are using. In case of checkpoint inhibitors which are being used, in all this you see the fungal infection is emerging in this group. And very interestingly, we have come to know, earlier we used to know that, okay, this is non-neutropenic, this is neutropenic, so there is immunosuppression, there is fungal infection. But now you know that the immunity, especially in the pathway, that signal transduction pathway that can be genetically mutated. And because of that, you see that these are the different fungal infection, IL-12 pathway, dimorphic fungal disease, NADPH oxidase pathway, there is the invasive mold infection which we are coming to know about it. So earlier, these are the doctors who used to bother about fungal infection, hematologist, AIDS physician, dermatologist, but now intensivist, pulmonologist, ID physician, Even the surgeon, you know that necrotizing fasciitis, one of the issue where we used to think it is a bacterial infection. By the time the surgeon realized that this is a fungi which is producing necrotizing fasciitis, already it is late. So these are the issues which we need to take care. Now, fungi is not put so seriously in case of public health, but it is very important. I have no time to go into the superficial fungal infection group because most of you are from the critical care or those areas where you deal with the invasive fungal infection. But what I like to stress, at least 1 billion people suffer from superficial fungal infection. One of the major issue nowadays is the drug resistance dermatophyte infection, that is terbinafine resistant. There is a new fungus which has come up and that is really spreading in case of India very rapidly. That is Trichophyton indotineae, which is being spreading in India. You see that million people, they lose their vision because of fungal keratitis. This isn't happening in case of the farmers. We are not able to identify this, diagnose this quickly, and that is a major issue. Women suffer from recurrent Candida vaginitis, and that's a really low self-esteem that is being causing. They don't go to the hospital for treating these cases. So these are the problem, and now we are also seeing that neglected tropical disease, there are certain fungal infections which have come into this picture, mycetoma, chromoblastomycosis and sporotrichosis. Now coming into this AIDS area, you know, in case of this is one area where in 2010 UNAIDS decided that within 3 years we'll have 0 death in case of the AIDS patient, because in antiretroviral therapy is really changing the game in case of HIV. But only there is reduction of 15%. 85% not reduced because of two things. One is fungus, another is the TB. TB and fungi are the very important factor. One of these fungi is the histoplasmosis. You know, histoplasma, we used to think that it is the north part of India which is having this along the Ganga river or Jamuna river. But now, like Dr. Atul had shown, that in case of the Rajasthan, in case of the Gujarat, so many cases have been reported. And I would say that it is being throughout our country, histoplasmosis there. It mainly depends on whether you try to identify it or not. And in India, especially in immunocompetent host, quite number of cases, they present with adrenal tumor. Without knowledge, clinician think it is adrenal tumor, they remove both of the adrenal. And then it found histoplasmosis. Now imagine for that particular person, young guy, he has to have throughout life without this adrenal and he has to be given the therapy. If it had been diagnosed or thought about, you could not have removed the adrenal, you just treat the histoplasma which can be there. In case of blastro also, there is very rare India infection. It's not being so common, but now there is another species has come up in blastro, especially in US, that is the Blastomyces helicus, which is being there. You know, emargomycosis, this is another fungal disease. This is emerging. It started from South Africa amongst the HIV patient, and now it has been found in case of the India. You see, this is in case of the HIV again, we found that this is Emargomyces pasteuriana, one of the fungus which is producing. Talormycosis, which used to be called as penicilliosis. Now this talormycosis is quite common in northeast part of our country. So these are the certain dimorphic group of fungal infection which are common. Cryptococcosis, I would say that in case of crypto, after Africa or the sub-Saharan Africa, it is the Asia where it is important. Now, Dr. Atul is conducting 2 studies, one in case of the within HIV, another is non-HIV group. What are the crypto presentation? Because crypto management is becoming difficult. Though we have very good drugs and very good recommendation is there, but certain patients suddenly die. And these are the areas which we need to explore what might be the reason. Amongst the 3 opportunist group, I would say that these are the 3 main fungal infections which we do see. One is of course the invasive candidiasis, then the invasive aspergillosis and mucormycosis. And especially in case of candida, what is happening is that it's colonizing our human body. Now with the drugs which we are using, they are the drug-resistant candida which are colonizing us. This was a paper which we published way back in 2015, and this particular study was almost 15 years back conducted this study almost. This particular study, 27 ICU, where we had shown that there is a completely or distinct epidemiology in case of India. Young patient with less morbidity acquired the infection much early. And this is so important because the intervention in case of ICU had to be very early, because within 8 days they acquired the infection, whereas if you go to the international data, you will see 23 days on an average. So there is a big gap which was there. And it's not the 5 candida species, rather 31 candida species which were producing the infection. Very recently, the data is yet to be published. Dr. Shiva Prakash has conducted this particular study across 22 ICU in this country. This time first he had done the study of case versus control, and case control analysis showed that the risk factor wise we have got this similar. There is not much change. But what is the big change had shown that earlier we used to have Candida tropicalis as the commonest one. Second was Candida albicans, but it has been completely replaced by Candida auris. I heard that you don't have so many cases of Candida auris, but it is there in Kerala. Kerala is one of the very ideal situation where infection control is much better compared to the whole of the country. So here I would say that Candida auris you are preventing. Tomorrow I will discuss about it. That's very important area where we need to understand the polemics which is happening in case of Candida auris. You see that it's not only Candida albicans, tropicalis, all this. There are so many rare species which are producing now the outbreaks, and these outbreaks is so difficult to understand because lab had to identify it quickly. Otherwise, you will not able to see or know how the infection is spreading. Because of that, whenever any outbreak happened in India, it happened in large number of people, because by that time you really realize it has spread across the hospital in many of the center, many of the wards which have been there. So there is a problem in not knowing the epidemiology of this. Second is identification is a problem. Third thing, in case of the therapy, what drug to be given, we don't know about it. If you do susceptibility, you cannot interpret the data without breakpoint. We don't know the breakpoint in these cases. And if you see another important things, because of these rare yeast which are coming up, though we generally say that if it is blood having yeast, hit immediately with echinocandid. Friends, we have published from Asia multi-center data, nearly 9% of the cases are not Candida. These are the different, like it can be crypto, it can be geotrichum, it can be trichosporon, many of those yeast which are not susceptible to echinocandid. So in those cases, possibly we have to go for liposomal amphotericin B. So this particular knowledge is so much important in case of this yeast. And that's why we need to just not only knowing that there is yeast in the blood, we need to know whether it is Candida or non-Candida that is there. Next, coming into the mold infection, this is again I would say Dr. Shiva Prakash conducted in PGI and had shown that in our ICU nearly 100 CFU or 100 colony forming unit of spores are being present in 1 cubic feet of air. We generally say that if it is more than 25, even a healthy individual can acquire infection. And this is nearly 4 times. And don't think PGI is the worst hospital. Across India, most of the hospitals have got the similar situation. What happens? We have got central air condition. And this central air condition where this particular mold, they thrive. And we don't have the HEPA filter at the end. Because of that, the air which is coming inside the ICU or any area is having high spore. And whenever you ask for the management to clean this air conditioned duct. At least in PGI, I tried and convinced my director once, and he did the cleaning of it. And after next year, when I asked him to do it again, he said, just it had been done last year. And last year you spent almost 50 lakhs rupees for cleaning. Now you are asking again this year. So you see, this is the problem in case of the management. They don't understand this issue. That's why when I showed you that in case of the AML, Biju George had shown that 3 times infection rate. This happened because our induction chemotherapy, when we are doing in a AML patient, it is being done in non-HEPA filtered room. So there the infection chance are getting high and high. So these are the way. Another interesting part here again with the diagnosis becomes important. Like suppose in case of your neutropenic patient, when the fungus enters the lung, it enters the blood vessel quickly. That's why we see this halo sign, air crescent sign, all those signs can be seen. But in case of the ICU patients, COPD patient, there is nothing, they don't enter the blood vessel because neutrophil is there to protect it. But then they enter in the tissue, first in the alveoli, then they enter the tissue. So they produce different types of non-specific sign. So when we go for diagnosis, Dr. Shiva Prakash will discuss the diagnosis next. There you have to think about if there is any new shadow had come in the imaging of the lung, that is very important. We also conducted a multicentric study in case of our ICU in India, and it had shown that the infection rate or mold infection rate is high. Not only that, one important lesson which we learned from that particular study is that yes, Aspergillus is the highest infection rate of 75%, but one quarter is mucormycosis. And that is not in anywhere we do see such type of situation. This is in case of India. We see mucormycosis very high. Second important thing what we have seen is that it's not the A fumigatus only, A flavus, Aspergillus flavus, which is quite resistant to amphotericin, that is equally being isolated in case of India. This is a study which we had done a meta-analysis in case of the cirrhosis patient, where we have shown around 10% cases where there is invasive fungal infection is there. In COPD, similarly 1.3 to 3.9. And this is also one interesting study we did of fungal sinusitis. And this is a very common infection which we have seen in North, but now it is being seen across India being present. And what it happens, especially it is in the community. What it happens is that we have seen in case of the Punjab, the farmers, they usually after wheat, just now wheat harvesting has been there, and they thresh the wheat to take out this wheat from the straw, and during this port count goes high, and because of this usually the people around they acquire this infection. We found 1.4% young adults suffer from chronic rhinosinusitis and 8% of them is fungal rhinosinusitis. You know, this particular respiratory virus associated respiratory infection, especially aspergillosis, it has shown that there are two types. One is in case of influenza, another is in case of COVID. There is a distinct important difference was there. In case of influenza, quite a high number, they enter the blood vessel. Because it is entering the blood vessel, your serum galactomannan can be positive. But in case of the COVID, there was not serum galactomannan is not positive. And this difference is so important because during COVID time, people are not getting samples from the respiratory tract. And the imaging was not helping. So ultimately, this 28 group of experts, they met together. They said that enough is enough. We have to have now, in case of COVID, we can take our protection and collect the respiratory sample. Otherwise, we will not be able to confidently diagnose COVID-associated pulmonary aspergillosis. So friends, this aspergillus is a very interesting fungus. In one end, in case of invasion, which occurs especially in immunosuppressed, in another end, they produce allergic disease. And you see that this is a study which we had conducted again from PGI. This is first time in community. It had shown that in case of the community amongst the asthma, around 6% has got this allergic bronchopulmonary aspergillosis. Another important factor is the in case of chronic pulmonary aspergillosis. You know, post-tuberculosis. Patient had gone home after treatment well. After 6 months, when the patient come back with the similar symptoms, what do you think? We start thinking it is a drug-resistant TB which was there, or it is a new infection which had come up. We do the gene expert. If gene expert comes negative, even then you start second-line anti-tubercular therapy. 20% of them now found to be having aspergillus, which is small cavity which is being produced because of TB. There they get colonized. And chronic pulmonary aspergillosis is highest in case of the world incidence in case of India. Drug resistance aspergillus. You know, this is a big problem in case of Europe. Luckily, we don't have such a serious problem till now in case of India. But what is there? Our problem is about the aspergillus flavors, where there is amphotericin B resistance which have been found. This is a very interesting data which have been published from the Mycology Reference Laboratory UK, where you can see that the way of the resistance increasing in case of Aspergillus fumigatus. You see that this is whether it is in case of Vori, Itra, Posa, any of these drugs, this resistance is coming up. Next, life is getting complicated and complicated and complicated. You see, this is a cryptic species has come up. And this cryptic species have been found in Aspergillus around 10% of the cases. And you see the resistance, red are the resistance. So whether we need to only identify Aspergillus, whether we only identify Aspergillus fumigatus, or we have to go to identify the cryptic species. That is now the question, because 10% is not a small number. And 10% where there can be a cryptic species and which might be resistant. Aspergillus lentulus, resistant to amphotericin. So this is a big problem which have been there till now in case of this. Lastly, what I like to speak about mucor. Mucor is our really a very important challenge. It is shown that worldwide, compared to the rest of the world, India has 70 times of this particular mucormycosis. The reason is uncontrolled diabetes is overshadowing all other risk factors. We love so much sweets. Anybody has been diagnosed of hypertension, he had to take throughout life drug. He is not depressed, but you diagnose anybody as a diabetic, he is so depressed. Even a doctor, they don't control their blood sugar well. And because of this, there is a big issue of uncontrolled diabetes which is being there. And there is the mucor which is being big factor in there. Many new mucorales have been found to be in case of India. And you see there are certain group of infection which we are not very clear. One is the isolated renal mucormycosis. Though case numbers are not so high, but young persons suddenly had fever, flank pain, hematuria, anuria, and you see this image-wise, there is this type of shadow which is being there. Their kidney has been infected, and this is a big problem in case of certain group of patients. Now, in case of the COVID time, I am not very sure how many cases you have seen of mucor, but this is one interesting study which we had conducted during that period of time. First thing is that there was a tsunami of cases of mucor which happened. Have you anybody have heard that within 1.5 months there is nearly 50,000 cases have been reported on the portal of the government, which that time they have made it as a notifiable disease. And the same portal is mentioning that the infection rate would be much higher because a lot of people are not reporting those cases into the portal. And during this myriad hypothesis, myriad means I am saying you so many number of ideas came from the people. People said it is the industrial oxygen which is the main responsible. Some said it is the humidifier water which is being contaminated. So many factors have been said about it. But we had conducted many of these studies to resolve what was the reason. First thing, what happened during this second wave when it came? There were so many patients. Doctors were seeing this patient not only in the ward, they were seeing in the corridor of the hospital, even on the pavement, the patients were there. And because of that, they had no time to control the comorbidity. Any patient who is having diabetes, it's not being controlled. And more on top of that, when there was oxygen crisis, they increased the steroid dose. Instead of 4 or 5 or 7 milligram Dexa, they had given 30 milligram Dexa, which is nearly 200 milligram prednisolone. It's not for 5 to 10 days. They have given for nearly month together. And because of this, blood sugar has gone through roof. Some of them have got blood sugar more than 1,000. And when we did this study of large number group of patient as well as the control, nearly 1,700 patients and nearly 4,000 control, which had shown that the diabetes and steroid were the main risk factors. Of course, zinc supplementation had been found one of the other risk factors which has been there. We tried to look into every center, multicentric study wise, we tried to look into the environment, whether it is the oxygen cylinder or it is the humidifier water. Nowhere we found that is been contaminated with mucor. But what we found is the AC vent, air conditioned vent was contaminated. But then people asked us, look, patients were treated treated at home, they acquired the infection, and mucor, after getting mucor, they are coming. So if your theory of hospital having got mucor is not only factor, you have to look into the home environment as well. So then we had gone into the 25 house where the people were first being treated for COVID at home, but acquired mucor and came to the hospital. And what we found that there is also in the bedroom very high spore count. And we really did the molecular study to correlate the isolate from the patient and isolate from the environment. There was a perfect match which have been there. Even what we have seen that when we try to look into what is COVID is trying to play, this is a big study. I am not going into this, but this transcriptome data had shown that this COVID virus was really altering the coagulation pathway, and that particular factor became important. So you see, in case of this triad, uncontrolled and poorly controlled diabetes, environment, and also the COVID, all three factors were important for producing this particular outbreak. So friend, you may think of mucormycosis when there is presence of severe sinusitis Escher, fever, worsening cough, brown or black sputum, chest pain, hemoptysis, patient is on voriconazole or echinocandin, acute or aggressive vascular event, repeated absence of galactomannan and beta-D-glucan. And in case of imaging, you can have this type of shadows. Friends, there are also certain new fungi which are emerging. One of them is the Cladophila bantiana. I am not very sure how many of you have seen these cases. Both these two fellows who are sitting in front of me, that are Rajiv Suman and that are Atul Patel, they have seen so many cases of this Cladophila brain abscess. And this is the not immunosuppressed, immunocompetent host suddenly have this problem of brain abscess which have been there. So this emergence of this rare mold which is quite common in case of India. So friends, summarizing, I know I have taken 5-10 minutes more time going slowly, but what is important is that there is a rising threat of fungal infection across the globe. The COVID-associated mucormycosis outbreak has given us good lesson. Invasive aspergillosis in new host population and F. flavus is in India, which is important. Post-tuberculosis, chronic pulmonary aspergillosis is very important factor. Non-aspergillus mold and cryptic species is also very important. So we need many things. We need population at risk where there is a global or local epidemiology study. In case of resistance, we need to know how the resistance is emerging, what is the test which can rapidly say about it. Is there any geographical shift in emergence of new fungal infection that need to be done? And we need finally a lot of research in case of diagnosis. You cannot say that in case of fungal infection we are really competent. 50% of the patients, they are diagnosed only in autopsy, never thought and found to be having infection in antemortem condition. So our diagnosis need to improve, which now Dr. Shivaprakash is going to discuss about it. And also I said that there is a need of an antifungal stewardship program. As I am not saying of India, I am saying world best center where it had been studied, shown that inappropriate therapy is around 50%. 50% is very high in number. So we need stewardship separately in case of fungal infection really. Thank you for your kind attention. Any question, quick or otherwise, we have enough time for discussing, because this would be in workshop pattern where we'll go in our subsequent classes. I think you can go to the next one.
Thank you, sir, for your valuable information. It is my privilege to introduce our next esteemed speaker, Dr. Shivaprakash Rudramurthy, Professor in Medical Mycology at PGMR, Chandigarh. Dr. Rudramurthy is a distinguished expert in the field, having served as the President of the Indian Society of Medical Mycologists and as Vice President of the International Society for the Human and Animal Mycology. He is a Fellow of the European Confederation of Medical Mycology and a core member of the Fungal Infections Study Forum. His academic contributions include founding membership in the Indian Academy of Tropical Parasitology and editorial responsibilities such as the Journal of Medical Mycology and Frontiers in Fungal Biology. Today, he will be sharing his insight on diagnosis of invasive fungal infections. Please join me in extending a warm welcome to Dr. Shivaprakash Rudramurthy, sir.
So good morning to you all. Is it on? Okay. Good morning to you all. So I've been asked to talk on a diagnosis of the invasive fungal infection. So actually I'm not talking about all the clinical diagnosis or radiological and other things. So I'll restrict my talk to the as a mycologist only for the laboratory diagnosis of fungal infections, invasive fungal infections. So you all know that standard approaches for the laboratory diagnosis includes direct microscopic examination, recovery of fungi in cultures, and also histological diagnosis. This is the standard approach, and just little bit for the help of the microbiologist and also for the clinician for efficient diagnosis of invasive fungal infection. I will talk some basics points. So specimen collection is one of the very important thing. So you need to understand that if you give a good culture, the specimen, in the specimen you have to give the good amount of the specimen, and also when you send the specimen, so you also have to provide with the clinician, especially I am telling the data on the clinical data, little bit clinical data, because fungus you all know that it is an opportunistic as well as it is an pathogenic. So the same thing which is there in the environment can cause. So colonization also can be there. So if you send just it is a pus, from where it is the pus can be from the deep tissues, it can be from the deep sterile within the organ, or pus can be superficial. So this information you have to provide to the microbiologist to get a good diagnosis. So for the microbiologist, actually they will do many of the preclinical treatment when you want to efficiently identify the fungi or culture the fungus. So they do for many specimens. So for example, body fluids, if you are giving ascitic fluid, pleural fluid, and all this one, so you have to try to provide as much as quantity as it is there. So when it comes to the microbiology lab, the pre-treatment actually microbiologist has to do the centrifugation. If you do just directly, if you inoculate the sample, provided the amount of fungus that will be present will be low. So if you centrifuge it and use the deposit to culture, then the efficiency will be much higher. In the laboratory also, in the microbiologist, you have to see that when you want to process the specimens, so for example tissues, when it is there, you need to understand whether you have to grind the tissues or whether you have to just mince it, especially for the histoplasma and all. If you grind it thoroughly, so you will get isolation properly. For example, in case of mucormycosis, you should not grind it and you should only split it. So direct macroscopic examination is one of an important one and a rapid method also. So by just doing a direct method examination, you can say that within few minutes at least you can come to some conclusion. So that's why immediately our senior resident, after the direct microscopy, they convey the direct microscopic features with the clinicians so that it will help to initiate the appropriate management, at least they can come to some conclusion that this could be an mucormycosis or a aspergillosis or cryptococcus or candida. So you can see there are many methods are there. So if you can if you can utilize this calcofluor along with the potassium hydroxide for doing a direct microscopy, so it can really help you a lot, and it is really very sensitive. So for example, calcofluor if you use, so if I see the direct only KOH, so then I may miss in the deep, because the tissues and all it will take some time to digest. Immediately you cannot provide the report, so you have to wait for some more time. If you add a calcofluor, so within the depth of the tissues, if it is there, that also it can be picked. So it will be rapid as well as a very sensitive technique if you use. India ink, you all know that it is very good. Methylene blue, toluidine blue for PCP can be used, and different morphological forms will be there, so through which we can appreciate that which fungus it is. We can come to some conclusion that which group of fungus it belongs to. For example, Hyalin septate typhae, most of your Aspergillus, Schistosporium, Fusarium, they all produce hyalin septate typhae, and also Demeticious fungus. So Demeticious, it will produce many of the time within the tissue. You can notice the Demeticious, means you can brown pigment can be noticed in it. So and also sometimes for phaeophyomycosis, we call it as phaeophyomycosis if it is caused by this Demeticious fungi or phaeoid fungi, because the management of hyalin fungi, and there is a lot of difference between the management procedure which antifungal you choose for the treatment. So it will also produce a rounded bodies like thing, so that also will help you. And yeast forms, so for example, yeast forms can be directly budding yeast or round yeast, or you can see pseudohyphae without pseudohyphae. For example, Candida glabrata, you don't see an pseudohyphae. Candida auris, you don't see an pseudohyphae. And then elongated, rounded spherical cells, so that if you see a spherical yeast, you consider it should be an Cryptococcus. So these are the different clues, by using these morphological forms you can identify. So these are some pictures. So you can see that if you are using this calcofluor examination, so you can clearly visible the septate hyphae as well as aseptate, you can differentiate. And also here you can see that in case of PCP also you can pneumocystis, you can diagnosis by using the calcofluor also. And these are all India ink method or nigrosins. So fungal structure, again as I said, by using the already I have discussed most of these features. So how you can come to conclusion that it could be this particular fungus. So culture medias, I am not going into detail, but just we can to know that, so you have to use the media whenever you are specimen, when you are using the isolation from the specimen. So any fungus that is present in the specimen should be able to grow in the media you are using. So most of the time it will be the SDA. So why now we are using this Emmons modification of SDA. It is at a neutral temperature, neutral pH, and also glucose concentration has been reduced. And also you have many other media such as Sabi agar. So Sabi agar, and also you can use this antibiotics to suppress the antibiotics, antibacterials, as well as sometimes we use this cycloheximide in order to prevent this opportunistic fungi, especially for the dermatophytes, and sometimes in case of an dimorphic fungus which is resistant to cycloheximide, it will grow very well, especially when you are using the sample which is contaminated, which is not a sterile sample. At those situations, if you use cycloheximide, if you suspect this dimorphic fungus, then the chances of amplification will be better. So for blood culture, mostly we do it for Candidemia, or if you suspect sepsis due to Candida or other yeast. Blood culture wise, we do know that nowadays, earlier I don't think that people are using the conventional blood culture. Most of them are using now automated blood culture. There are different platform. So this platform, even by using a large number of platform that's available, so you can see that the sensitivity is still not going up to 50 to 60%. So maybe maximum to the efficient will be 70%. Still you will be missing about 30% of the cases in case of blood culture. Other some of issues with the conventional diagnosis of the blood culture include conventional diagnosis mainly include diagnosis of Candida pneumonia. For example, that's a really very, very rare case. You all should know that only you can diagnose Candida pneumonia not by isolating the Candida or seeing the Candida in the sputum or ball. We do not report these balls and Candida if we see in sputum or ball. So you need to have an histopathological demonstration of Candida, even in a very highly or when the patient neutropenic, when the patient is highly neutropenic and his neutrophil count is 0, even in those situations. So you need to interpret properly about the Candida when you isolate from these respiratory specimens. Candida isolation from peritoneal fluid. Okay, it is still controversy. So many of the time we know that acute necrotizing pancreatitis in our this one about a patient who comes directly, about 8% of these patients are due to Candida. So whether it is significant, sometimes you will have the lines, pigtail drainage and other thing. So when it is significant, only when it is less than 24 hours you should consider this it is insignificant. If it is more than 24 hours, it signifies that it could be an colonization not involved with the infection. So these all the urine, again you will have to think when you are reporting Candida from the urine, it will be generally a colonizer, not a this one. So many molds and dimorphic fungus take a longer time to grow, that is an issue. And so nowadays the development in the diagnosis is especially in case of an Malditov. Everybody might have heard about Malditov, but the Malditov we know that it can do the identification rapidly. That is the only thing. So you don't think that directly from the clinical samples you can subject the sample in the Malditov and can identify. So only when you have an isolate culture, then Malditov will help you, especially in case of, but in case of blood cultures, when you have already done, when the automated blood cultures, when there is a signal from there, sometime if you do directly from that sample, if you take, so it is already amplified, Candida has grown, then you can identify the this one in about 70% of those cases correctly. So there are many applications of Malditov in the diagnosis. So we do have lot number of this one. So here, what do you want to do? Conventional diagnosis, we do have a lot of problem and issues. So we have to go further. What we want to do is, especially when the patient is have a biological infection at the earlier point, so we have to diagnose the thing. So most of the time conventional diagnosis, when the patient is having a severe infection or when it is disseminated, then only we get positivity. For example, if you want this histopathology will be positive if the organism burden is more than 10 to the power of 3 per ml. So that's why that will be very high burden. So the patient will be in advanced stage. So we do need to identify the diagnose the cases as early as possible. So that now we do, so that we can give a targeted prophylaxis and preemptive therapy. So we do have many biomarkers tests are available nowadays for the diagnosis, including this one. So what are the main targets that's used for the diagnosis? So we do have this is the cell wall of this one fungus. So you can see that cell membrane and cell wall, most of the thing will have this cell wall antigens will detect. So it can be either 1,3 beta D glucan or mannan or galactomannan, and also molecular based DNA based molecular diagnosis has been improving and it is helping us in the diagnosis. So cryptococcal antigen detection, you know that it is one of the best tests that is available. So and sensitivity and specificity is very, very good. So capsular antigen is the one which will help. But nowadays we are seeing cryptococcus many other species. So it will have less number. For example, cryptococcus gattii. So decagatti, which has gotten very less capsule, you may miss those cases. So in those situations, this latex agglutination may be of some less useful. So nowadays this lateral flow assays have been developed. So this is very simple and very equally sensitive and specific like a latex agglutination test, and you can use this semi-quantitative test especially for the diagnosis of Candida, and also it also will help. It also will help you to in picking up this Candida, the cryptococcal gattii infections. So cryptococcus the diagnosis not only in the CSF serum cryptococcal antigen detection can also help, and you can see that in patients who are an highly susceptible or who have an high risk, for example HIV patients. So in them actually screening also will be useful, beneficial. So even the patient may not be having symptomatic, like for example headache and features of cryptococcal meningitis may not be there. If you screen them by using this latex or this lateral flow assay, so you can pick some of the cases, and if you treat, the mortality also can be reduced. So next, coming to 1,3 beta D glucan assay. So this is an beta D glucan, this is an kinetic ELISA assay, and this is one of the very highly sensitive. This is the different pathway, just like an endotoxin detection test. So you do have Fungitel is the one which is most commonly or FDA approved kit that is available. So nowadays we do have many other kits are also available. So you should understand the cutoff value when you are interpreting. So if you are sending the beta D glucan, you should ask them which one, because nowadays many of the Chinese kits are also available for the diagnosis. So if they do not use Fungitel standard one. So you have to ask them whether which kit has been used, and you have to interpret the values accordingly. So beta D glucan test also we do have some of an false positives. So especially when you are using the patient when they have a contact with the sponges and gauzes, and hemodialysis patients, cellulose containing filters, immunoglobulins, and also some of the antibiotic commonly used like amoxicillic alvinic acid and piperacin tazobactam also can use false positive region. And also many of the time false negative results also can be encountered, especially when you have patient is on antifungal treatment for prophylaxis or empirical. So nowadays we do have, you know, that Fungitel is a batch test and it is a very expensive one. You cannot do it one or two samples if it is there. So that's why the same company, they have come up with a Fungitel stat. So Fungitel stat, even if you have a one sample, so you can give the report immediately. So but the cutoff values that they have, when they have compared it to standard Fungitel one, you can see that if more than 80 is in for Candidemia, you can consider more than 80 is an positive one, 80 picogram, but here it is more than 1.2, which correspond to as a more than 80. And also we do have the another kit nowadays available, Fuji Vaco Beta D glucan assay. Again the principle is the same thing, but when we try to evaluate this, you can see that really it has a very good comparable with that of an Fungitel assay. The advantage of using this Fujifilm Vaco assay is it is a little bit cheaper than the main Fungitel, and also you can use it the batching wise also you will not lose. If you have 4 samples also you can run the sample. So that is an advantage over the Fungitel. In Fungitel generally we will wait for up to 21 tests, otherwise we will have to waste a large number as in control. 4 controls will be using, so 4 test price you will be losing. So both in case of invasive aspergillosis and invasive candidiasis, this particular test Vaco Fujifilm has performed really very well. So other diagnostic markers, Mannan and anti-Mannan. So these are all commercially available thing. So Mannan is again present in an candida like galactomannan in aspergillus. So Mannan detection will be very useful, especially when it is an immunogenic also. It will produce an antibody. So both Mannan antibody as well as anti-Mannan antibody as well as antigen detection will help in the diagnosis. So if we do combination, generally it will benefit. So you can see the performance in case of ICU setting also, it will be around 55% sensitivity and 60% specific. So most of the time if you use a single value, it may not be of much is one, just especially you have to demonstrate the increase in the value, because patient colonization if they have also, they may have this antigen as well as an antibody. So this is an CAGT8. This is germ tube Candida albicans germ tube assay. Again, these particular kit actually Spanish groups are working, but in India till now it has not been widely used, and some of the European countries they use this particular kit. And again, the sensitivity and susceptibility is almost like Mannan antigen and antibody detection test. But you should they only they also say that you should use always this test in combination with beta D glucan or Mannan and antigen antibody detection test. So next is galactomannan assay. Galactomannan, again, it is a very important part of that's this one component of the cell wall that is present in Aspergillus, Fusarium, as well as in the case of Histoplasma. And detection of this galactomannan in BAL and CSF will be helpful in the diagnosis. So this is very specific. Galactomannan is released into the circulation only when there is an invasion. So if it is patients are colonized, it may not be this galactomannan will not be seen in an secretions. But if the patient is having an invasive disease, then only it will produce. So it has been, that's why used as a more specific in the diagnosis. And we do have a very good ELISA detection technique for the diagnosis, and the sensitivity is up to 1 nanogram. So that's how. And again, galactomannan platelia is the one which is FDA approved, and nowadays we do have, and that's a batch test. Now we do also have this single detection test, galactomannan AG varicella mono test. So even if you have a single sample, you can do the galactomannan detection test. So galactomannan detection, especially in the serum and the ball, it will help. If you are diagnosing pulmonary aspergillosis, then testing the ball will have more value than comparing with the serum. So it is also, as I said, that is present both not only in Aspergillus, in Histoplasma as well as Fusarium, and as an high specificity. But the negative results does not exclude the invasive aspergillosis. So that's why what you have to do is regular monitoring is required. So in a very high risk patients, such as neutropenic patients, hematological stem cell transplant patients, so those patients actually you have to regularly. So sometimes when they are in the initial phase of an immunosuppression, so at least twice in a week they have to be screened for the galactomannan antigen to pick the disease early. So again, false positivities are many. Lack of elimination, especially in the food, galactomannan can be there. So if you have any problem, chemotherapy, if you are taking at that time through percolation through the food, this galactomannan can go inside and they can be given positive. And also antibiotics, they say, but nowadays the batch what they are getting giving this galactomannan detection kits. So earlier we used to see a lot of this one cross reactivity or false positivity with amoxicillin and clavulanic, but now they can claim that it has been reduced. So now galactomannan also we do have an lateral flow assay nowadays. So lateral flow assay, again they have a sensitivity of about very good sensitivity, 96 to 98% specificity. So at 0.5 cutoff, galactomannan result actually we say in terms of an cutoff 0.5. So more than 0.5 we take it as an significant. So in the serum as well as in the ball also, this percentage or the performance is really very good, high sensitivity and specificity in all the group of patients. So you can see that even in case of an ICU patients, they just got very good sensitivity, at least 1.5 if you use 73% sensitivity and 83% specificity. So lateral flow devices, again this is another device that is available, and this one will not detect an galactomannan, but it detects an glucoprotein. Again it is having a very good specificity at least. So though the sensitivity it is a variable, so it is an point of care test and very simple. Within few minutes you don't have to have any specific machines, but only thing, very small reader they provide along with this, and if you use that reader, so then you can clearly give the results. So these are the different tests, that the sensitivity and specificity, especially when you do it in the ball as well as in the serum. So in hematological malignancy, ICUs, solid organ transplant, so everywhere the sensitivity and specificity of this LFD is good. Even in case of an ICU settings, they say that sensitivity of 75% and specificity of 85% is really very good. And also next thing is LD bio aspergillus. So this one also, when we try, this one will detect an aspergillus specific IgG and IgM. So when we try to evaluate, especially this one will be used for the diagnosis of IgG, means antibody detection may not be of much beneficial in invasive aspergillosis. But in case of chronic pulmonary aspergillosis, detection of this is one of an criteria for the diagnosis of chronic CPA, chronic pulmonary aspergillosis. So both IgG as well as IgA. So when we try to use this particular kit, LD Bio, earlier we used to do the serum precipitin by using an immunodiffusion, but now the kits are available. So this LD Bio kit has done in very good performance as provided. So last coming to as this galactomannan and beta D glucan. So how to interpret the values? For example, we do have an criteria for UORTC criteria as well as ECIL criteria. So in ECIL criteria, that's especially in a neutropenic patients, they say that so they can have this A2 this one recommendation for BAL in neutropenic as well as in non-neutropenic patient. So A2 in serum or plasma in case of neutropenic, B2 in non-neutropenic, and also 2 consecutive positives in the blood if it is more than 0.5 and more than 0.1 in case of BAL sample. CSF and BAL more than 5 is an 0.5 is an adjunctive. Again, recommendation is A2. So coming to EORTC MSG, again for BAL sample, you can see that these are the three different things. One of the things should be positive. If you are using a single value from the serum or the plasma, it should be of more than 1.0. So for BAL fluid, again more than 1.0. So single serum or plasma. So if you have both this one of 0.7 and BAL if you there along with that, so it should be more than 0.8. For CSF it is 1.0. So for fungital assay, so it is generally 80 picogram is considered as a positive, and less than between 60 and 80 is an intermediate zone, less than 60 is picogram is a negative test. So patients, when you want to do the test, so this is very important. When this test should be used only when you have an probability of an infection very high. For example, in stem cell transplant, pre-test probability, if it is very high, then the post-test probability also will be very high. If, for example, in case of corticosteroid therapy or a solid organ transplant like renal transplant, if you use this particular test for screening or diagnosis, so the probability, if it is less, than again false negativity or the post test probability will be very low. So the next thing is these are some of an newer things. So you can see that volatile components are also been this is in many respiratory diseases, especially for invasive aspergillosis. They have seen that when they try to look into it, so on the left side you can see that this is the patients without invasive aspergillosis and this is with aspergillosis. You can see some of the patients with aspergillosis, many volatile compounds specifically has been identified. So if you use these particular agents, especially in as a breath test, so it can help you in the diagnosis, but still these are all in an investigative phase, so we do not have much. So future with nowadays the technology how it is growing, maybe in future we may have this particular test. So for mucormycosis, really we do not have any biomarkers. So but still this is they are in a experimental phase, or still people are evaluating, but some progress have been made. So we can see that rhizospor specific antigen, especially they have identified in case of serum as well as lung, and in mice it has been shown to have a very good, it can be detected. And also recently against fucomannan they have used this monoclonal antibodies, and they have shown that it will help in the diagnosis of mucomannan. If you can, it will help in the detection of this fucomannan, these monoclonal antibodies. And also monoclonal antibodies against this RSA also have been identified. And also now recently we have identified one of an immunogenic protein in case of serum of the sample, both serum as well as a BAL. So and we have evaluated, and we can see that clearly when we did it for, we looked both for IgG and IgM. So when we did for when we did it for IgG, we can see that the 84% of the patient we could pick. So whereas IgM 69%. But here actually we did not look into the specific days, how many days after infection and other thing. But in general, when we try to combine both IgG as well as IgM, we can see that the sensitivity was we could detect up to about 94.9% of the patients. So this could be, we are now trying to identify the epitope and purifying it and try to bring up and make the test more specific for mucormycosis. So one of our students are still working on this particular thing. For histoplasma, we do have 2 commercial kits that is available. So for I can detect antigen both in case of serum, CSF, BAL as well as a urine. Whereas IMI one, this is Miravista MV, and the lower one is an IMI. So it is an both are ELISA based test, and in case of IMI detection or in the urine only, they say that especially in case of an disseminated histoplasmosis, if it is there, then you may get the positivity. So for example, cutaneous one and all, even our experience and literature, they say, so cutaneous only if you have a mucocutaneous aspergillosis one histoplasmosis, then this test may be negative and not that much at least sensitive. And this is one of the tests that you should remember, that many other antigens will cross react with this histoplasma antigen that you detect in the urine. So coming to the DNA based test, just to give you an idea what is going on in 5 minutes, just I will just to wind up because I don't want to talk much about the molecular based diagnosis. The major problem in molecular based diagnosis, DNA present in the serum, like in the serum, if you want to detect an aspergillosis just by taking a non-invasive sample like serum, then it will really be a very good test. So people are doing, there are different international groups, so like an isham as well as European group, they are working on aspergillus initiative, but they have still now still very few recommendation, and major problem is an extraction of the DNA. So because fungal cell wall is very hard, and even the DNA quantity within the serum and the samples will be very less, so it is an challenging. So you should have a very good method and highly sensitive method. For example, in case of T2 candida, it's a really very high, they used a nanotechnology, and they're diagnosing this candida. That's a very high test. So targets also there are different. So pan fungal targets we'll do, especially when we are doing clinical sample. So these are the commercial tests that is available for diagnosis of aspergillosis by molecular method. So this is mainly, it uses an multiplex PCR, and most common species they have included in this. Along with that, some mutations also can be detected in this. So the aspergillus PCR now recently they have included in the guidelines. So one of the criteria, it is considered as one of the criteria for the diagnosis of aspergillosis. And for mucormycosis, again one of the commercial kits are available, but the sensitivity in the serum is only about 70%. And pneumocystis, again real-time PCR, and as you know, it is an also colonizer, so you should have a cutoff. So many of the kits that is available, they provide a different test, but you need to evaluate in your own group. And also another approach is identification from the tissue samples. So directly especially it will be very for a formalin fixed tissue section, especially when it is not cultured, when the patient is having problem and not responding, those when you want an identity, this is another approach. Just isolate the DNA, amplify it, and then do the sequencing. So by this we could identify large number of things. So again, do you know about the film array? And nowadays it is the next generation, like nanopore and all is becoming more cheaper. So there actually, if you do next generation sequencing, the chances are DNA quantity, even if it is very low, you can identify. So this is one of the tests just from the biopsies which they have done the next generation sequencing. You can see that they could identify large number of pneumocystis cases by this, followed by aspergillus and mucus. So now the latest, this is again the comparison, and next again plasma cell free DNA diagnostics. So this is the technique is really very hard. If you have a very simple technique for getting this cell free DNA, then really that will be an challenging. But now the technique is really very cumbersome as well as expensive. So with this, I would like to end my talk. So non-culture based test helps in the rapid diagnosis, and also many of the time when you are using different markers, so you should use an multiple times you should do, as well as DNA based molecular methods are promising in future. With this, I would like to end my talk. Thank you all for your kind attention.
Next, we'll have the inauguration section.
The year 1962 witnessed the landmark in the healthcare sector of central Travancore, when Bishop Mar Thomas Tharale laid foundation to the establishment of Caritas Hospital at Tellagam, Kottayam. Staying true to its founding ideals of charity and pursuit of excellence, Caritas soon outgrew its name in the treatment of snakebite victims and branched out into providing care in multiple other specialties.
The Department of Critical Care Medicine and Caritas. As the head of this department, I am incredibly proud of our extraordinary team whose unwavering commitment to excellence places us at the forefront of patient care. Our department is a comprehensive, multidisciplinary powerhouse with 26 highly qualified doctors, 72 nurses, 8 respiratory therapists, clinical pharmacists, infection control specialists, nutrition therapists, physiotherapists, etc. We have dedicated neurology ICU, stroke ICU, cardiology ICU, trauma ICU and CTBS ICUs, along with the state-of-the-art medical ICU and surgical ICUs. We provide world-class care for all patients with any degree of injury and any degree of severity as per the etiology. As a department committed to academic excellence, apart from academic programs like DRNB, we conduct regular CME sessions, seminars, and also publish case reports and review articles to share our insights with the broader medical community. At Caritas, every team member, every specialty, and every ICU shares a unified mission to push the boundaries of critical care further, to deliver cutting-edge treatments, and to provide compassionate support to every patient who comes through our doors.
Now, it's a time for the formal inauguration of our program.
As we commence the auspicious occasion with the divine blessing and the lamp lighting ceremony, we will begin with a prayer. May I please request the entire gathering to rise for the prayer. Thank you all. Now you may please take your seat.
It gives us immense pleasure to welcome you all to the Masterclass in Fungal Infection. We are honored to extend a warm welcome to all our distinguished dignitaries. It's a great respect and gratitude that we welcome Reverend Father Binu Kunnath, Director and CEO of Caritas Hospital. Father has been a constant driving force behind the initiative and his unwavering support, visionary leadership, and commitment to the excellence has been instrumental in bringing this program to fruition. We are truly honored by your presence today, Father. Thank you for your continued guidance and encouragement.
Dr. Bobby Abraham, esteemed Medical Director of Caritas Hospital, a beacon of inspiration and a source of continuous encouragement and guidance for the entire program. We are privileged to welcome you, sir, with his absence.
Dr. Jacob George Pulunelkunodil, Senior Consultant and the Head of the Department, Caritas Critical Care Medicine, Caritas Institute, the visionary and the architect behind this masterclass. His meticulous attention to detail and exceptional coordination has been the backbone of this success. A very warm welcome to you, sir.
At this time, I respectfully invite Reverend Father Binu Kunnath to kindly come forward to light the ceremonial lamp and deliver the inaugural address. And I also request the other dignitaries on the stage to graciously join Reverend Father for the lamp lighting ceremony, making the formal commencement of this masterclass.
As this time, I respectfully invite Father Binu Kunnath, and I also request all the dignitaries on the stage to the gracefully with the Father for the lighting ceremony. I invite Father for the inaugural address.
Very good morning. First of all, I would like to welcome each one of you to the Caritas family. We call it as a family rather than a hospital institutions. Because right now we have hospitals, we have institutions including nursing college, a pharmacy college, and paramedical. So we are calling as a family. We are about more than 4,000 plus staffs are working in our institutions, and everybody feel like a coming to a family. Here more than today, masterclass in fungal infections conducted by the critical care of the Caritas Hospital. I am honored to be part of this wonderful CME with the distinguished and eminent speakers across the country. When our Dr. Jacob told me that we will have a masterclass workshop and CME, normally we conduct in a Sunday or Saturday. He asked me to conduct the CME workshop in Friday, weekdays. I asked him why. He told me that, of course, doctors and other staffs, healthcare providers are always around the clock, 24 hours working in a week, Monday to Saturday late night. Normally we get maybe, not everybody is getting only 8 hours or 4 hours, or at least Sunday with the family and other facilities. That's why we are conducting on Friday. And normally when we conduct any workshop or CME, we get a lot of calls from the different hospitals to participate in the workshop. I heard that today we have more than 100 plus participants are there, and there are a lot of many to join, ready to join with the workshop, which we stopped because of they're conducting also the workshop. As you know, Caritas Hospital is one of the oldest hospitals in Kerala. Maybe in India, we could say. It's almost 64 years of its legacy here. We started 1962 with a 50-bedded small hospital for the pregnant woman and snake bite. That was the initial stage. Later, year after year, decades, we grown up to this mark. Right now, we have 5 hospitals in and around Kottayam district, Kerala, with a lot of almost 300 plus doctors are working here. Almost more than 18 departments have the DNB or DRNB programs running in Caritas Hospital. Unfortunately, we have the critical care is running DRNB program here. Every year we are getting 2 doctors for their DRNB program. And I am proudly to say that we have a good leader, HOD, Dr. Jacob is here. Under his wonderful leadership and visionary leadership, of course, I would say that visionary leadership. You know, unfortunately, everybody is speaking about healthcare industry. We have aviation industry, food industry, electronic IT industry. But right now, everybody is speaking about the healthcare industry. But I would say it's not an industry; it's a service sector. Even if we develop in a different way with the new technological revolutions or the most more advanced IT or right now artificial intelligence, we try to replace humane in the place of artificial intelligence. But we should keep in our mind that it's a service sector. We are serving the people. So in a way, we have almost 155 bedded ICUs are working in Caritas Hospital right now. Only for critical care, we have more than 26 doctors are working only for critical care. And more than 100 nurses, I think 260 nurses are working in our ICUs. And we have seen the video with the respirator therapist, infection control nurses, physiotherapists, technicians, a lot of other different verticals of the healthcare departments are working in our hospital. I would say that one of the phase of any hospital that should be critical care and emergency medicine. Right now, with the God's grace, we have the good critical care and emergency medicine right now running in our Caritas Hospital. Even our critical emergency medicine with the 60-bedded emergency department, even with the DNB program, they're also running. So the critical care and the emergency department, they're the 2 sides of one coin, even the 2 allies of the same bird. More than that, we look forward, collaborate with many NGOs, even with the Kerala government, even with the central government, for promoting the quality care with affordable price. Of course, even with 100 rupees or 200 rupees, you can see a super specialty doctor here in Caritas Hospital with more than 20 years of experience for 1 month of these subscriptions. Caritas Hospital coming to its IP or OP patients flow, we are covering almost per day 3,000 plus OP per day in our institutions. Our percentage of IP is 100 plus, maybe 90 plus percentage. With this, I wish you all the best. I'm so happy that we got a good speakers from across the country coming to our small God's own country, Kerala, and giving the best example of the best practice of how can we treat our patients as a human. As I always say to my fellow beings, colleagues, even if we are running behind any technological revolutions, AI, artificial intelligence, telemedicines, whatever possible way that any missionaries, but we don't forget to treat our patients with a humane touch. If you lose this mantra, this therapeutic touch, we are losing our healthcare service. Dear doctors, dear nurses, and dear technicians, everybody, I'm here as a layman. I will be today or tomorrow, I will be a patient, will be coming in front of you. What I want from a doctor, a empathetic way of looking, a sympathetic way of talking, a smile from your face, looking at your face, rather than always in the EMR and the, what you call that, typing or the writing in the paper. Of course, we need, as per our rules and regulations, at the same time, the patient is expecting a smile from a doctor. Don't worry, macha, you will be okay. Tomorrow you will be okay. Don't worry. That kind of empathetic and sympathetic way of dealing, expecting from me, from many doctors. So with this wonderful morning, wish you all the best and God bless you. And thank you so much for the eminent speakers from the different part of the countries, and you are running. Actually, I don't know personally, but I came to know through our Dr. Jacob that you are doing wonderful work in your institutions, and you are the gems of our Indian healthcare in the future and the present. And all the very best to the participants. Of course, you are going to gain from the masters here. Of course, once upon time, they were just like you people. They went different part of the country to attend a workshop. Listen one day from a master, and one day today they came as a master, as a teacher. Maybe in the next, after few years, you will be here to teaching your new generations. Dream that. Let us dream about the future of our state. So wish you all the best, and really congratulate Dr. Jacob and the entire Caritas Hospital critical care team, including doctors, nurses, and all technicians. There's a wonderful support to patients. God bless you. With this, I formally inaugurate the wonderful day of fungal infections. Once my friend from St. John's Medical College, I did my MH from St. John's Medical College. When a lady doctor passed PG, and she got a maybe SMS, maybe WhatsApp message from a other patient that, sister, don't lose your infectious smile. That means the smile that comes to the heart. No, of course, everybody's worries about the infection from the hospital admission. So wish you all the best. God bless you. Thank you so much.
Thank you, Father. Now, I request Father to felicitate our esteemed speakers. I'd like to invite Dr. Arunalok Chakrabarti sir to the stage. Dr. Rajiv Simon sir. Dr. Atul Patel sir. Dr. Pradeep Bhattacharya sir. Dr. Shiva Prakash Rudramurthy sir. Dr. Parikshit Prank sir. invite all the faculties to be on the stage to take a photo. Thank you, sir.
Next, I invite Dr. Jacob George, Head of Department and Senior Consultant, Department of Critical Care, Caritas Institute, for the word of thanks.
Umanapata Binukunatacha, respected faculties, respected delegates, dear friends, colleagues, at the end of this inauguration ceremony, it is my duty to say the word of thanks. I always fear telling word of thanks because I am bound to forget someone and that will always haunt me. So if at all, I'll try my best to remember every one of the team of Caritas Critical Care and Caritas Hospital who was behind this program. But foremost, I would like to thank the Providence, God Almighty Himself, who was there, who has always been a force whenever from the thought of the inception of this program and towards the whole journey till date, and still continues to be the force of this program. The God Almighty His hand was always present, steady, guiding, and always leading me. And for that divine presence, I thank the God Almighty. My heartfelt thanks to Reverend Dr. Binnu Kunnathachen, our Chief Patron and Director. His visionary leadership and his steadfast encouragement has always been instrumental in fostering the best of the program that should be conducted in Kerala. And what makes his support truly exceptional is that he empowers us to pursue such educational initiatives without any reliance on the industry. So most of you have noticed that such a conference has been conducted with a minimal registration fees, and not a single stall is outside for the pharma company. It is totally sponsored by the Caritas Hospital, and because of that, we are able to do an impartial academic activity. And that really makes a difference whenever we are venturing towards a conference. And Achan's silent strength and quiet generosity forms the bedrock upon which this event was built. I sincerely thank you, Acha, for all the support that you have been giving. Our medical director, Bobby Abrams, is probably busy, that's why he is not here. He is a fatherly figure to us, and he has been instrumental guiding me, supporting me throughout from the start of the program till today. And he's a surgeon, he's a medical surgeon always carries a checklist with him. And in between, he always asks, Jacob, is that over? Is this over? He goes by the checklist to make sure that no stone is unturned in making this program a success. Bobby Abrams, sir, thank you so much for your support. To our eminent faculty who has come all over from the different parts of India, Dr. Arunlok Chakravarti, sir, Dr. Rajiv Soman, sir, Dr. Shiva Prakash Rudramurthy, sir, Dr. Atul, sir, Dr. Pradeep Bhattacharya, sir, and Dr. Parishit Prag, sir. You know your space in the field, and yet you have arrived here with humility, warmth, and immense grace. You are not here to just deliver lectures. What you carry along with you, assurance, depth, and kindness. I did have my moments of tension during this organization, and your gentle reassurance and calm presence gave me the courage to move forward. I am deeply touched by the affection and support you extended. I thank you all for your support. Noel is here. Noel? Yeah, okay. So I'd like to thank and recognize the efforts of Noel, our organizing secretary, for his consistent support and tireless commitment to make this conference a good support. And again, my whole team, as Sachin said, we are a team of 26 members, 9 physiotherapist therapists, and the nurses team. The whole team is there. Today I have not gone to the ICU. I will go. But my team is taking care of all the calls and all the patients in the ICU. And that's why I am here today. So my team, I really have to thank my team in the critical care department for allowing me the space and peace of mind to organize this event. Achan had already mentioned earlier why we chose to host this conference on a weekdays. The decision was deliberate because in this demanding rhythm of our clinical lives, weekends are often the only moments that you and I have to reconnect with ourselves and our families. And I didn't want any academic activity to engage into that sacred personal space. And as you are all going to accept it, that this is going to be an intense academic output program. So the intense academic input requires some time to imbibe itself and get absorbed. So I hope that spending 1.5 hours immersed in oncology, 1.5 days immersed in mycology will demand such bandwidths, and we wanted to honor that. A sincere thanks to all the delegates who have joined us from across India. We have participants from Lucknow, we have participants from Vellore, Coimbatore, etc. And as this program is being streamed online, I just checked earlier, we have 22 more delegates watching the program online on the YouTube channel and Facebook channel of Caritas Hospital. The delegates, your support has always been an immense boost for us to move forward to the higher next level and do excellent programs. All the 3 programs that we did, the nephrocritical care, the preceptorship program, and whatever programs we have done, it was always you who have propelled us or who have continued to encourage us to do further programs. I cannot forget the help that I received from Jyotish, Ashwati, and my team, the Food and Beverages team, the IT team, and as I told you, every member of the Caritas supporting staff whose dedication, precision, and hospitality make this event seamless and memorable. Thank you, each of you, for being part of this meaningful endeavor. May the insights that we gain here penetrate our practice, help our patients, and continue and help us more in the continued pursuit of excellence. Thank you.
Thank you, sir. So we'll have a short break and we'll right back with more interesting sessions. Tea has been arranged on this side. 11:15 we'll be back, and restrooms are on this side. If anyone want to use it, restrooms are on this side. I invite our next distinguished speaker, Dr. Pradeep Bhattacharya, sir, Professor and HOD of Critical Care Medicine at RIMS Ranchi. Dr. Pradeep Bhattacharya, sir, is a distinguished leader in critical care medicine with over 25 years of clinical experience and 18 years in medical administration. He currently serves as the president of ISCCM and chancellor of the Indian College of Critical Care Medicine with more than 75 national and international publications. He has been instrumental in launching India's first PhD program in critical care and in establishing the first tertiary level ICU in Madhya Pradesh. Dr. Bhattacharya will now speak on the topic antifungal agents and do we need in vitro susceptibility testing. Please join me in welcoming. So,
thank you and very good morning to all of you. So, in next 25 minutes or so, I'll be covering this topic, that is antifungal agent, and the second part is, do we need in vitro sensitivity testing for this? What I could see, that crowd which is attending or the delegates who are attending this meeting, most of you are either critical care specialist or infectious disease specialist, microbiologist, medicine. This is so well learned crowd what I could see. So my topic it will not cover the general part of the what we exactly want to see as far as antifungal agents are concerned, but definitely the second part will come with some points which will argue in favor of this, that yes, we need in vitro sensitivity susceptibility testing for our patients. So this is the classification of classical antifungal drugs which we use currently in our spectrum on in various cases in our intensive care units. The antifungal, they are mainly fungicidal, and we all know that basically they target the cell membrane, that is ergosterol part. And the second one is flucytosine, which basically it is again a fungicidal against Cryptococcus, but it inhibits the DNA and RNA, that means the nucleus of the fungal cell. And then the third one is azole, which again targets the cell membrane, and they are mostly fungistatic. And the fourth one is echinocandins, which targets the cell wall, basically beta 1, 3 and beta 6 glucan, and they all are fungicidal and mainly effective against Candida species, but they are fungistatic against Aspergillus. So this is the diagram which was shown by Dr. Shiva Prakash also, that yes, these are the various areas of cell membrane, cell wall, and the areas where different antifungal agents are working. Now, first of all, the Pauline antifungal, that is amphotericin B. We know that nowadays mostly we deal with lipid formulation or liposomal amphotericin B rather than deoxycholate, but deoxycholate has got its own importance. These are maximally protein binding. When they work, they are maximally protein binding, almost 95 to 99%. And the kidney and bile mainly eliminates this deoxycholate part of amphotericin B. But as far as elimination and metabolism of lipid formulation of amphotericin B, after intravenous administration, it has not yet been established properly that how it happens, but it is safe as far as kidney patients are concerned. It has also been shown that at equal doses, it has been found that lipid formulations are less potent as compared to conventional form, that is deoxycholate form. But we use it because of its reduced nephrotoxicity, and that is why it has become so popular, and most intensivists now prefer this drug as compared to deoxycholate form. These amphotericin B are mostly they are concentration dependent antifungal agents, and that is why once it reaches the area under the maximum concentration which they can achieve area under the curve, they show their best effect. And it has been shown that Cmax by MIC ratio of 2 to 4 is associated with a good therapeutic efficacy. But in patients with invasive candidiasis or invasive aspergillosis, what we need is Cmax by MIC value of around 10, and that is good. Now, as far as doses are concerned, and as I said, because it is a single dose agent, that means it has got a very good post antifungal effect, means once you give, it works for the whole day, that is almost 24 hours. The second one is the dose. As far as dose, it is the liposomal form, which is almost 3 to 5 times higher we give as compared to deoxycholate form. Deoxycholate usually we give at a dose of 1 milligram per kg, and whereas the liposomal form we give at a dose of 3 to 5 milligram per kg. So current available evidence does not support the routine use of therapeutic drug monitoring, which is another important part for any antifungal agent for this class of antifungal agent. We know that these pollens are mainly made for aspergillus and mucor infection, but in patients, as far as Candida infection is concerned, if you follow this flow chart, you will see that in patients where there is Candida auris infection, there is a chance that yes, we can use liposomal amphotericin B to take care of your patient where echinocandins are not working. The second one is flucytosine. The flucytosine is again almost it has got a very low protein binding, 3 to 4%, and TMIC, it is basically a time dependent antibiotics. Rather, pollens were concentration dependent, this is time dependent. So it is as much time it stays above the MIC level, it will work in a better way. So T over MIC of 40% has been found to be very useful, And because it is time dependent, that is why a frequent antifungal dosing has to be used, and that is basically 6-hourly dosing which we use for this agent. The usual dose is 100 to 200 milligrams per kg per day divided into 4 doses, so 6-hourly. Here, the therapeutic drug monitoring is strongly recommended because it has at both extremes, it creates problem. If the peak concentration goes beyond 100 milligrams per liter, it is associated with bone marrow suppression and hepatotoxicity. And if the trough concentration goes below 20 to 40 milligrams per liter, then it is associated with development of resistance. So that is why this is very important. Now, the most important group of antifungal agent, that is azoles. We all know that right and left we are using azoles for different kind of fungal infections. So main azoles are fluconazole, itraconazole, voriconazole, posaconazole, and now isovuconazole is also we are using for our daily practices. Now, let us see what are the problems which are there with these azole agents. We all know that they are basically metabolized in the liver, and they have direct interference with some of the enzymes like CYP3A4, CYP2C9 as far as fluconazole is concerned. We will see in similarly voriconazole and posaconazole, and they have a very high concentration in urine, and that is why it is very good as far as when we talk about urinary tract infections are concerned. But when we talk of invasive or mucosal infection, at that time you need to give a higher dose of around 12 milligrams per kg daily for children, and in adults you need to give a loading dose of 800 milligrams of around 20, that is around 25 milligrams per kg. What about itraconazole? Itraconazole, again, these are very good oral availability. When we take oral, then oral availability of this drug is very good, and capsules are very well absorbed, and suspension form is also very well absorbed when it is given orally. Again, it has got a very high plasma protein binding, almost 99%. And as I said, all of them, they are somehow or otherwise directly or indirectly hepatic enzyme inducers, or they interfere with the drugs which either is substrate or inducer of these particular enzymes like CYP3A4 and CYP2C9. They again have got an interference. So that is why they can create hepatotoxicity when they interfere with those drugs. I will show the chart after finishing these azoles one after another. So in the intravenous formulation, it has got creates a metabolite that is called hydroxypropyl beta cyclodextrin, and it is eliminated through glomerular filtration, and that is why it is considered that if the kidney function is not appropriate, you should avoid giving this drug because it can create problem of kidney failure. Now, the another one is voriconazole. We all know that it is very well absorbed orally, and protein binding is almost 58%. It has got the maximum hepatic enzyme interference. So, drug interference with voriconazole is maximum. It is basically metabolized by CYP2C19, CYP2C9 and CYP3A4. So, these are the enzymes wherever the other drugs which has got either relation with these enzymes in the form of substrate or inducers, they get interfere with the voriconazole. The dose obviously is 6 milligram per kg per 12 hour for first day, and then 4 milligrams per kg per 12 hours. That is BD dosing is given for this drug, and later on you can reduce it to 200 from 400 to 200. Now, what is bad about voriconazole? It is a time-dependent, non-linear pharmacokinetics with significant interpatient variability in its clearance, because of it has some patient doesn't have this enzyme in their liver, that is CYP2C19 enzyme. So, because of genetic polymorphism, if this enzyme is deficient, obviously the tolerance of voriconazole will be poor. So that is why some patient tolerates this drug very nicely and some patient tolerates this drug very badly because of genetic polymorphism. In addition, a number of clinically significant interactions of voriconazole with other drugs have been observed. And this is the chart which you can see. Most of the drugs are either anti-tubercular or anti-epileptic, anti-malignant, and then H2 blockers, proton pump inhibitors, and then anticoagulants. So all those drugs which whether it has got relation with CYP2C9, CYP2C19, CYP3A4, they get interfere with this voriconazole, and all of them, in all of these patients there may be a problem of interaction and hepatotoxicity with the use of this drug. Now the another one which has come was posaconazole, and posaconazole, although tablets, gastro-resistant tablets are available, oral availability is very good, almost 98% protein bound, but again it has got it is metabolized in liver, but the proportion with which the voriconazole creates problem, it is less with posaconazole. But again, it has got a metabolite that is called beta-dex-sulfobutyl ether that is also toxic to the kidney, and that is why when it is used for patients who have compromised renal function, they may you have to use it cautiously. Dose is again 300 milligrams 12 hourly on the first day, then followed by 300 milligram once daily. Then comes isovuconazole. Isovuconazole is safer as compared to itraconazole, posaconazole as well as voriconazole. It is metabolized in liver again, but liver with these enzymes, but the moderate effect on these enzyme inducers, and that is why the toxicity is less with isovuconazole, and it has shown as a promising result in different kind of mucor infections as well as aspergillus infections are concerned. So the usual dose is 200 milligrams 8 hourly for the first 2 days, and then 200 milligrams once daily. Now azoles have got, as I said, variable post antifungal effect. As we see in polyenes, they have got a very good post antifungal effect, but here the post antifungal effect is variable. Now all of these, they are all related with the trough concentration and the outcome. For voriconazole, the optimal outcome is associated with a trough concentration of 1 to 2 microgram per ml. Higher trough concentration of 2 to 5 are recommended for severe invasive fungal diseases, and similar results were obtained from itraconazole and posaconazole, where the optimal outcome was observed with a trough concentration of more than 1 microgram, more than or equal to 1 microgram per ml. This is very important. That is why it is strongly recommended that for itraconazole, voriconazole and posaconazole, the therapeutic drug monitoring should be done whenever you are using. But I don't know, how many of you are using therapeutic drug monitoring in your institution? Can you raise your hands? TDM? Only one. Okay, but now it is recommended that in critically ill patient, you have to do TDM for isovuconazole also, because they say that there was associated with elevated BMI in those patients, and where the SOFA scores are high, they say that for isovuconazole TDM is necessary. So that is why for our critically ill patients, TDM is necessary for isovuconazole also. I understand all of you are using a lot of echinocandins. They are one of the safest drug. They work on cell wall, and their main pathway of metabolization is liver. Through although CYP450 enzyme is used, but the intensity is very low. Micafungin again has got a very high protein binding. It has got interference with CYP3A, but very minimal effect as far as hepatotoxicity is concerned. And aniludulafungin, it is not metabolized in liver, but undergoes slow chemical degradation in our body itself, and it has got least toxicity. So of these echinocandins, they again exhibit a concentration dependent activity. That means Cmax by MIC, that is very important. But in vitro and vivo have got they have got a prolonged post antifungal effect. The PD parameters associated with therapeutic and fungicidal efficacy are Cmax by MIC for Candida and Cmax by MEC for Aspergillus. Why it is like that? Because as I said at the beginning, that for Aspergillus it is basically bacteriostatic. When you see the cell wall of fungus, it contains both 1,3-glucan and 1,6-glucan. So when this Aspergillus is attacked by echinocandins, it dissolves the 1,3 part, but it fails to dissolve the 1,6 part. So it is partially the fungus gets a bacteriostatic effect rather than bactericidal effect. So that is why. And it has been shown a very good effect against Candida biofilms also. And although in urinary tract we see the maximum biofilms are formed, but echinocandins somehow they are not effective in urinary tract infections. So these are some of the indications where it can be used for aspergillosis. I'm not going to the detail. Some of the new antifungals which has come, I think tomorrow it will be discussed, all those new antifungal, but I'm not going into the detail of that. Some of them, just to name, are phosphomagnogepics. This is one. Then olorofim. Tomorrow all these will be discussed in detail. Then Ibrexa fungar. This is another one. I presume it has it is in the phase 4 now rather than phase 3 trial. And then risafungin. Risafungin is another one which has come into the market, and hopefully very soon it will be available in India also. So these are some of them. Now come to some of the critical care scenarios, like scenario of renal insufficiency, because we know that in renal insufficiency there are problems with the use of different kind of antifungal agents, and side effects which are associated with voriconazole is highly, basically, although it is highly effective against aspergillus and different kind of other fungi, but its use has to be restrained, because as I said, the component which arises after it gets metabolized in the blood, that creates a problem. But as far as fluconazole is concerned, here you can see that although most of the antifungal, they do not need so much of dose adjustment, but some of them, like fluconazole, here in cases where we are doing CRRT, we need to enhance the dose of fluconazole. At the last you can see here, here it is 400 to 800 milligram OD and 300 to 400 milligram per OD. Then as far as other antifungal agents are usually they do not need any added adjustments as far as renal failure is concerned. Just we have to see their safety profile. Then as far as hepatic insufficiency is concerned, triazoles are used in ICU patients. Basically, the dose reduction up to 50% recommended in cases with voriconazole, and therapeutic drug monitoring is considered as mandatory, as I said. And echinocandins are administered as first-line antifungal treatment in critically ill cirrhotic patients. And for patients with severe hepatic insufficiency, there are no data for use of micafungin. So micafungin, it is the data are not available and it should be avoided, and dose reduction in case of caspofungin. And this is the chart which shows that yes, clear-cut recommendation for micafungin is not there in the literature, as this was actually basically little bit old, 2020. So this is not there. As far as sepsis is concerned, what happens that most of the patients with sepsis, they have got a high volume of distribution, and that is why the dosing may need to be increased in these patients. So if we do the normal dosing, like fix 400 milligram of fluconazole in critically ill patient, there is a 33% chance of achieving the subtherapeutic level. So that is why, because of the change in volume of distribution, we need to increase the dose, what exactly is recommended for normal patients. In obesity also, it has been found that because increase in body mass index and the surface area of the body, the amount of dose which is required in patients who are admitted in ICU, the dose has to be increased. And in born patients, because there is a loss of protein again, so protein binding is less. Here again, in these patients, the amount of drug, antifungal drug dosing needs to be increased. And what about ECMO? There are controversial reports. Some of the reports says that yes, you need to increase the dose, but some of them they say there is no need to increase the dose when they used voriconazole and caspofungin. But some of the studies also said that yes, there is no need to increase the dose of caspofungin and voriconazole. But other studies says that if we use voriconazole, there is a sequestration of drug and that goes and stick to the tubings which are actually used in ECMO, and that is why there is a dose reduction in the body and we need to increase the dose. But more studies are needed on patients who are receiving ECMO, who are treated with antifungal agents. Now, the second part, do we need in vitro testing? This is very important. We all know that at the beginning, when amphotericin B was invented in 1950, there was only one antifungal agent. So we had no choice. Whatever fungal infection, we had to give only one drug. But with the passage of time in decades, by the time we reached 1990, we are available with many drugs, antifungal agents. So at that point of time, the choice with the treating physician came that yes, why not you are choosing the best drug for this particular infection, and that was the reason how it has started developing as far as antifungal are concerned. Although antibacterial it has started much earlier, because we had number of antibiotics were much higher as compared to antifungal. Now, what are the needs basically? Why the predicting clinical outcome and guiding our therapy? This is first point. Now, the reasoning is that species specific variability has been seen. Now we see when we different Candida species like Candida albicans, Candida glabrata, Candida krusei, Candida auris, they have different differences in their susceptibility to various antifungal agents. So sometimes they may be sensitive to one or may not be sensitive to other, and that vice versa can happen in other situations. So that is why specific variability can be observed with these most virulent organisms, and that is why it is necessary. Then acquired resistances, which happens because of prolonged exposure in immunosuppressed patients. So they may develop acquired resistance. That is another reason. And patient, when you treat, they will not respond. And that point of time, you need to add or do susceptibility testing. Then local resistance pattern. This is again very important, which we all know as far as bacteria are concerned, that is varies from ICU to ICU, from institution to institution, from place to place. Similarly, in fungus also there is a high level of geographical variation, and there is a variation with healthcare institutions. So that is why this local resistance pattern is important. Then another one is personalized medicine. Susceptibility testing allows for a more tailored approach to the treatment, and we have to be more precise. So targeting more precisely will give a better outcome. So that is why it is very important. Then detecting emergence of resistance. Now, if you do a constant surveillance, if you have a record of your own microbiology lab, then obviously a good monitoring reduces the emergence of new resistant mechanisms, and that helps in improving your antifungal therapy in the institution. Then optimizing antifungal stewardship. This is again very, very important. Avoiding unnecessary broad spectrum use. But currently mostly what happens whenever the patient comes, we use empirically these antifungal agents. But if we have a data, then we can always narrow down our spectrum, and that will help in maintaining the stewardship program. Then monitoring treatment and response. While not a direct measure or in vivo response, changes in the susceptibility pattern during treatment failure can provide a clue about the development of resistance. And then obviously, as far as clinical trial and research is concerned, evaluating new antifungal, because unless and until we come to know more and more resistance pattern, we will not think of developing new antifungal agents. Then understanding resistance mechanism, that is also very important. When we see some resistance, then only we understand that where, in which direction we need to go. So that is why all these are very, very important points as far as which goes in favor that why we need in vitro susceptibility testing. Now, clinical breakpoints, MIC, MEC, all these are important from laboratory point of view. And to standardize this, CLSI and UCAST has been developed in United States and in Europe, and they basically standardize this breakpoints for all those antifungal agents. And with the help of MIC and MEC, we found out which will be the best agent for any particular patient. So they develop, publish, and regularly update their standardized methodologies for determining the MIC and MEC of antifungal agents against various fungal pathogens, including Candida species. So all those pharmacokinetic and pharmacodynamics methodology they use to find out the breakpoints. That is, they give it in the form of susceptible, intermediate, or resistant, what they give there in the reportings. Certain other phenomena in laboratory like this, such as trailing growth, they can sometimes confusing. I am not going to the detail of that because of paucity of time. That is one phenomena which confuses the microbiologist whether this drug will actually work or not. So exactly, as a clinician, when do we feel that in vitro sensitivity is essential? When the fungal infection is invasive, when acquired resistances are suspected, and when the patient is unexpectedly failing to therapy. So these are tension and these are our headaches when we manage patient in ICU. In each of these scenarios, knowing the in vitro susceptibility pattern would inform the clinician when making therapeutic choices and changes when we want to do. So at last, this MIC, MEC are limited because they only describe in vitro phenomena, obviously, but they are of great help. Linking this MIC, MEC data to clinical outcomes as a clinical breakpoints allows for determination of whether an antifungal agent will be effective for the patient for invasive fungal disease. It should be noted that antifungal resistance as measured in vitro will not necessarily translate to treatment failure in a patient. This is very important. Antifungal sensitivity test cannot uniformly predict success or failure, and it has been observed that in a sensitive group 90% success we can accept, but where the resistance is coming even after testing, there also we can expect almost 60% of success in treatment. Thank you very much.
Let's go to the next session, and the question will start with pouring in when we will have workshop. Oh, no, that would be the next way.
Thank you, sir, for your key information regarding the topic. Next, I would like to welcome Dr. Adur Patel, is the Chief Consultant Director of the Infectious Disease Clinic, Settling Hospital, Ahmedabad. A distinguished authority in infectious disease, Dr. Patel has authored over 18 peer-reviewed publications in prestigious journals, including the Lancet Infections Diseases, Clinic Infectious Diseases, and Intensive Care Medicines. Notably, he is also a co-author of 2 current global guidelines on the treatment of mucosis and cryptococcal disease. We are honored to welcome him today for an interactive case discussion on Candidemia in the ICU. Welcome, sir.
Yeah, good morning, and thank you, Dr. Jacob and the Caritas team for inviting FISF and me to speak on Candidemia in ICU. So this is an interactive case presentation. So I need your active participation. right? And we'll all try to learn like from this case. So why we are bothered about the invasive candidiasis? The reason is that every world globally, like we have 600,000 of patients who develop with invasive candidiasis, and mortality rate is very high, 30 to 40%, and even this is in high income countries. So even where the resources is not a big issue, the mortality once the patient develops invasive candidiasis remains very high. The patient who are having an invasive candidiasis but they are not picked up, their number is far more than the patient who received a diagnosis, and it is almost 900,000 patients. So we are missing large number of patient who has invasive candidiasis because of the limitations in the making a diagnosis. And generally this invasive candidiasis occurs in a patient who has one or the other risk factors, right? So it occurs both in both neutropenic patients as well as in non-neutropenic patients. And we all know the risk factors in ICU, those patients who develops invasive candidiasis ranging from central line parenteral nutrition, GI surgery, broad spectrum antibiotics, hemodialysis. So we know all the risk factors for development of invasive candidiasis in ICU admitted patients. But in the recent past, like there is some challenges which is associated with the invasive candidiasis, and the challenges is limited not only to the development of resistance, but the newer host factors which has come up for the risk for the invasive candidiasis, and that is the patient who has received the IL-17 inhibitory treatment, right? So we are creating more and more new hosts. At the same time, the fungi is also developing resistance, and two important species which we would like to be very careful and cautious is Candida auris. We know that it has significant drug resistance, and it can emerge resistance while patient is on antifungal therapy. And the second is fluconazole resistance Candida parasilosis. The biggest challenge in the diagnosis of invasive candidiasis is that when you look at the clinical presentation of the patient, the clinical presentations is not specific, and the patients can have very minimal fever to a frank sepsis, just like a bacterial sepsis, right? So it is very difficult to predict that this patient is having just mild infection and it cannot have candida or it cannot have invasive fungal disease. No, the patients can have very minimal fever and patients can have full-blown frank sepsis. And if you look at the physical examination or the signs in a patient who has invasive candidiasis, there are very few signs that you may point, it can point that this could be invasive candidiasis. So these patients can have skin rashes, so you have to be very careful in your physical examination. And many different types of skin rashes that you may see in a patient who has invasive candidiasis. You can also get the ocular involvement in a patient with Candidemia, right? So you have to specifically look for the ocular involvement, and you have to involve your ophthalmologic colleague to look at the fundus. Very rare, this is infrequent, the clinical, the sign that is the muscle abscesses. So you will find a localized swelling and tenderness over the one group of the muscles in a patient who has invasive candidiasis, but this complication is considered as a very rare. So there are very few clinical signs from which you may pick up a case of invasive candidiasis. And diagnosis, we have a very good lecture in the morning sessions about the fungal diagnostic, but the blood culture remains a very important and the gold standard for making a diagnosis of Candidemia. But there are several non-culture based tests: BDG, Menon, anti-Menon, Candida albicans, germ tube antibodies, T2 Candida, and the PCR. So I'm not going to discuss any of this. So another important concern that I told you that like we are missing large number of patients, and this article is very interesting, and it says that almost half of the patients to whom we are giving a treatment for invasive candidiasis, we are missing rest of the half. And it requires the improvement in the diagnostic capability to pick up all these missing 50% of the cases. So when you look at invasive candidiasis, it's a spectrum of the disease where you can get the patient who has only Candidemia, so Candidemia without deep-seated focus. You can have a patient who has Candidemia plus deep-seated focus, and you can have patient who has only deep-seated Candidemia. and there is no Candidemia, right? So only deep-seated candidiasis. And if you improve the diagnostic capabilities, you are going to pick up more and more cases of especially the deep-seated candidiasis. The reason is that when you are using a culture, blood culture, right? The patient who has Candidemia with or without deep-seated candidiasis, you'll be able to pick up from 50 to 70% of the patients with this disease. But when patient has only isolated deep-seated candidiasis, then only 15% of them, they can have blood culture positivity. That means that you are going to miss a large number of patients who has deep-seated invasive candidiasis, and you need the fungal biomarkers to pick up those cases, right? To provide them effective care. So now coming to the case, right? So now I need the participation from all of you. So this is a 70 years male residing in Udaipur who presented to our clinic with high-grade fever spikes of 103 degree Fahrenheit with chills for last 3 weeks. He also had weakness and the loss of appetite and the weight loss. The relative also described the altered sensorium with high-grade fever spikes for the last 3 to 4 days time. He also had a frequency and the urgency of urination. So he has some urinary symptoms. In the past history, patient was diabetic and recently being diagnosed to have Hodgkin's lymphoma. He completed 3 cycles of ABVD and the chemo port was placed before 4 months. So this was his presenting complaints. So treatment that he has received for this 3 weeks, very high grade fever, like he was admitted and he was worked up extensively. Urine examination, the cultures were unremarkable. There were no pus cells and the culture remains sterile. And it was diagnosed to have benign enlargement of the prostate. The echocardiogram, CT scan of thorax, abdomen, everything was unremarkable. He has received multiple course of antibiotics. And the MRI and the CSF examination was also carried out because of his altered sensorium along with high-grade fever spike, and both the investigations were normal. So that's the reason that patient was transferred to our center for further evaluation and the treatment. So in the summary of clinical presentation, the elderly diabetic male recently diagnosed with Hodgkin's disease on ABVD, chemo port in site, and he presented with fever without localizing signs and symptoms, right? Though he has dysuria and frequency, so we considered as the focal symptoms probably pointing towards the urinary system, but his urine examination and the culture were normal, and he was diagnosed to have benign enlargement of the prostate. That's why I'm using a terminology of without localizing the signs and symptoms. And he has no response to antibiotics that he has received. So on physical exams, like he was thin built, drowsy but arousable, and anemic. He has a generalized increase in the skin pigmentation, and there was a fingernail clubbing of grade 2. The heart sounds were normal. There was no murmur. He has clear breath sounds, and non-tender spleen was palpable below the left costal margin. So the differential diagnosis when patient was admitted to our hospital. So whenever you are treating a patient who has fever of unknown origin, like he has completed 3 weeks, high grade fever, and patient is not having any focal signs and symptoms pointing towards any organ which is being involved, like either pulmonary system, GI system, liver, kidney, or any other system, musculoskeletal or the CNS. Right? He had some CNS or some urinary symptoms, but the workup was unremarkable. So this patient is having a true FUO without localizing symptoms. So diagnosis here is always challenging. So 2 things that comes into my mind is, one is the drug fever, because drug fever can give you a funny fever, but the important points when you are suspecting drug fever is that the patient becomes absolutely normal or near normal in between the fever spikes, right? So this is a very important clinical clue of suspecting drug fever, that patient is having high grade fever 103, 104, patient can have relative bradycardia, but once the fever goes down, the patient is normal, patient is eating normal, patient do not have any significant residual complaints. So this is a characteristics of the drug fever. But this patient was not having that. Patient was having a persistent weakness and he was drowsy. So despite that, like we keep a possibility of drug fever. the disease activity. This is again very important because he has Hodgkin's. He has completed 3 the courses of ABVD, right? It is possible that Hodgkin's might have not come under control and giving a very high grade fever spike. Endocarditis was again a possibility because he has a fever, he has a clubbing, and he also has a splenomegaly, right? No skin rashes, no splinter hemorrhages, but it's still possibility. Cytomegalovirus is a funny and notorious virus. It can reactivate in immunocompromised patients, and patients can have funny fever, right? So it is always the very important differential diagnosis here. And prostatitis, because he has a urinary symptoms, right? Even though like he received a diagnosis of benign enlargement, but prostatitis could be a possibility. So we started his workup. So blood culture, urine culture, and the routine investigations were sent on the admission. The empiric antibiotics meropenem was started, and his labs comes hemoglobin 10, WBC 11,000 with 83% polymorphs, platelets were normal. Urine again showed 2 to 4 pus cells and 1 to 2 RBCs and trace protein. RA factor, which was sent for the assessment of endocarditis, it came 2 times upper level of normal. Creatinine was upper level of normal. Mild transaminitis, hypokalemia, hypomagnesemia, and the sodium was normal. So these were his important reports. But we got a call from microbiology lab after 23 hours of the hospitalization that his blood is growing east. The blood was collected from chemoport and the peripheral line is still sterile. So the first response to the call was like we just added caspofungin, right? Echinocandins are drug of choice whenever you are suspecting or whenever you are treating a patient who has candidemia, right? So we just added caspofungin in the standard dosage. But we need to remember that when you are treating immunocompromised patients like this, the non-candida yeast, which is not susceptible to the echinocandins like Malassezia, Trichosporon, like so, these are the fungus which can also produce fungemia, and it is not susceptible to the yeast, echinocandins, right? So we have to be very careful, especially when you are just responding to the call from the microbiology lab that there is a presence of yeast, right? But fortunately, this yeast was identified by Vitek2 as Candida parasilosis, which is drug susceptible to almost all. Fluconazole MIC was less than 0.5. Vori was 0.12, Caspo was 0.25, Mica was 0.5, Ampho was 0.5, and the flucytosine was 1. Now the question to the audience, like so we have so many ID physicians, microbiologists, and critical doctors. Is this represents a chemoport colonizer? How many of you feel that peripheral line is sterile? Just 1 day of admission, the chemoport has grown something which is Candida parasilosis. So do you think that this chemoport is responsible for this candidemia? It's just colonizer and we need not to act. Anyone? Just raise your hand. Those who believe that this is a colonizer of chemoport, just raise your hand. I think you should participate because this is interactive case presentation, right? There is nothing right and nothing wrong. Okay. So the things that you should remember is that whenever any line or any blood which has been collected in the blood culture bottle is growing either Candida or Staphylococcus, whether it is MSSA or MRSA, should be respected. You cannot ignore. It is always a pathogen, right? So you have to treat this episode even though the peripheral line is sterile. And in this patient, like this patient has a fever of unknown origin, he do not have any significant localization. There was a hardware inside, like he was having a chemoport before 4 months. So likely that this invasive candida, he has invasive candidiasis, though I mean peripheral line was negative, but chemoport is colonized and producing some symptomatic disease. Now the second question, should we remove the port? Just raise your hand. How many of you will favor the removal of port? Yes, good number. How many of you would like to keep the port inside? Because recently he has started chemotherapy and he would like to, preserve this precious the line. Anyone would like to retain? No one, right? So that's the correct decision. So guidelines strongly recommends that you have to remove the hardware whenever you have infection like Candidemia. And guideline also says that as soon as you are removing the hardware or the port or the central line, the benefit or the outcome would be much better, right? So the important thing is that once you have a Candidemia, your plan of treatment should be to remove or to get out of this hardware from as soon as possible. And for our patient, like patient has Candida parasilosis, and remember that parasilosis loves plastic, right? So it easily and rapidly produces the biofilm. So whenever it is a parasilosis, though Candidemia is an indication, but if you are dealing with parasilosis, you have to get out of the hardware as soon as possible. Now this is very important questions to clinicians. We have so many ID doctors over here. Should we change the antifungal to fluconazole? Fluconazole was sensitive. The MIC was less or equal to 0.5. So how many of you would like to change caspofungin that we have started on day 1 to fluconazole? Just raise your hand. How many of you would like to continue with the caspofungin? Oh, so many. So do you know that parasilosis has higher MIC for echinocandins as compared to the other species? And this is because of the naturally occurring FKS mutations, right, into the parasilosis. So the MICs for all the echinocandins, caspo, mica, and the anidula is generally high. Not in 0.0, it is always in 0.5 or something like this one. So despite that, would like to continue with the caspo? Okay. So switching of antifungal to fluconazole is here good option because fluconazole is very sensitive here. Like so, MIC is just 0.5, and echinocandins has higher MIC for parasilosis because of these naturally occurring FKS region mutations. But we continued caspofungin, so I go with the most of the audience which has voted for the caspofungin. The reason or the rationale for continuing caspofungin at that time in my mind was it has better biofilm activity, right? So we know that like liposomal amphotericin is also having a very good activities against in the biofilm. But caspo is one drug where you expect, or the echinocandin is a drugs where you expect a very good penetrations into the biofilm, and not only planktonic but the biofilm related the organisms will be also taken care. And there are no clinical data, no clinical studies which says that the outcome is much better in a Candidemia because of the Candida parasilosis who has received fluconazole versus echinocandins, right? And there is recent the Spanish study, which is multi-center study, which also says the same thing. There is no difference in the outcome of Candidemia because of the Candida parasilosis who has received fluconazole versus echinocandins. So I mean the clinical information which was available to us was very much the supporting the decision. Yeah, sure, yeah.
But we must also consider cost.
Yes.
If there is no worsening, then I will still think, although if you look at the verbatim what the IDSA guidelines of the third now, what has it said? That in those patients who have been started on echinocandin and have improved clinically,
yes,
it is reasonable to continue with the echinocandin. I have a serious objection with this statement.
Right.
Okay, so in our country where the difference in cost is extremely huge, and here you have an organism which is fairly susceptible, and
Exactly.
you have removed the line.
No, we have not removed the
You
line.
not yet removed the line.
Bilkul
Okay,
nahi.
sorry, then it's okay, but then I will strongly suggest that you do that first.
Yeah. So we'll go to the
Even
case.
without
Yeah. So
pondering
yeah,
about,
exactly. So this is
echinocandins
I
versus
think.
fluconazole, removal of the line is very, very important.
So the Rajiv's point is extremely important. Let the cost when you are treating a patients, right? So we need to consider the financial aspect of the patients also. But the interesting part, when echinocandins and the parasolysis comes, even if like in vitro, the MIC for micafungin is higher, but if you add a serum, even in vitro, or when you are treating a patient with micafungin with Candida parasolysis, the PKPD parameters of micafungin changes, it reduces. So even though the MIC is high, but presence of serum improves the efficacy of micafungin, right? So you can still continue with the echinocandins when you are using micafungin for the treatment of Candida parasolysis. So this is a small point, but it is very important point. So patient's relative refuses for hardware removal. They said no. It is a precious, and I do not want to, give permissions to remove it. So this is, I think, day 3. So again, like day 2, like he has refused, and day 3 also he said no. So now question comes, like patient is having hardware inside and you are giving some antifungal and patient is having candidemia. So how you are going to monitor? So how should we monitor a patient who has candidemia? So guideline recommends a daily blood culture. Still patients achieves a sterile blood culture for 3 consecutive days. So this is a current recent guideline, candidemia guideline. So you have to collect a daily blood cultures. But in my practice, I made little change in this daily blood culture collections. So my way of treating candidemia, my way of monitoring candidemia in my ICU would be, I repeat the blood culture on day 3 of antifungal therapy, then day 7, day 10, day 14, and so on, right? So I do not collect daily blood cultures. So what about the other experts? Like, are they collecting daily blood cultures? 48 hours, right? So this is my way, 3, 7, 10, 14. So the repeat, because of Staphylococcus guideline, because Staph aureus bacteremia, day 3 blood culture is very crucial, and it decides the duration of therapy and the complications and everything. 70, yeah, exactly. Okay. And 48 hours, like sometimes, like even though you are using a loading dose, the steady state level may not be achieved. So that's a little, early blood culture for me.
They say that any staphylococcal second culture being positive means complicated
Exactly.
The definition is also
Change. So I just extrapolated the Staph bacteremia guideline into Candidemia 1. So one way to monitor the Candidemia would be the repeat blood cultures, and the second way would be beta-D-glucan, right? But the important limitations of having beta-D-glucan to monitor. So remember, like Shiva Prakash says that galactomannan is used for the monitoring of treatment of a patient who has invasive aspergillosis, especially in neutropenic setting, right? So serial galactomannan will show reductions in the galactomannan levels, and it is correlating with the success of antifungal therapy. So similarly, can we use beta-D-glucan? Yes, we can. But the issue with the using of beta-D-glucan is that up to 20% of the patient will have rise in the beta-D-glucan despite patient is having successful therapy, right? So it will confuse you. So using beta-D-glucan in monitoring of candidemia would be little difficult to interpret, because 20% patients can have increase in the level of beta-D-glucan even though the patient is receiving successful therapy. So this is a real challenge in monitoring of patient with candidemia. Yes. Yeah. So generally it should not be done. Yeah.
There is just one small study from Thailand, and Ostrowski is the senior author there. Jaijakul is the first author. That is the only study in the world which has shown that you could use it. Now compared to that, there is huge clinical experience of not using beta-D-glucan, or the fallacies of using beta-D-glucan.
You know the reason why it cannot be used? The reason is that we do not know the actual kinetics of beta-D-glucan, how it produces, how it excreted, and how the patient, even though they are responding, and that's the biggest limitation. Like galactomannan, we know that replicating mycelia, the galactomannan is released from the replicating bud of the aspergillus. So once you inhibit, once you treat, the galactomannan goes down. But the kinetics of the beta-D-glucan in the human body, we do not know.
Same thing is true for PCP.
Yes.
You have sky high beta-D-glucan and you don't even use it for monitoring.
Yes, that's true. right? But this is what like you can use theoretically, or I mean sometimes it is useful, like in 80% of the time you expect decline in the beta glucan. You get fever spike but with reduced intensity. So the fever which was 103.
So in such a situation, if the guys are not allowing you to remove the port, my recommendation would be to give that caspofungin through the port and not peripherally.
Yeah. So or the antifungal lock therapy.
Lock is a different thing. If they don't even allow you to lock, then at least give it through the port.
So that can take care of the colonization.
To some extent.
So patient has continued to get fever spike, like, but it has reduced intensity. So previously it was 103, but it's still spiking fever. The sensorium started improving. So patient's relative were happy that, look, patient is, doing good clinically. The urine culture which was sent on the admission came back sterile. Day 3 blood culture that we have sent from the chemoport grew east after 22 hours. The first culture was positive after 23 hours. This is 22 hours. And the peripheral line grew east after 46 hours. So this time both the lines were positive. And Vitek identified the same fungus with the same drug susceptibility. So now the problem is that day 3 blood culture is positive. Now what to do? What are the causes apart from the chemoport which is inside? What are the important differentials which can lead to day 3 culture positive? Rajiv has says source. yeah, yeah.
The drug levels.
Yeah, you have to say something.
The drug levels in the body.
Sorry?
The drug levels.
Drug levels, like generally in the echinocandins, it is not like azoles where you have non-linear pharmacokinetics and the absorption is unpredictable, especially for itraconazole and the posaconazole suspensions. It's not like that. Here, like you are giving intravenous therapy, so you expect the drug is delivered properly to the body system, and the pharmacokinetics is not that unpredictable like azole therapy. So drug level, I think, if patient is on renal replacement therapy, patient in severe sepsis, septic shock, patient is hyperdynamic circulations, then increased capillary leak and other things, then probably yes, then the drug levels may be low and this could be a cause of failure.
Metastatic abscess.
Another site of infection. This is a very important answer. So source control, another metastatic site. Anything else? How many of you feel that the wrong selection of antifungal therapy could be the cause of treatment failure in patients in persistent candidemia? Though we know that, there is no difference between fluconazole and caspofungin. Right, so generally we are sure that, it should work. So the wrong selection of antifungal could not be a cause. Failure to remove hardware or the source control is, I think, one of the very important factors in my patient who has not responded. And the deep-seated source, right? So metastatic lesions. So the patient who has day 3 or the repeat blood culture positive rather than removing the day 3 word. So how do we approach? We always look into our prescription, look into the drug interactions, possible drug interaction, as doctors rightly said, if you are using azoles and some other drugs. And even for caspofungin also, like the enzyme inducers reduces the levels of caspofungin. So if patient is on anti-epileptic or rifampicin, then the drug level, the inductions of the CYP3A4 system by rifampicin and anti-epileptic will reduces the drug levels of caspofungin. So you need to increase the dose from 50 milligram to 70 milligram, right?
There are a lot of clinical pharmacists here. So I always have an argument with them because I refuse to reduce the dose of caspofungin from 70 to 50.
Yeah.
And when I don't do that, the clinical pharmacist is breathing down my neck saying that, why don't you do that? Okay, so we are still, I think in critically ill patients, now this guy is not terribly critically ill, but in critically ill patients, it is definitely recommended to have a higher dose of any of the echinocandins.
Yes.
So for caspofungin, I think it is costs also the same. So I wholeheartedly endorse my own view, of course, of continuing with 70 milligrams. What do you think of that?
Yeah, absolutely. So that is what my practice says. So I continue with the 70 milligram. There is no difference in the cost. So when the repeat blood culture is positive, always look for the drug-drug interaction, whether the patient is receiving drug properly or not. Check for the possible source of infection. So here, like, the important possible source would be the line that we have not removed. Always positively look for the deep-seated focus, and the most important focus would be either endocarditis or vertebrodiscitis. So Candida loves vertebral and the disc space, right? So whenever the patient is having a persistent or the prolonged Candidemia, this bone and joint infection, especially the vertebrodiscitis, is not uncommon. So you have to positively look, because many times patient will not complain of back pain. So you have to ask positively whether you had get a new onset back pain or not. You have to physically examine the spine and look for the tenderness. And if required, you have to use the radio imaging to confirm that patient is having vertebrodiscitis or the metastatic lesions in that side. And patients can have deep-seated lesions into the other body sites also, like intra-abdominal, if patient has pancreatitis or the retroperitoneal collections, abscesses, where patients can have the deep-seated or the intra-abdominal candidiasis, and that could be a source for persistent candidemia. So in my patients, I think that we have not removed chemoport, and that could be the very important source.
One more point, although that's not going to produce fever, is the eye exam.
Yes.
When you talked about others,
Yes.
that is also an important thing. Of course, you won't get eye involvement producing.
So now patients' relative, the second blood cultures comes positive. So now patients' blood, relatives, they agree that, look, this is the real trouble. We are spending money and we need to get out of this chemoport. And they also agreed for having a TEE also, because second blood culture was positive. So we just removed the chemoport, and the tip gram strain showed the gram positive yeast. So that is what we expect, that chemoport is also colonized. The culture grew the same Candida paracillosis with the flush method, and same drug susceptibility. So there is no change in the drug susceptibility. In the morning, like antifungal agents and drug susceptibility, they have, it was stressed that we should know the emergence of resistance, right? So it is possible that with persistent infection, you may expect the increase in the MIC, but the sensitivity remains the same. But TE showed a large, elongated, freely mobile structure into the right atrium, which was independent. It was not associated with any valve, right? It was in the right atrium. It was distinct. The valve was seen very clearly. Look at this.
So why was it missed on transparency?
I don't know. It was done at Udaipur, and so we have not done here. So look at this. So this is a very large, elongated, freely mobile structure, which was popping in and out, and tricuspid valve edges were absolutely normal. So this was endocarditis, right? So we'll discuss that. So meropenem was stopped on day 7. Caspofungin was continued. There is a progressive clinical improvement. Patient became afebrile after removal of the chemoport and started eating food, felt a sense of well-being. The repeat blood culture on day 7 remains sterile. Patient was discharged on day 14th of hospitalization on caspofungin for 1 more week, followed by the oral fluconazole 400 milligram once a day, because fluconazole MIC was less or equal to 0.5. So if you look at the AUC MIC for this patient, it was 800, right? Because for fluconazole has a linear pharmacokinetics, and to calculate AUC for fluconazole, it is extremely easy. The dose of fluconazole is AUC. So if you are using 600 milligram, the AUC for fluconazole is 600. If you are using 200 milligram, the AUC is 200, right? And AUC MIC of more than 100 is generally associated with the improved outcome. And for my patient, the AUC MIC is very good, 800.
This MIC was done by Vitek?
Vitek.
So this hospital is not.
I know microbiologists are not happy, but this is what we have. So now coming to the question, like the valves were clear, right? The edges were distinctly seen, and it was popping in and popping out, and it was a freely mobile structure. So is this Candida endocarditis? How many of you feel that this is Candida endocarditis? Just raise your hand.
Any repeat echo was done after removal of the line?
After this was after removal of the line. So I forgot to tell you. Yeah. So yeah, it was not a thrombus. Yeah.
It's a mural endocarditis.
Yes. So how many of you feel that this is endocarditis? Yes. Okay, good. So what are the criteria that we know? The patient satisfies two major criteria, right? One is TE showing a freely mobile some structure into the right atrium, and the blood culture is growing Candida species in a patient who has intracardiac device, right? He has a chemoport going up to the right atrium. So and Candida was isolated. So two major criteria, and if you look at the minor criteria, he also has a fever and the positive RF factor, right? So we can say that this patient is having Candida endocarditis. So how to treat Candida endocarditis? The guideline says that you can use echinocandins, and especially the guideline recommends caspofungin, liposomal amphotericin with or without 5-flucytosine for the treatment of endocarditis, and the fluconazoles in a higher dose, that is 6 to 12 milligram per kg, as a step down therapy in a patient who has clinically responded infection, and infection is caused by the fluconazole susceptible Candida species. The IDSA guideline recommends the previous IDSA guideline. Currently, we have ECMID global guideline, but the IDSA guideline recommends the higher dose of echinocandins, so Caspo 150 milligram, Mica 150, and Anidura 200 milligram per day for the treatment of Candida endocarditis, right? But I have not increased the dose. I just continued 50 milligram for 1 more week. And guideline also highly recommend the surgical removal of, so that is what we are, heading towards, So surgical treatment is very important and essential component of treatment of endocarditis. So either you have to do a valve replacement therapy, or if you can remove the vegetation, so vegetectomy is also recommended strongly, and removal of the intracardiac device. So if you have pacemaker wire or any other intracardiac device, you have to get out of this foreign body or the hardware, right? So this is highly recommended by the treatment guidelines. And the important thing in this surgical therapy is that it should be done as soon as possible. So you have not allow the patients to have prolonged candidemia, because if patient is having prolonged blood culture positivity, then patient will have more metastatic sites. The chances of intracranial infections, vertebrodiscitis, and other deep-seated focus, including the eye involvement, the chances would be very high. So it should be done as soon as it is possible. So next question, like what Dr. Pradeep says, how long we should continue the antifungal treatment for endocarditis, right? So guideline says that you have to continue for at least 6 weeks after the surgical therapy. So if you remove the valve, or if you remove the process, the hardware, then for at least 6 weeks. And the long-term suppressive therapy is recommended for those who cannot undergo the surgical therapy, right? So possibly it is a lifelong continuation of the suppression therapy. So coming to the case. So we chose a prolonged therapy for total 12 weeks rather than 6 weeks, because my cardiologist says that, Dr. Atul, like we need to continue to, even though the tricuspid valve looks okay, so let us give a prolonged therapy. I said, okay, no issue, because patient was tolerating well and patient is on fluconazole therapy. And we could achieve the source control by removing the chemoport. The valves were free from the vegetation, and we gave 3 weeks of caspofungin 50 milligram followed by 9 weeks of oral fluconazole. The patient responded very well. He has a weight gain and the feeling of well-being, and the repeat transthoracic echo was absolutely normal, and the beta-D-glucan at the time of discontinuation of antifungal therapy was also normal. So whenever you have a case of Candidemia, Staphylococcus, or the gram-negative bloodstream infection, these are the 3 areas in the infectious disease where having a consultations from ID physicians makes lots of difference. It significantly improves the outcomes. Now we have multiple publications for all these 3 organisms, Candida, Staph, and the gram-negative, that having a consultation, even for Staphylococcus, telephonic consultation with the ID physicians also improves the outcome of patient who has Staph bloodstream infection. So take-home message from this interactive case, the source control is one of the very important component of Candidemia treatment. Echinocandin is not adversely associated with the outcome in invasive candidiasis because of the paracillosis. The search and the treatment for deep-seated focus is very important when the repeat blood culture is positive. The blood cultures and the BDG are useful to monitor Candidemia treatment, and the ID consultation reduces the mortality in patient with Candidemia. Thank you very much for the patients listening. This is a zebra crossing Mara River during the Great Migration, and look at his fear. Any questions? Or questions would be during. I just highlighted the splash.
Thank you, sir. No, sir.
You want to use this?
I want to use no.
ये मैं डॉक्टर प्रदीप का
नहीं, I have a pen. इसमें मैक नहीं जाएगा, आपने मेरा पेन ड्राइव नहीं जाएगा.
I will introduce our next distinguished speaker, Dr. Raju Somansar,
ये निकाल दिया.
consultant physician in infectious disease, specialist at Jupiter Hospital, Pune, a renowned academician and a name with excellence. Dr. Raju Somansar was the top-ranking student throughout his MBBS and postgraduate years, and remarkably, he continues to lead the example even today, consistently staying at the forefront of the clinical knowledge and research. Dr. Soman is the co-chairman of the Fungal Infections Study Forum, executive and founder member of the Clinical Infectious Disease Society, and the editor-in-chief of Journal of Clinical Infectious Disease Society. He is also the author and the editor of multiple seminal works, including Casebook of Infectious Disease, Casebook of Invasive Fungal Infection, and the Casebook of COVID-19. His passion for knowledge and teaching continues to amaze and inspire everyone. We are truly privileged to hear from him today on the principles on antifungal therapy. Please join me in welcoming sir.
And it's indeed a great pleasure here to be with all of you and in the company of my colleagues from FISF and Dr. Jacob, wonderful hospitality. Okay, so I really hope that all of you join this discussion, because what I gather from all your profiles is that you are not greenhorns, but you are already experienced people, and I'm sure you can add a lot to these discussions. Okay, so maybe this talk should have been a little in advance, because we are discussing principles, but doesn't matter, because so many things have been discussed since morning, and that will probably highlight what these principles are all about. So we are mainly talking here about 4 important invasive fungi, and you know those 4. And although they are often considered together, so people keep on using this word invasive fungal infection, but to my mind that word doesn't have a real clinical meaning. Why? Because no one can diagnose an invasive fungal infection. Okay, because what does it really mean? The syndromes which each of these fungi are producing are totally different. Okay, so their syndromes are totally different, and therefore that approach to diagnosis and management are absolutely distinct from one another. However, there are certain principles which are important, which are different from bacterial infections and which are common to them, and that is what we are going to discuss. So the first principle is that they produce disease when the immune system is compromised or the integumental barriers are lost. Okay, so let's take some examples here. So here you have the first patient who's got intense chemotherapy, so there is a lot of oral mucositis, and what you can see here is also there in the intestine,
and everywhere else. Okay, so you are going to have candida which are normally residing in the bowel, other fungi too, which are going to translocate into the bloodstream, and then in the bloodstream you're not going to have enough neutrophils to take care of them. So it's not a surprise at all that here you'll get the problem. The picture down shows you a line like the port, or this is a hemodialysis catheter. So again you have an integumental barrier which has been lost, and this, which is not actually so obvious, but you have a hugely distended bowel, maybe an obstruction, subacute or acute obstruction, maybe areas of ischemia there. So again what happens is, this is going to allow the candida organisms in the gut to translocate into the bloodstream. So these are the many situations where you can expect it. Similarly, if the highest chance of getting Candidemia is a gastroduodenal or a esophagogastric perforation, much more than a colonic perforation. Aruna Lokhe talked about this. So you could even have this kind of a thing. So this is a patient who had a very severe soil contamination, a road traffic accident, and continually appearing necrotic tissue. Okay, so this definitely indicates that something is going wrong. A vascular invasive mold is very likely here. And among the mucorales also, you have that question in your thing, and I'm sure you have chosen Apophysomyces variabilis as the answer here. Okay, so that is a commonly derived, soil derived organism which has nothing much to do with the neutropenia or immunocompromise. Now here a patient with head injury, and there is an abscess there, and has no prizes for guessing that this is Schistosporium. The next principle, which is quite unlike bacterial, is that you may start treatment even when it is not isolated. And also importantly, you may not start treatment even when it is isolated. Okay, so let's see this paradox. So you have the first patient, so she has a gastric and a large duodenal perforation. And if you look at this side, the predisposing factors for invasive candidiasis and what is the prevalence of that. So if you look at all these, these are your standard ones like ICU admission and all these other things, and the usual, MSG01 criteria or Lyon's criteria and all those common scoring systems which we use, but that all gives you only a prevalence of only 5 to 10% at best. But look at high risk biliary surgery or a gastroduodenal perforation. So there the prevalence is as high as 30%. And 30% might be a physician accepted threshold for starting empiric therapy. So remember that all these points will help you to know that I am going to start empirical therapy or not. Maybe you will want to confirm that with a beta-glucan, but this is the way you can approach it. The other patient here is a patient who had community acquired pneumonia, and as you can see, these are two large, dirty, necrotic looking abscesses. And what is the sputum? The sputum is showing pus cells, yeast occasional, and what has grown there is a rich growth of E. coli and Candida species. So in the first instance, you have that high prevalence. So you have a gastroduodenal perforation. So you have not yet even isolated Candida, and you might elect to treat. And in the other instance, is Candida a cause of community acquired pneumonia? No. Certainly not these kind of lung abscesses. No. And neither is E. coli. So actually this was a case of melioidosis. Okay, and this was because the patient had spent time in the hospital. The patient had probably got colonized with all these things. So it's very important to keep all these things in mind. Now, obviously, diagnosis of invasive fungal infections is often based on a combination of host factors, the particular syndrome, the radiologic findings, and maybe non-culture based tests, which we also call as biomarkers, but also on histopathology and culture. And also, because the diagnosis is based on 3-4 pillars like this, there are different levels of diagnostic certainty, and therefore we call them as proven, probable, or possible invasive fungal disease. Now let's take a little detailed look at these. So this mainly comes from the EORTC, MSGRC guidelines. So case definitions rather. So what is proven invasive fungal disease? So no prizes for guessing. That this means that you have found a fungus in a sterile site which is obtained by a sterile procedure. So that excludes what? So it excludes BAL. Remember, BAL is not a sterile procedure. Similarly, a sinus specimen, sinus means a discharging sinus, and from the urine, these are not considered as sterile specimens. Or from a freshly placed catheter or a drain into a body cavity which is normally supposed to be sterile but is showing the disease process. Remember that each word here is very, very important, and seemingly, slight changes in the wording will create a profound difference in the meaning. Okay, so it's very important to understand every small bit of this sentence. Or it is from a blood culture which is showing a yeast or a mold like fusarium and some others which are there in your MCQs also. Or it is a cryptococcal antigen from a CSF for Cryptococcus. Or finally, if this is a non-sterile site. So if it is a sterile site, you just need to get the fungus. But if it is a non-sterile site, it is essential to show that the fungus is also invading the tissue and there is a tissue reaction around it. Okay, so now you need a biopsy from a non-sterile site. So if a sinus specimen, just a surface culture showing you calcofluor or even growing something, may or may not mean anything. You need to show that there is a histological evidence of that fungus inside the tissue and there's a tissue reaction or a tissue damage around it. So it's from a non-sterile site, you need a culture, because without a culture you will just call it as invasive mold disease if you don't know what is that mold. When you have a culture, then you can call it as invasive aspergillosis or whatever else. And so histology. So why have I drawn this like this? So you have just one single thing, and that pillar is so strong that this diagnosis cannot be shaken. It is based on one of these things, right? On the other hand, trying to have this kind of a biopsy is not very easy because you will have so many problems with the patient, and because of his physiological state, you may not be able to obtain the biopsy. That's because you can't do it for aspergillosis, and like you saw, there was clearly insensitivity of the first peripheral blood culture in Atul's case. Okay, so you had something, the patient had a proper syndrome and yet peripheral culture was negative. So there is insensitivity of the blood culture for Candidemia, and it's difficulty in obtaining the biopsy for maybe from the lung or from the brain and so on. Hence, we entertain lower levels of diagnostic certainty, and these we call as probable and possible. And obviously they are based on 3 pillars. So what are those 3 pillars? You need to have good host factors, you need a clinical radiological syndrome, and you need a mycological test. And then you call this as probable IFD if all the 3 are present. But remember that each of these, the host factors, the clinico-radiologic syndrome, as well as the mycological test, all of them have difficulties. They have limitations, they are evolving, they need continuous validation, and therefore the size of each of these pillars is still not adding up to that first big pillar that I told you. So this still remains probable. Okay, it doesn't become proven. Now let's go further. Now, if you have a problem that you have not even done the mycological test or it is coming negative, then what is it? Then it is only a possible IFD. Okay, so you have now only 2 pillars. The third pillar is not there. So in this situation, when you call it as possible, remember that the host factors and clinical criteria have to be fully consistent. Alternative etiologies are excluded. That in clinical practice is not a very easy thing to do, especially if you have lung and various other things involved. And an attempt should always be made to upgrade the diagnosis. And finally, all these proven, possible, proven, probable, possible are meant for enrolling patients for clinical studies. Okay, to have uniform case definitions. For a clinician, for you and me, even lower levels of certainty might be enough to take therapeutic decisions. Okay, so you can't only base therapeutic decisions on these. It's very similar to your SLE criteria and so on. You have a big list of SLE criteria. Now, in the beginning, the patient is not going to meet all these. And yet the patient, we know for certain, is going to have SLE. So the disease will evolve and the criteria will come. But for a therapeutic decision, it's a little different thing which you need to keep in mind. So now looking at each of these factors, if the host factors are not fully consistent, alternative etiologies are not easily excluded, the pre-test likelihood of the disease is now going to be less. And so even if the biomarker is positive, what can be the interpretation? The biomarker can be falsely positive. And do we have reasons for that? Yes, since morning we have heard there are so many reasons for the false positive biomarker. So now why have I shown that each of these pillars is becoming thinner and thinner? Okay, so in this situation, it is going to be very difficult. So let's spend a moment talking about the utility of biomarkers. So Shivprakash has told us about all of them, but remember that they are, it's just a small component of that fungus. So by itself, it is not indicator of a disease. They only assign a certain probability of the disease. Also remember this important fact that they are quantitative. So it all depends on what you and me consider as the threshold. So is it 0.5, is it 1, is it 0.7, is it 80 picograms? What is it? And who has made these criteria? Okay, so it depends on how sensitive or specific you want those criteria to be. If you keep the criteria very, very sensitive, they'll become positive even before the clinical signs and symptoms come. And the other way around, if you keep them very high. Okay, so that is something which we must understand. So the positive predictive and the negative predictive values are determined by the pre-test likelihood, that is the prevalence of the disease, and that depends on your host factors and your clinico-radiological and other syndromes. So now, if to be useful, that non-culture based test must either elevate the post-test probability above a certain threshold or bring it down below a certain threshold. Is it understood? Like in the first case, gastroduodenal perforation, 30% prevalence. If I do a beta-D-glucan, it will make it say 90%, but I already have 30% which I am going to start treatment in any case. Okay, and it will be all the other way around if it is a very low prevalence. Now let's apply this to Candidemia. The standard of care is utilizing a clinical prediction rule, and there are so many such rules there to identify high risk hosts. But remember that even then you are identifying only 10%. It's nowhere near that 30% or something like that. And then you monitor the BDG or the PCR for a biomarker based trigger, which you will call it as a preemptive therapy, or use the clinical prediction rules themselves to start empirical therapy, but use the high negative predictive value of the beta-D-glucan to stop or to de-escalate or whatever as part of stewardship. There is a small entity, sometimes it's interesting that you can have somebody with Candidemia who's persistently beta-D-glucan negative. Okay, and there are a few causes of that. But and there are some Candida species which are poor releasers of beta-D-glucan. I think Oris is also one of them. Okay, so these can little confound all this kind of approach of a de-escalation approach on the basis of a negative BDG. This is a recent study and I think it's very interesting. So here they've looked at optimizing the use of beta-D-glucan in PCP, in HIV and non-HIV patients based on their pre-test likelihood. So we had a recently a case who was a SOT recipient. So that gives him a score of 2. He had a good compatible sort of infiltrate on a scan that gave him a further score of 2.5. His LDH was normal. Okay, so his score stood at 4.5. So if you look at this leaf plot, which is a nice way of looking at it, he had a score of 4.5 that gave him a pre-test likelihood. Pre-test I am referring to is the BDG of only about 30% or 33%. Now if that BDG would come negative, his post-test probability would again remain roughly in that same range. However, if it were to come positive, which it did in this patient, then his post-test is going to coming close to 80%. Okay, so in this patient where that BDG is going to be so helpful, which is making the post-test likelihood, then you can of course confirm it with a microbiological test, like you try to do a smear, GMS staining, PCR, and all these things. But this can be a nice way of utilizing this biomarkers. Then we have something like prophylactic, preemptive, and empiric strategies. And these are, we don't sort of give so much importance to these strategies in bacterial infections, but we do it in fungal infections. Why? Because they have a more predictable occurrence. So giving you some handle about what might be the pre-test likelihood. They have greater diagnostic difficulties, and we saw some cases on that. Higher cost, poorer outcomes with delayed treatment. Okay, so what are these three important strategies? So if you just have a risk and nothing else, then it is called as prophylactic. Okay, so look at the first row, there is just a risk. So, but if you follow that strategy, then you will be ending up treating a very large number of patients and so many other problems. And sometimes this is derisively called as a fear-driven approach. Okay, I'm not specifically written that on the slide, but yes, that is one of the things. On the other hand, if you have a risk and you also have a biomarker positive, then we would probably call this as probable IFI. And then, but here the test performance should be good, and there might be increased cost of monitoring, but at least you will reduce empiric therapy. So, you know, this, supposing in the context of a neutropenic patient, you keep doing galactomannan every 3-4 days. So cost of monitoring will go up, but you will be able to catch the patient very early. Then take the next. So there is a risk, and there are fever and focal signs, which are, means some clinical syndrome is there. So here we would call it as possible IFI, and the therapy that we would embark on would be called as empiric therapy in this situation, also called as a fever driven approach. In the previous one, it would be called as a diagnosis driven approach. However, remember here, there can be many other causes for this syndrome. So if you don't have the biomarker, again you are in a problem, because one is it might be too late, or the polymicrobial infections could occur. There could be other causes why he's having fever and other symptoms. So it might not even be a fungal infection. So it's really becoming a very difficult situation. And finally, regardless of anything else, if you have found it in a sterile site and you're sure that this is obtained by a sterile procedure and all that, then it is proven invasive fungal infections regardless of any other factors, but then that might be too late. Now this has been talked about the biofilm, and Atul's case also illustrated that issue very well. A little more discussion on that. So fungi have this property of producing biofilm, and that's not unique to fungi. I mean, there's so many other bugs which would also do that, you know, Burkholderia, Steno, many others are there. So what is this biofilm? You know it very well, though it is all this sort of polysaccharides and so on. And it is just a simple, it's too simplistic, I would say, to consider that there is a penetration barrier. It's not just that, because these fungi or other organisms which are associated with biofilms are genetically at a different phase. Okay, so different genes are getting expressed for environmental hardiness and not really virulence, but resistance to organisms. Okay, the biofilm content actually increases with the glucose content of the medium, and that means diabetics in urine and all that are going to have more biofilm. Interestingly, the biofilm shows organisms show higher content of beta-D-glucan. Okay, now what does that mean? And that is the reason why the MICs in biofilms for echinocandins, which are actually inhibiting the beta-D-glucan, is actually lower than in the planktonic. And that is what Atul was saying just now, that even though parasilosis is having that, the echinocandin efficacy inside the biofilm might be actually very good. Okay, but look at what has happened there. On the other hand, there is upregulation of the glucan genes as well as efflux pumps. So efflux pumps are the ones which are creating a problem with your azoles, and therefore the azole MICs in biofilms are so high. Okay, much higher than before. And there might be some downregulation of sterol genes. So when you don't have all this, then you can't remove that because of some reason like the relatives or the patient or whatever it is, then there is a recourse to using antifungal lock therapy, which this was one of our very old posters. But look at the conclusions there, that we had this, we could salvage them in salvage the catheter in a good number of patients to achieve that particular aim. Like you had this patient who was going to get a transplant, renal transplant, within a short time. So that short time I can probably work as a bridge before he gets transplanted, and then the port is not port, the hemodialysis catheter is got rid of them. However, remember, because this alternative is there of ALT, that should not prompt, or that success may prompt clinicians to be complacent about infection control measures, which should never be the case. Okay, so don't pay attention to infection control. Make a ID reference, that guy will come along and give me a antibiotic lock. Okay, this is should never happen. Okay, so keep that in mind. So similarly, we have actually used lock therapies in CSF, Omaya reservoirs and CSF shunts, and these have been published. And in, say, for example, there is going to be a huge problem if you have a Candida auris shunt infection. Okay, because the only drug which you are going to use for that is a echinocandin, which does not have very good CSF penetration. So in this particular situation, we could successfully treat it. But these are, remember, last resort strategies. This is not to be offered for every patient. Now, this is a recent paper from Jackme's group, and that is creating a very big problem, in at least in my mind, because if you look at it, what they have done is Candida auris biofilm MICs across different clades. I think there is a question about which clade is there in India, and I'm sure you have come up with the right answer. So this is the clade from India, and look at the biofilm MICs. So I was all along thinking that echinocandin biofilm MICs are very good, but here it says that it is not. So that was all for Candida albicans. Okay, so albicans and auris is different in many myriad different ways. So they are different as compared to all the Candida albicans from older reports. And different MICs were isolates from 5 different countries in 3 different continents. I have only shown you the one from India. And likely there are a lot of genomic, proteomic differences between Candida auris and all the other Candida species. There might be differences even among the clades of Candida auris. Yes, Parikshit. I fail to understand. I was under the impression all this time that liposomal will be better, but it is not, according to this study also. Aruna Log, any comment on this?
You see, liposomal versus conventional, as in vitro or activity wise, there is no difference. Right. The only difference is that how much they can for the toxicity or the penetration.
No. Here the question is about the using as a lock.
As a lock wise, it's a very difficult.
Yeah. See, if you look at the previous one, that shows that. See, where is this? Look at deoxycholate and look at liposomal. So liposomal shows better biofilm MICs as compared to deoxycholate. Although deoxycholate, I think, is also a sort of a saponificant or some sort of a dissolver of something, because that deoxycholate component is meant for that. But still, that is so much different, and here it is different. So after that, I am having some doubts whether we should be using it or not. But yes, we have used it, and clinically it has worked. But this is a study which is available.
In our study, when we studied about fungizome, and that is compared to deoxycholate, we saw that our fungizome has got better penetration and lower MIC.
In biofilms, no? As compared to planktonic. That is there, but this is for biofilms, so that is very surprising. So finally, should we use some non-antifungal? Okay, so look at this particular thing, NICE. So it is nitroglycerin citrate and ethanol. Okay, so this combination probably will work regardless of whether it is auris or whether it is anything. This can really probably take care of everything. Now, this was also discussed in the morning. So, what is the role of the immune system in disease causation, expression, progression, and recovery? All these words are also very important. And what's the relevance? And Pradeep also told us about all these problems, that what is the relevance of MIC, interpretation of clinical breakpoints still remains a little bit uncertain. Okay, so this is a classic example of IPA in neutropenic versus non-neutropenic. In neutropenic, there aren't neutrophils, so you have more fungus, you have a larger zone of infection, and more mycelia, so more of the tips of growing mycelia, so more galactomannan is produced, more galactomannan is going to enter the circulation, and there is going to be less polymorphs in the circulation to catabolize that galactomannan. So it's not surprising at all that you will have a higher sensitivity of serum galactomannan in neutropenic patients. You will have a larger dense nodule, you will have a surrounding halo. Okay, so all that is telling you that the organisms are having an upper hand. On the other hand, in non-neutropenic, it is the inflammatory response which is the disease. Okay, so there you have consolidates like in the panel there which I have shown you, and another where there isn't much of a halo sign. So the halo sign becomes less, nodules are there, but consolidations are also seen in non-neutropenic patients. So you can possibly see how the immune system determines the expression of the disease. Okay, so whether you will get a halo, how big will be your zone of the nodule, and how will be your galactomannan in the serum. Also, it plays a very great role in your recovery. Like look at this post hoc analysis of this, I think it is the secure study. So there they found that they've used the isavuconazole, which is sort of touted as the one of the best drugs and all that, and yet if you see, mortality is entirely dependent on recovery of neutropenia. Okay, it's 5% versus almost 50%. So it's the neutrophils which is really playing such an important role in the recovery. And then these are a few examples where you can have a recovery of the immune system creating the problem or the disease. So here you have a patient with cryptococcal meningitis who was started on ART too soon, and he developed a severe hemorrhagic enhancement of his meninges. Okay, and previously not seen cryptococcoma was now started making its appearance in that thing. So this is an inflammatory thing. And the same thing again occurs with hepatosplenic candidiasis. Okay, so the patient, now this patient also has had many rounds of chemotherapy, no? Your patient. So who knows that such a patient could have had neutropenia, candidemia earlier, would have had seeded his liver, spleen, kidney and all these things, and at a later point when his recovery from neutropenia has occurred, he will get high grade fever and altered LFTs, and then you'll start seeing this target lesions in the liver, spleen and kidney. So this is the syndrome where immune system is playing such a big role in the expression of the disease. And finally this, Pradeep told us about this. So the generated MICs depends on a lot of lab conditions and all that. But also remember one important principle. Microbiologists would really like us to divide them into susceptible versus resistant. But just pay attention to this fact. So is it really correct or not? What it only tells you that at this level of MIC, the chances of success are less, or at this level, the chances of success are more. And that again, he told about the 90-60 rule. Okay, so that is an important thing. So clinical breakpoints have been established as a yes-no parameter. Okay, so it divides it into black and white. But actually speaking, it's not like that. Varying levels of MIC yield different probabilities of a response. So once the MIC is beyond a certain limit, we say that the chances of success are less. We cannot say that it can never happen. Success will be determined by many other factors which ultimately determine the outcome. And that is a multifaceted phenomenon. So what are they? So drug penetration, time of initiation, how soon have you started beginning your treatment? Did you use combinations? What are the conditions in the tissues? Source control, tolerance, cost of resistance, and all these things. These are also important in determining the final outcome. Also, we know TDM is an important tool in the management, and I think there is going to be another talk on TDM, so I'll rush through this. That there are definite benefits of using that, but let's take that quick example. So this is a post-COVID-19 mucormycosis was diagnosed elsewhere. I mean, nobody would think that this is TB, but they did, and started him on HRZD for 15 days. Then he presented to us, diagnosed it as COVID-associated mucormycosis. Amphotericin B was not available at that time. Isavuconazole was to be started, but remember that rifampin is a strong inducer of CYP3A4 and 5. So we had to give him a high, keep up the high dose of isavuconazole with the hope that you could still have some levels, and yes, we were able to achieve good levels very soon of 2.97. So this also was discussed. So do you need the TDM for isavuconazole? I will raise both my hands. It is absolutely needed according to me. It was stopped, but still the inducing effect will continue for 2 weeks. So the patient has already received rifampin for 15 days. After he comes to us, we can say definitely this is not COX. So you stop, but still that effect remains. So for first 15 days, I am worried whether I am going to have levels or not. Okay. Now the use of combination therapy is established in some IFIs, and maybe an induction de-escalation strategy may emerge in others. And obviously one would like to transition to oral, less toxic, less expensive agents, and that should be an established practice. So about cryptococcal meningitis, there is no doubt the early fungicidal activity is best with this combination, and that is really the standard of care, although now newer things are coming up. For aspergillus and for mucor, this whole issue is a little murky. Okay, so we know that VORI is the most appropriate option, but still better treatment is an unmet clinical need. And this point also came up in Pradeep's talk that echinocandins are not cidal, so they can only be used perhaps in combination. Where would I think of using a combination of VORI plus an echinocandin? In maybe such a patient, where the initial levels of the azole are not going to be achieved. So rifampin, or where voriconazole resistance is significant. So I don't think it's really significant in India. Shiva Prakash also has a similar incidence, about 1% or so, and this is another study which showed about 1% resistance. Although in Netherlands and so on, it is about 24-25%. Okay, and maybe parts of UK. So Dutch guidelines actually tell you not to use voriconazole alone, and that's what I'm coming to. So there has been only one small study, Karen Mar's study, in hematologic malignancy population, where adding an echinocandin to the azole gave a little bit of a good some benefit. So there was improved survival, which was statistically significant only in those patients who started early treatment, who had a biomarker aided diagnosis. And there was one, this is a nice study called as IA Duet. Okay, so this is a trial has been terminated because of poor patient accrual and many other problems. So really there's not going to be any control trial which is going to answer this question, whether combination therapy for azole susceptible aspergillus is going to be useful. So an RCT to settle this issue is unlikely to be conducted. But yet we do use combinations for various reasons in, say, mucormycosis. So for example, in this patient, he had, this was before COVID, so he had rhinoorbital mucormycosis. The patient just refused to continue any treatment further and was insisting on discharge. And does this occur in a significant proportion? Answer is yes. So there is a FISF study led by Atul, which showed that almost 1/4, means 25% of them wanted to go away. After hearing about the cost, about the surgery and all, bhag jayega bas. That is what people would do. So what will you do for such a patient? So you'll probably begin treatment with an amphotericin preparation and then probably continue with an azole. So these might be some of the situations where you might want to use a combination therapy, although this is also changing. So you could use Lomatospora prolificans is a very notorious bug. Similarly, Fusarium. So here there are scanty data to really guide whether combination therapy should be used, but there is this rare mold guidelines from ECMM which you might want to refer. Combination therapy, again, this was discussed. Atul said that you could use amphotericin plus or minus 5-flucytosine for endocarditis or the large dose and so on. So, and these can be other. In the urinary tract, again, if it is a azole resistant candida, you have a problem. So maybe you can use some combination. Final point is about duration of treatment, and that is also not a very easy question to answer. So for Candidemia, we know that it is 14 days, and we do that because we want to control metastatic foci, and this is an organism like Staph aureus which can also produce easily metastatic foci. So you're giving this 14 days even after blood is cleared, because you are anticipating that there might be microscopic foci somewhere or the other, and that's why this 14 days. But also remember that it's after resolution of signs and symptoms. You have ruled out metastatic involvement. In neutropenic patients, there has been a recovery of the WBC count, and maybe it is lifelong for fungal prosthetic valve endocarditis. Okay, not necessarily for native. For cryptococcal meningitis, again, it depends on how long will be your induction, consolidation, and maintenance. But that maintenance will continue till the CD4 has gone up to more than 100 for more than 6 months. But in patients who are non-HIV, there is a difficult question. So at least 1 year, maybe longer. In SOTs and those who are apparently normal people, how long will you give that? So difficult. For invasive mold disease, again, very difficult. And this comes from the old ESCMID guidelines. So 3 weeks to 50 weeks. So look at the range. So it is just too much. So everything depends on your clinical, radiological, microbiological improvement. That is the one which is going to help you to decide. So you must have stabilization. Now that improvement is also a word which is difficult to use clinically, because when you look at imaging our mucor and other things, it's not very easy to say that it is showing improvement. Even if it shows stability, it is good enough. Sometimes we use criteria that that particular tissue which you are seeing is enhancing well on a contrast MRI. So if it is enhancing, it tells you that yes, this is not infarcted. That means the mucor is probably not there. But these are difficult things. I have also used PET scan sometimes for lung as well as for cranial involvement to see whether activity has reduced. But what PET is telling you that inflammatory activity has reduced. It can't tell you whether fungus has gone. So these are all multiple sort of things you need to put together to tell what should be the duration of therapy. And if we have achieved a good PK/PD index, then there is a reassurance in my mind that it is likely to have worked, and of course immune recovery. But for knowing whether I have achieved the PK/PD index, I need to know the drug level, I need to know the MIC. Okay, and also do some extrapolation to the site of infection. So these are not very easy things to do. So I'll close by saying that these are all principles which are gleaned from practice and following the evolution of testing and treatment strategies. However, remember that these are all diseases of medical progress, and we are going to see more immunocompromised patients, more interventions, maybe more resistant fungi, but on the other hand, you are also going to see better and new antifungal agents. So this kind of a seesaw of challenges and solutions will go on, but I've purposely I showed you the principles. So these broad principles are likely to remain constant and will continue to be helpful while we look at the future. Thank you. No questions? Everyone is hungry, looks like.
Thank you, sir, for your insights. We are pleased to welcome our next speaker, Dr. Parikshit Prayag, consultant transplant and infected disease at DMH Pune, a distinguished academician and dynamic clinician. Dr. Prayag serves on an editorial board and key national committee, including the Transplant ID and Fungal Infection Study Forum. He is a respected reviewer and has been invited to speak at national and international conferences. A recent recipient of both the Presidential Citation from ISCCM and a Young Achiever Award from IMA in 2024. We are privileged to have him present an interactive case discussion on mold infection in the ICU. Welcome, sir.
So thank you for the kind introduction and thank you for inviting me. Thank you, Dr. Jacob, for the lovely hospitality. I'm going to be talking about mold infections in the ICU. So we'll be talking about 4 cases. Throughout the morning, we've seen what the principles are when it comes to diagnosing these infections. What are the challenges, when it comes to diagnosing and treating these infections. So let us see how we put this all into clinical practice. Now in the ICU, the challenges are different. So as we have seen, there are differences in mold infections for the specific cohort of patients. So when you're dealing with a hematology oncology patient or a transplant recipient, the approach is going to be different. When you're dealing with a community acquired fungal infection, the approach is going to be different. So let us highlight some of these issues and what we can do and how it becomes complex and how do we navigate our way through this complexity. So my first patient is a fairly young, I would have to call 43 young. So a 43-year-old male who presented with 5 days of cough and 1 day of breathlessness. So he is coming in from the community. He is fairly healthy, no real comorbidities, not a smoker. At least that's what he told us. He was admitted to the ICU and required about 4 to 6 liters of oxygen by nasal cannula initially. Now his upper respiratory swab, the nasopharyngeal swab, was positive for influenza and he was started on oseltamivir but was also started on ceftriaxone and azithromycin. He was requiring about 4 to 6 liters of oxygen. Initially the labs don't tell you much. His procalcitonin was negative. His CRP was not very high. WBC count was around 7,000. So it did improve over the next 72 hours. However, on day 4 of hospitalization had increased oxygen requirements. Now his CRP at that point of time increased to 89, which was in the 30s, and WBC count didn't change much. So his WBC count is still around 9,000, which was around 7,000 initially. Procalcitonin also hasn't jumped up much. He was started on piperacillin, tazobactam and doxycycline by the ICU team because of this worsening, and there is some increase in the CRP. 24 hours later, he was intubated. Now his ET secretions were sent and a galactomannan test was run on that, and that came back as 1.3. His serum galactomannan here is 0.4. Blood cultures have grown staph hominis in 1 out of 4 bottles. And the ET cultures are actually growing Candida, which is a surprise because, as far as we knew, he was a young patient without any comorbidities. Of course, he has spent now 3 to 4 days in the hospital. So how many of you here think that, we have fair evidence for post-influenza or influenza-associated pulmonary aspergillosis, or IAPA as they call it? How many of you will be comfortable at this point of time in adding something like a voriconazole? How many of you would want further diagnostic workup on this patient? So how many of you think that we are fairly comfortable in calling this situation influenza associated pulmonary aspergillosis? Remember, the only marker that we have positive here is a proximal airway sampling. This is a non-invasive sampling that we have done. So ET secretions, the galactomannan is 1.3, serum galactomannan is negative 0.4. Now we have looked at the criteria in the morning. If you are looking at, of course, if you have the first thing to do here is to define the host. Now in these patients, you may not have the classic host here, right? But any patient who has influenza or COVID is considered to be someone who has the entry criteria or someone who is at risk for pulmonary aspergillosis. So how many of you will think that this patient now satisfies the criteria of aspergillus? We don't need further sampling. So everyone thinks we need further sampling at this point of time? Okay. That's interesting. So let's look at the diagnosis of influenza associated pulmonary aspergillosis. I'll leave the tracheobronchitis part aside for the time being, in the interest of time. Let us focus on the pulmonary or the parenchymal aspect. So how do you define IAPA? Now, as we have seen, proven is when you have tissue that is showing or growing the fungus. But for probable, if you have a pulmonary infiltrate, and here a pulmonary infiltrate is difficult to interpret because this is going to be in the background of most of the times severe respiratory viral involvement. So these patients invariably will have ground glassing interstitial infiltrates. So if you have any pulmonary infiltrate and if you have a serum galactomannan more than 0.5 or a BAL more than 1 is how they have tried to define influenza associated pulmonary aspergillosis. Or if you have a cavitating infiltrate, now it becomes a little bit more specific there. If you have a cavitating infiltrate in the setting of a viral infection or a respiratory viral infection, and you have a positive sputum culture or a positive tracheal aspirate culture, so then they have said that a non-invasive sampling or a proximal airway sampling is okay if you have a cavitatory infiltrate. So now coming back to our patient, the next thing that we did was a CT chest. Does the CT chest lead you anywhere? Not always. This is a patient. Now, one surprising thing is he has some crazy paving there. He's not someone who has comorbidities, but you don't get much, and not anything specific from the CT scan. It is pretty much showing bilateral ground glassing. So look at the literature published. This was a good study which showed the radiographic findings of patients who had viral associated pulmonary aspergillosis, so both influenza as well as COVID. And all of them, if you look at the 24 patients, all of them had diffuse reticular or alveolar opacity. So that's understandable because that's coming from the underlying viral involvement. How many of them had wedge-shaped segmental or lobar consolidations? Quite a few of them. How many of them had the classic findings of invasive pulmonary aspergillosis that we see in hematological malignancies or in the setting of post-hematological stem cell transplants or solid organ transplants? The halo sign, cavitations, air crescent sign, very few of them, 12% halo sign, 20% cavitation, and none of them the air crescent sign. Tree in bud, around 30%, but that's more to do with airway involvement. Bronchial wall thickening, interestingly 30%, and pleural effusion was 37%. So, CT scans at this point of time may not help us in really defining who is a patient of post-viral aspergillosis, or in this case, influenza-associated pulmonary aspergillosis. On the other hand, if you look at proximal airway sampling, now the proximal airway sampling is actually an interesting way of diagnosing aspergillus. If you look at the COVID data and if you look at COVID guidelines, then they said that if you had a tracheal aspirate or if you had, let's say, a proximal airway sampling which was not invasive, you would need a very high value. More than 4.5 was actually considered to be positive. Or you should have 2 samples from the tracheal aspirates which are having a galactomannan of more than 1.2. Subsequently, there has been some literature which has been published which shows that actually proximal airway sampling is a good way of making a diagnosis for viral associated pulmonary aspergillosis. But again, as sir mentioned, in the previous talk, it all boils down to your pre-test probability. So what is the probability that actually this patient is clinically and radiographically likely to have aspergillosis? The problem here is that in these patients, it's not always easy to define the pre-test probability based on the clinico-radiographic picture, because as we have mentioned, these are patients who have had a lower respiratory viral involvement. These are patients which could have very non-specific CT findings. So it boils down to the prevalence of aspergillosis in this type of a population. Now, if the prevalence is more than 15%, you could use low thresholds or low cutoffs for tracheal aspirates as well, as we were discussing with Soman sir in the morning. So if you have a patient who has a tracheal aspirate or a non-invasive or a proximal airway sample which is showing a galactomannan of more than 0.7, and if you have, let's say, a clinical scenario in which the possibility or the prevalence, I should say, of aspergillosis is more than 15%, then it's a significant number. Now, what is the prevalence of aspergillosis? In meta-analysis, it is almost 19 to 20%, the prevalence of aspergillosis in the setting of severe influenza. Add to that what Arunlok sir showed us in the morning, our mold burden. Add to that some of these patients may have been treated with steroids. So the different comorbidities, some of these patients may have uncontrolled diabetes. Now, if you have definitely aspergillus in an immunocompromised patient, then it makes it even more likely, or the prevalence is expected to go up. So that's why, proximal airway sampling is I mean, I would say a good way of diagnosing it, but given or provided you consider all the factors there. So with this, we actually started him on voriconazole, but with this CT picture, we actually wanted a better way of diagnosing it. Or I wouldn't use the word better, but a more reassuring way of diagnosing influenza-associated pulmonary aspergillosis. And again, the respiratory biofire panel was negative. BAL galactomannan was 1.5. So voriconazole was added at that point of time. So this is a patient in whom there is worsening in the second week. He has initially improved in response to oseltamivir, now has developed worsening. So far, your entire bacterial workup is negative, and initially you had a tracheal aspirate which was giving you a galactomannan which was around 1.3. So I think proximal airway sampling is a very interesting way of diagnosing viral associated aspergillosis. Now that's not to say that in any patient, if you, yes sir, propensity aspergillosis. True. Now that's not to say that in any patient you would send a tracheal aspirate for a galactomannan and look at the galactomannan values and look at that. So that's why the entry criteria are important. What is the whole kind of host, or what is the kind of patient that you're looking at. No, so second one, how do I go back here? Yeah, this 1.5 is BAL, but the initial one which was done is ET secretions, which is giving you a galactomannan of 1.3, and the serum galactomannan is 0.4. That's what I'm saying. In COVID, what they gave the cutoff for ET secretions or for tracheal aspirates was 4.5 for a single sample and more than 1. Yeah, exactly. So that's what his question is. No, that was for tracheal aspirates. Right. For non-invasive sampling, it was non-invasive sampling. Right. So they. Right. Non-BAL, true. So basically it meant that there is no invasive sampling there. So whenever there is no invasive sampling, that was the cutoff that was given. Now specifically your question was what are the cutoffs there. So that they said was 4.5 for, like he said, non-BAL specimens if you are using a single value, or more than 1.2 if you are using two values. Now this later publications look at tracheal aspirates and look at galactomannan in that setting and say that more than 0.7 could be useful, provided you have a good pretest probability of aspergillosis in that setting, and more than 15%. But like we said, already the prevalence is more than 15% of influenza associated pulmonary aspergillosis. So it could be an interesting way. I'm not saying that in every patient you should do tracheal aspirates and try and diagnose aspergillosis in that way, but I feel it is an interesting way of diagnosing it, and that's what sir was saying in the morning. Exactly. Exactly. So that's why I would still do some other tests, sir. I mean, that's why we did go for a BAL. Exactly. Right. Yes. Right. Yes.
They are recommended because it becomes much easier, because there was the evolving process from there.
Right.
At that time, repeatedly multiple papers have come out to the evolution.
Yes.
And those evolution ultimately culminated into that particular consensus guideline.
Yes.
And consensus that we should follow that one instead of previous.
True. True. So influenza-associated pulmonary aspergillosis, when they have tried to define it through the consensus guidelines, they have talked about the serum as well as BAL, or obviously positive BAL cultures, or if you have a cavitating infiltrate which is not attributable to any other cause, then they have looked at non-invasive sampling like positive sputum cultures or positive tracheal aspirate cultures. So again, perhaps the take-home message is that we have to know the host like in any other fungal infection, and the other thing is that if you do have a non-invasive sample which is positive for a galactomannan, then yes, its performance cannot be totally ignored, but it is probably worthwhile to follow it up with another test in order to really find out if your patient truly has aspergillosis. Yes. Agreed. Agreed. You know, I mean, and especially because he improved initially and then worsened. So whether we are looking at a superadded bacterial infection or a fungal infection, or exactly out of that bacterial was ruled out, so you would still narrow differentials to an inflammatory worsening versus a fungal process. But both the galactomanins were at least, you know, done after he worsened. So those were in the initial galactomanins, and the CT was also done after he worsened. So we really don't know how much of a change it was from the baseline. So my next patient is a 42-year-old male who had FLT3 positive AML, who underwent a matched unrelated donor stem cell transplant 4 months prior to this current admission. And then he presented with diarrhea, nausea, vomiting and fever. So we'll look at the timeline first. So he underwent a matched unrelated donor stem cell transplant. 3 months later, he was found to have GI GVHD. So he was put on steroids, and as with all transplant patients who have GVHD and who are put on steroids, he was put on posaconazole prophylaxis. Now what happened was that he started having watery diarrhea 2 weeks prior to this admission. So 3 months post-transplant, he gets diagnosed with GVHD, is put on steroids, and then about 2 to 3 weeks later, he starts having watery diarrhea. And then 10 days prior to the current admission, he visited an outside hospital. They did a stool biofire panel or a multiplex panel, and that showed norovirus and C. diff. Also his C. diff assay was positive both for GDH as well as toxin A. So, started on nitazoxanide. I won't go into the details of how useful that is for norovirus, as well as oral vancomycin. There was some initial improvement in the diarrhea after starting therapy, but after a couple of days, started noticing worsening of the diarrhea again, this time accompanied by vomiting. He also noticed that his stools had become coffee ground in color. So, this is where we are. Diarrhea post stem cell transplant. Outside PCR shows norovirus and C. diff. He started on vancomycin and nitazoxanide. His diarrhea initially improved and then worsened again, became bloody, also accompanied by vomiting, and was shifted to the ICU. So how many of you here think that, you know, this could be a worsening of his C. diff? This is a patient who has received a stem cell transplant. 3 months down the road, he has had GI GVHD, now has been put on steroids, has been put on posaconazole prophylaxis, has been diagnosed with norovirus and C. diff, both toxin A as well as GDH positive, has been started on oral vancomycin, initially improved and now has worsened. But the important thing here is that the character of the diarrhea has changed here. So now it has become bloody and is also accompanied by vomiting. So how many of us think that this could be the C. diff which is worsening, or it could be going into fulminant C. diff if there are signs of hypoperfusion, if there are raised lactates, and we would work on the C. diff pathway? How many of you think that the GVHD is worsening at this point of time? Now remember, the steroids weren't reduced after he was diagnosed with C. diff as well as with norovirus. So how many of you think that it's the GVHD which is worsening, especially in the face of C. diff being positive? So, you know, C. diff and GVHD have an interesting relation with each other in post-transplant patients. How many of you think that, you know, there could be some other infective etiology which is going on here? So we would look at still something like a CMV, look at something else which could be there. So anyone who thinks that, you know, this is C. diff which is worsening? That one perhaps the most important clue, but I think the other clues here are that his characteristics there. Now it has become bloody and he has also developed new onset vomiting. So these are important clues. So patient was started on IV flagyl by the ICU team. Oral vancomycin was continued. perhaps I wouldn't have done that, but this GI multiplex PCR was repeated, I wouldn't have done that either. This is expected to give you the same result. So it again showed norovirus as well as C. diff, which was positive. His creatinine is slightly raised at this point of time. Now his POSA levels were 0.3, so they were slightly lower than what you would want in a prophylactic setting. Of course, he has many factors at this point of time to give him subtherapeutic POSA levels. He is someone who has now had diarrhea for almost 2 weeks. Sorry, sir. His CMV PCR was 373 copies. What do we make of that? Again, nothing, because patients who have been put on steroids can have low levels of viremias at that point of time. That doesn't tell you that this is GI CMV involvement. That doesn't rule out GI CMV involvement either. So the way to diagnose GI CMV would be to get the GI tissue. Serum galactomannan and beta D glucan, all this workup was done before we were involved. This was all negative, and the stool for ONP was also negative. And these are his endoscopic findings. So you can see large necrotic masses. Now any guesses? This is mucor. So his biopsy actually showed broad aseptate hyphae suggestive of mucormycosis, and the cultures actually grew mucor circinelloides. So that explains a few things. One is that this patient was extremely immunosuppressed. This is a patient who has undergone a matched unrelated donor stem cell transplant, has developed GVHD, is on steroids, is on subtherapeutic levels of POSA with diarrhea, and now is breaking through with mucor circinelloides, a species that is well known to have high MICs for posaconazole. So if you look at the comparative studies between amphotericin and posaconazole, this particular species, there are a few species wherein you would be worried about the MICs of posa and isavuconazole. This is definitely one of them. So again, this was not a good situation, GI mucormycosis breaking through on POSA in a patient who has GVHD, who has active C. diff. In a post-transplant patient, again, the prognosis is going to be poor. So he was started on liposomal amphotericin. Surgical consult was placed, but there wasn't much that they could do at that point of time. He rapidly developed septic shock, also had carbapenem-resistant Klebsiella in his blood, and with worsening shock, he actually ultimately succumbed.
Because of the so much high mortality here.
Right.
So, going to suspect, how to suspect, and what we can do to improve the outcome, we need to discuss about it.
Absolutely. So I think one important thing is, early endoscopic interventions for these patients, because there is no other way you can really diagnose mold GI involvement, and especially in a patient who is high risk like this and who is having bloody diarrhea and who has got all the risk factors, although technically he is on POSA prophylaxis, but who has got all the risk factors. One thing to push for would be early interventions, because again, if you see the workup that was done prior to his mucor being diagnosed, a lot of it wasn't relevant, like sending a CMV PCR in the blood, or sending a galactomannan, or doing those sort of things, or repeating a biofire panel. That's really not going to give us much when we have a worsening patient in whom we know that to begin with he has C. diff and norovirus. So I think that can be one thing which can be discussed about, that early invasive sampling in these type of situations. So his gut GVHD initially when he was put on steroids was controlled, but of course in uncontrolled gut GVHDs we do tend to look at levels. We found that almost 30 to 40% of the total prophylactic levels in our center have been subtherapeutic. Now if you look at gut GVHDs, the number is going to be far higher than that. So my next patient is again a patient with AML who also underwent a matched unrelated donor stem cell transplant. Also developed GI GVHD 10 weeks after transplant, but the case is a little different and it highlights different things. So subsequently developed GI GVHD 10 weeks after transplant, was started on steroids, responded partially. So ruxolitinib was added, also started on posaconazole prophylaxis, and subsequently actually developed transplant-induced thrombotic microangiopathy, or TMA, which is again a terrible thing to happen in the setting of a post-BMT patient. Was given 2 doses of esulizumab, 1 week later, because still he was undergoing the process of looking at his CMVs from a preemptive point of view, he was still under day 100 from his transplant. So 1 week later his CMV PCR was checked and was found to be more than 1 lakh. So you can see here 1,11,000 IUs per ml. At that point of time, he was still slightly cytopenic or slightly leukopenic and definitely severely thrombocytopenic. Now his platelets had really never recovered that well after transplants, although because till the time really he engrafted and the platelet recovery was seen, he developed this transplant induced thrombotic microangiopathy. So WBCs remained on the lower side, platelets remained around 15 to 20, 25,000 on most days. Was given 1 dose of cidofovir at this point of time because the BMT team really didn't want to give him ganciclovir with this type of a picture. At this point of time, there was no evidence of end organ involvement. So was given 1 dose of cidofovir, but his creatinine increased to 1.6. He also had proteinuria. Remember, he has recently been treated for TMA. So it was a complex situation when it came to choosing the CMV drug. So he had cytopenias, he had increased creatinine, he had this aftermath of TMA wherein he was still thrombocytopenic, and his creatinine had increased to 1.6 with proteinuria. So he was started on letermovir. So again, I'm not going to go into the details of his CMV management, but he was started on letermovir. 2 weeks later, the CMV PCR was 23,000. So it had come down from 1,11,000 to 23,000. But he developed cough and breathlessness, required oxygen, and was shifted to the ICU. Look at the CT chest done now. No prizes for guessing that this is an invasive mold. Now the question, now what makes it complex is the setting in which this mold infection has developed. So remember, this is a patient who has broken through, because if you look at posaconazole levels, those levels are 0.9. So those are decent levels when it comes to prophylactic posaconazole. So his posaconazole levels are 0.9. So if you ask, in this type of a patient, what are the factors which are associated with a breakthrough infection, then broadly you can classify those into host related factors, organism related factors, and drug related factors. So what are drug related factors? Either the patient is not compliant with this prophylaxis, or as he mentioned, the POSA levels are subtherapeutic, especially in a patient who has GI GVHD, in someone who has absorption issues or who has been put on antacids, or in obese patients, there could be issues related to the posaconazole drug level. So that could be one factor. There could be other interactions. Now remember, we have put him on something like letermovir. So sometimes these drugs can surprise you. Not that letermovir has an interaction with posaconazole, you can give it, that's perfectly fine. But at this point of time, we need to check the interactions there. But his level was good. So drug related factors don't seem to be at play here. The other factor, of course, could be the organism related factor. So what can break through? So if someone is on voriconazole prophylaxis, of course, he can break through with something like mucormycosis. If the patient is on posaconazole, he might occasionally break through with something like aspergillus, or many times someone on ISA can break out with candida. So it could be organism related factors. Again, the susceptibilities are important, as we just heard. Antifungal resistance, as far as posaconazole or voriconazole is concerned, especially vori, is not very high in our settings, but these could be organism related factors. And last but definitely not the least are host related factors. So when someone is breaking through on good prophylaxis, what are the host related factors? Here the obvious host related factor is development of CMV viremia. So this is a patient who is severely immunocompromised and has had 2 weeks of fairly high levels of CMV viremia, and as we all know, this can predispose to an invasive fungal infection. So host factors could be something like this, or someone who has an indwelling catheter. We just saw a case. So these are host related factors, or someone who is neutropenic, someone who has not yet engrafted, or there is primary or secondary graft failure. So all these are host related factors wherein you could be on the right drug yet break out with a susceptible mold. So that can be seen in some of our patients when they have breakthroughs. So breakthroughs could be host related, drug related, or organism related. So non-compliance, insufficient levels, drug interactions, breakthroughs caused by pathogens which are resistant to the prophylactic drug or outside the spectrum. So for example, breaking through, like we said, with mucor on voriconazole. Or there could be factors related to the penetration. So for example, if you have someone, let's say, on posaconazole prophylaxis, he is now having an azole susceptible candida urinary tract infection. So all these things are important when you look at breakthrough infections. Now his BAL galactomannan is 3.1 and serum galactomannan is 1.9. So clearly he has broken through with aspergillus. So when someone is on posaconazole prophylaxis, what do? You have two options there, either to change him to voriconazole or to change him to, because he's on good levels of posaconazole, to either change him to something like a voriconazole or isovoconazole, or to change him to amphotericin. Now, doing a PCR might help you to a certain extent with species and looking into whether amphotericin would be a good drug at this point of time. The other problem or the other complex factor in this case is interaction. So remember, this is a patient who is on letermovir for his CMV viremia. Now, if you look at the interactions, then if you look at interactions with letermovir, then letermovir increases the exposure to tacrolimus, sirolimus, cyclosporin, but more importantly, it reduces voriconazole exposure. So it has quite a significant interaction with voriconazole. This was also a patient who had mild transaminitis, slightly raised bilirubin. In fact, he was also worked up for VOD and was also thought to have a component of liver GVHD. But that aside, voriconazole and letermovir do have significant interactions. It does not significantly alter posa the least, and isovoconazole it does alter to a certain extent, but definitely not as much as voriconazole. So that is an important factor here. So when you are choosing the drug for this patient, it is about considering various factors for breakthrough. Again, trying to diagnose what the breakthrough is with, and then looking at various interactions and toxicities to choose the drug. So he was actually switched to isovoconazole because he had broken on posa, and vori for the reasons that I mentioned. He did have some liver affection at that point of time and has a severe interaction with letermovir. So letermovir was continued. The other way to think about this is, can we change the CMV treatment? Now he clinically improved. Serum galactomannan 2 weeks later was 0.4. Again, we just heard that galactomannan, unlike BDG, is a good marker to look at response to therapy in this setting. CMV PCR 2 weeks later was also 1850. But unfortunately, so that episode to a certain extent was taken care of. Unfortunately, in the last 1 month, this patient had many complications. So this, what I showed you, is about 3 or 4 months back. But subsequently, he had Pseudomonas bacteremia, had cefepime-induced seizures. He remained pancytopenic, broke through with Klebsiella bacteremia, and just recently we actually lost this patient. But this case again highlights the complexities of breakthrough mold infections on prophylaxis and the various interactions and constraints that you would see in this setting. My last case, just probably for the last 5 or 7 minutes, this is an 18-year-old AML, 18-year-old male with AML who developed febrile neutropenia after his HIDAC regimen. So his induction regimens were actually fairly uneventful. When he was given HIDAC, he actually developed febrile neutropenia. Was started on piperacillin tazobactam, he remained febrile. He developed skin lesions as shown, and his CT chest is also shown there. His serum galactomannan was 0.8. Aspergillus PCR was negative. BDG was 185. Sputum cultures grew Candida again, even though he is an immunocompromised host. We are not going to think of a Candida pulmonary involvement here. He was shifted to the ICU in view of tachycardia, febrile neutropenia, and minimal oxygen requirement. So now his blood cultures grew this. So I think you had also this question as one of your pre-test questions. So what is this likely to be? Fusarium. Fusarium is one of those rare molds which can grow in blood cultures. So his MALDI was done, which actually showed Fusarium solani. So what would you put him on? Again, I think this was also one of your pre-test questions. So what would you put this kind of a patient on? There are not too many situations in which you would consider empiric dual antifungal therapy for molds, and Fusarium is one of them. The reason is that the MICs are also very unpredictable. So if you look at the various species, then you can see here that actually for solani you could have higher MICs for something like voriconazole. So his back to our patient, he was started on amphotericin and voriconazole. His line was removed, and look at his MICs here. So this is the next challenge. How do you interpret these kind of MICs? Especially for molds or for fungal infections which don't have defined breakpoints, and that can arise. This situation can arise for a lot of the fungal infections that we see. So for example, non-Candida yeasts or molds like these. Again, there are many complexities here, which for the lack of time I won't go into. How much do these actually correlate with outcomes? How there is an in vitro in vivo discrepancy. So there are many issues to be considered. But he had a voriconazole MIC of 4 and an amphotericin MIC of 0.5. Doesn't automatically mean that ampho is a better choice here. We should be careful about just comparing based on raw numbers. But if you look at the epidemiological cutoffs, then if you look at solani, again, epidemiological cutoffs only tell you whether this is a wild type or a non-wild type isolate. It is not going to tell you, how my individual patient is going to respond to it. But these are some guide these are some data that you can use when you're trying to make sense of the MICs. Again, for the non-candid IEs, now we have a little bit more clarity. There have been guidelines published. There has been an algorithmic approach or a pragmatic approach that has been recently published. But if you look at some of these molds, then sometimes it is difficult to make sense of the MICs that the microbiology department gives us. So here, if you see the epidemiological cutoffs for Solani, then for Vori it is 16, for amphotericin it is 4. Our patient has an MIC of 4 for voriconazole and amphotericin was 0.5. So his voriconazole was stopped, actually his skin lesions resolved, he improved clinically. Amphotericin was continued till there was clinical and radiographic resolution. So again, this case highlights the importance of, two things. One is that Fusarium is one of those molds which can grow in blood cultures. The other is that is one of the rare situations in which empirically, or not empirically, but upfront you would give this patient dual antifungal coverage. As sir said, there are not too many situations in which we consider dual therapy strongly for mold. So this is one of those situations. At least till you know the species, till you know the MICs, till you know the clinical response. And the third challenge here is how do you interpret the MICs in such situations that the lab tells you. So I think I'll stop here with this. If there are any questions, or we can break out for lunch. Thank you so much.
Thank you, sir. Now it's time to hit a pause. We'll have the lunch. We'll reconvene at 2:30. Please note, food items are not allowed to be brought inside this hall. Washrooms are located on this side. Thank you.
For there is one vegetarian counter on the left side, and then there are two other normal food counters. The faculty dinner.
Please start. Sir, he has to start. There is. No, start this. Yeah, please start the slide. Okay, so friends, all of us should remain awake, including me. So let's see. So what I'm going to do is present some cases which are real, and then I'd like the audience to have some quick answers. You can shout out your answers and so on. And after that, it will pass on to the expert panel. Okay, and I hope we can have some engaging discussion. So naturally, the theme is when, which, why, and so on. So to tell the obvious, we are talking of ICU setting, and there isn't any luxury of waiting for the whole syndrome to evolve and for us to, the patient to meet various criteria by whatever bodies and so on. And obviously, sicker the patient, greater is the need to target the correct organism and its susceptibility. So often it can happen that assessing, investigating, and treating all may have to go in parallel. Also, there is spiraling today, empiric treatment before the patient comes to the ICU, as well as in the ICU before the ID reference. So that lessens the chance of microbiology confirmation or even exclusion of a pathogen. And needless to say, host immune status, indwelling devices, prior healthcare exposures, local epidemiology, and even community exposures, all these are going to be important. And this is what I began in the morning also to tell you, that there is no exclusive pathognomonic sign of an invasive fungal infection. The 4 fungi produce syndromes which are distinct from one another, although there is some overlap, and this is how it evolves. So like Atul showed us the case where there was sepsis because of Candida and Candidemia. So you could have those skin or papillonodular and such things. Pulmonary lesions, leading cause can be aspergillus, but there are so many other molds, as well as some of the yeasts which can also produce fungal infections, of course not Candida. Meningitis, Cryptococcus immediately comes to mind, but you can have others producing meningitis also. And rhinoorbital cerebral, again the knee-jerk reaction is mucor, but you could have others which will also. And remember also that each of these syndromes would have alternative fungal etiologies as well as microbial etiologies, as well as sometimes even non-infectious diagnostic possibilities. So all these things have to be, kept very much in mind by the physician. Okay, let's begin this case. So this is a 29-year-old lady, type 1 diabetes, CKD, hypertension, hypothyroidism, fully treated HCV in the past. So this is just the background. So on 11th of December, she received a cadaveric kidney pancreas transplant. So the donor had cerebral venous sinus thrombosis 1 week earlier, but likely had received lots of antibiotics elsewhere. So this patient received a large dose of ATG, triple immunosuppression, and was on meropenem, teicoplanin, and micafungin. Okay, so you can see the duodenal loop there and the pancreas there. So there was rising WBC as well as CRP and the drain outputs from the abdomen also. And therefore, almost 9 or 10 days later, the patient was referred for an ID opinion. So there was that discharge coming out. So what we did was a JI panel, multiplex PCR panel. Now this is entirely off-label. Also remember that this drain is there for last 8 to 10 days. But what it showed was a CTXM and a NDM producing Klebsiella pneumoniae. Okay, so you can see this there. It's CTXM there, NDM there, and this is the organism which is found. So meropenem was changed to Cas-IV-aztreonam and teicoplanin was changed to tigecycline. The idea was that you could also increase the enterococcal cover, although teicoplanin also would cover, but tigecycline can also work for enterococci as well as anaerobes and so on. And with the important thing that was asked to re-explore, okay, because things don't seem to be going well. So these are the surgical notes where they said infected Surgicell pus necrotic collection present in the perigraph area along with slough adjacent to the pancreas and all sorts of things. And as always, they do a thorough wash and so on. So this operative specimen, so I said let us do the JI panel on that also. And that also showed the same Klebsiella carbapenem resistant along with a growth of Candida whose IDAFST was awaited. Okay, now this is being awaited, I have to do something. What should be planned as anti-Candida treatment? Continue micafungin as before, change to liposomal, or change to voriconazole, or none of the above. So what do you all think? Quick, and then we will go to the expert panel for discussion. Anything? You can't wait for ID and AFST and then answer. You have to work now. Nothing? Okay, then let's ask the expert panel. What do you all think?
So here, like, I mean, we have now good evidence that patient is having intra-abdominal candidiasis because the operative sample is
Also showing.
Yes.
Yes.
The only concern is like why we have used drain fluid for microbiological.
That
because
was initially.
Yeah, that was initial, but I think the message here is that drain fluid growing anything probably represents colonization, so it may not give you a picture, true pathogen pictures.
Correct. I have my own idea about it. See, when we say that the drain culture may not be representative, it doesn't mean drain culture is never representative.
Yeah.
It can be.
It
So
can
now
be, yes.
supposing the exploration is not in my hands, supposing the consent doesn't come, supposing the surgeon doesn't come, and so on. So there could be a lot of time gone there. So at least I can get some idea. This was for
It
9 days.
represented, yeah.
Ideally, I know Atul very well, but this, where is the sentence that it is never representative?
Yeah.
It is never like that. So I can still use my head to see whether that is fitting into the whole. The patient is on meropenem. 9 days are over, 10 days are over. What do I expect? CR only. So that is also matching. Okay, so that is one. But I am not asking you about
Yeah.
that part. I am asking you about this.
This part, yeah. So the patient is already on micafungin, and now the exploration is showing the evidence of Candida infection. So here probably how I would interpret these reports, that patient is on appropriate antifungal therapy, but source was not controlled.
Yes.
And that could be a reason that there is a persistent or the isolation of the organisms. Now the source has been taken care of, so I'll continue the same micafungin and wait for the drug
Are you sure
susceptibility.
that the source is taken care of? You read his operative notes. So what has he written? Previously operated in ये सब ठीक है. That
He
was
said
all
he has
removed.
thorough wash and he has removed the necrotic.
Yeah, but what do you think is the source? Is this the source? This is the pus.
He said the peripancreatic necrotic and the perigraft collection both were taken care of.
Yes.
So there were two intra-abdominal.
Why did he get that? Something
Possible,
going
that
on
is
there.
possible,
Yeah,
yeah.
so that means I am not so sure that the source is controlled. Yes, he has done whatever could be easily done. But is that, I don't think that is the right
But
thing.
generally we expect that when surgeons are looking, I mean, they will take care of his own part, like whether there is anastomotic leak or some perforation or something like this.
If it is the same surgeon or or another surgeon, it makes a lot of difference. Anyway, yes.
My issue is different.
Okay.
About the PK of the echinocandida.
Yes.
That is a major issue in this aspect.
Yes.
And here I think as we are getting more and more data, it shows, that's why you see that this is a moderate recommendation in case of the echinocandida.
No, but even see this, even the guideline is not, I think, current. Let me say. See, this is the guideline. Now look at the intra-abdominal candidiasis. What are they saying? Standard dose only. Look at that. 200, 100, 70, 50, 100. Like that.
So the thing is that the higher dose, it's not been proven also.
Not proven, but I will do it.
Then you have to give an expert opinion.
I am going
but
to
I
do
would
that.
rather say that if you look into liposomal amphotericin B, that has been green. So why not we give amphotericin B in this sense?
All right.
That should be the. Another issue is that though while diagnosis is being discussed, have any one of you have tried for peritoneal fluid beta-D-glucan? Because now the data is coming very strongly. Peritoneal fluid beta-D-glucan along with serum beta-D-glucan can better confidently diagnose this scenario.
In those patients where candida has not been found, here it is already found. So it's not going to add
I am just
anything.
saying that diagnosis wise. I am
Right.
not saying
yes,
this case.
yes. If you are not found, then it's a good test to do that. But otherwise, this has been found. The other issue is that this patient's peritoneal fluid, if we do, they would have been surgical gauze, and the patient has had recent surgery and a second surgery and all that. So how will you now interpret that?
And,
so
and
there can be
blood
issues.
products also.
I have not,
blood products also.
I have not spoken in this context of this particular case, because this case is you have already from the necrotic
You already
material
know.
you have diagnosed.
Correct. Here there is no question.
problem.
Here,
But I am just saying in case of intra-abdominal candidiasis, now the issue is strongly coming additional, easier diagnosis if you don't go for surgery. That can be with the peritoneal fluid beta-D-glucan.
Perfect.
Sir, if it is intra-abdominal candidiasis, again the important question is whether it is, in this case we know, but in general the question is whether it is peritoneal versus other sites in the abdomen. If this would have been a pure peritoneal infection, then I would have probably changed the drug. Right now, looking at the site and looking at, there is further margin for source control, I would probably increase the dose and keep the same drug.
You're right. So these are the issues which were in my mind. So you can have issues with the PK, the PD, as well as the PK/PD index that is desired. Okay, so would you like to take this a little more in detail? We have intensivists here. Dr. Jacob, what do you think? Yeah, he is the intensivist. So what do we want to do? So Arunalok already said that he also said that there will be issues with PK. Do you know the Candida species? You don't even know that. Okay, so there can be issue with the PD and the PK/PD index needed in the peritoneum. Okay, so there are really important issues here. Also remember, this patient has received a disease donor graft. So has that patient, the donor, received huge amounts of antifungals? We don't know. See, there are many hospitals where even if he gets a cerebral venous sinus thrombosis, they will still put on antifungals and so on. So there are so many issues. Is Candida auris an important or a pathogen in that institution? Did the graft preserving fluid in which the graft came to you, was it contaminated? Could it have had Candida auris? See, these are very important questions which all of us have to think about. Okay, so there are lots of issues in all of these. So obviously the most important thing is PK. So you have suboptimal peritoneal penetration, and I would strongly urge all of you to read this Novi's article. Jason Roberts is also there in that. So look at it. Echinocandins penetration is only 30%. So you won't have much of a dynamic problem, but you could have if there is some resistance and otherwise toxicity. Liposomal, very good as Runalok said, but even here it is recommended to give 5 milligram per kilogram. And there can be these issues. Fluconazole penetration is really good, like 85%, but then you can have a problem with it might not be azole susceptible fungus also, you don't even know. And here also they have said use the high dose fluconazole, and preferably this is one situation perhaps where TDM for fluconazole also may be useful, and that's what has been recommended. Anyway, also remember that there is high volume of distribution because the patient is septic, has had multiple surgeries. There's actually abdominal drains which are taking out the fluid as well as the administered antifungal. So the patient is losing on one side. Also remember that hypoproteinemia would probably lead to augmented hepatic clearance of this. See, remember all echinocandins are highly protein bound. So when you have hypoproteinemia, more free drug is there. That free drug is being metabolized by the liver. So this is a situation analogous to augmented renal clearance. Here I would use the word augmented hepatic clearance of a drug such as micafungin. Then, as I said earlier, Candida genus species are awaited. Is it exogenous? Is it endogenous? Is it come from the patient's own duodenum or where? The JI panel had been negative for fungus. Okay, so that includes albicans tropicalis, glabrata, cruzi and parasilosis, but does not include auris. Anyway, let it be. Then let's go to this. This did show a growth of Candida krusei. Okay, so needless to say that was won't be susceptible to this. So a secondary exploration showed leakage and blood was oozing from the anastomotic site. So there was all these difficult issues continuing the antifungal treatment. Patient, remember, had received a very high dose of ATG and also triple immunosuppression. So was there a need for any mold active prophylaxis following that IV treatment and so on? So it really became a difficult issue that time whether something like posaconazole should be continued later on after treating this intra-abdominal candidiasis.
So in this case, AUC versus MIC ratio,
yes,
in case of this divides into two groups. PKPD wise. One group is that if Candida parapsilosis is there, other group is that if non-Candida parapsilosis. But this particular patient, when you have Candida cruzier, you have landed in a problem. Because you cannot give amphotericin B. Amphotericin B may not be useful in this situation.
It can be,
Some
no?
of them are resistant of this.
This was susceptible,
So
I think.
susceptibility wise, is it coming susceptible?
I don't know.
One. Amphotericin
Huh. It is 1. And this is by sensititer. Sensititer. Yeah. इसमें आया 0.5 वाइटेक में.
But it's a real problem in case of the echinocandida. You treat it, doctor, you say that in case of this interabdominal candidiasis.
Yeah, absolutely. Because the PK issue is with Anidula fungin, and the Caspo and the mica has excellent penetrations into the retroperitoneal tissue, and it generally achieves the therapeutic levels. So Anidula fungin have two
Has
issues, like
peritoneal
pleural
problem.
and
Correct.
as well as
Pleural
the
and
peritoneal.
peritoneal. Correct. Absolutely. So we had not chosen Anidula fungin in any case in this patient. Okay. So next patient, 84-year-old lady, diabetic, hypertensive, chronic atrial fibrillation, admitted to ICU with fever, cough, dyspnea, which was going on for 3 days. She had received lots of antibiotics. That goes, I think, without saying. I don't have to say that. Every patient receives lots of antibiotics. Okay, developed these dense nodules with halos, and the serum galactomannan was done, which was 2.3. So that was positive. So now my question to you guys is, what is likely? Is this invasive pulmonary aspergillosis? Is this bacterial pneumonia? Is this nocardiosis? Or you can't say. So even though this is a fungal conference, you are free, because see, the patient doesn't know it's a fungal conference. So he is free to have any of these things. So tell me, what do you think? Cannot say? No, who said cannot say? You can imagine whatever are there, whatever are given in the ICU. Okay, let's see what is the audience, what are the expert opinions.
Sir, I would say cannot say, because to really look at invasive pulmonary aspergillosis, we can't directly start with the galactomannan. We have to start with risk factors, radiographic findings, and then go to even ordering a galactomannan. So I think with this information, I wouldn't be able to comment at this.
Absolutely. I think one of you said that, and yeah, Tulten.
So here issue is like patient is non-neutropenic and you are doing a galactomannan. So interpretation is bit tricky, and there are several conditions where you will get false positive galactomannan, right? So when patient is non-neutropenic, I mean, you should be very much alerted when looking at very high values like 2.3 in non-neutropenic setting, because most of the galactomannan which is produced by the replicating aspergillus will be taken by macrophages and neutrophils. Right. So generally, non-neutropenic patients may not have such a high galactomannan. So look for the false positive conditions. I mean, false conditions which give you a false positive results. And the second thing, like the history is very short, just 3 days. So you should give more, I think, weightage to the short history. Like acute onset, 3 days, patient becomes breathless, and you can see the multiple opacities with some cavitations and ground glassing. That is also possible that patient may remain asymptomatic for a longer time, and with worsening, like patient may say, I have very short history. But I mean, this could be a possibility in a short history.
Make sure that all the elements of history are properly checked.
I would put it as probable IPA. The reason is, if you look into the clinical grouping, patient ICU stay is one of the clinical grouping, which is the latest had come. Second, patient had got fever, dyspnea, both are there in this situation. Along with there is a imaging wise, there is a shadow which had come, and serum galactomannan is positive. It is a probable invasive pulmonary aspergillosis.
Aruna Log, with deference to you, have I put probable IPA anywhere? So if you want to say probable IPA, you must say cannot say.
No, that's why I said. That's why I said that
you said probable IPA. I have not given you probable
So
IPA.
if Rajiv gives me a liberty to put only fungal diagnosis, then I will put here as a mixed infection aspergillus and mucormycosis, not only aspergillus.
My answer is cannot say, because you still don't have a good host factor. Okay, so the diagnosis नहीं है. ICU stay 3 दिन का ICU stay
Sir,
is not a host factor. I don't agree with that.
This
Now,
kind of
wait a minute.
radiological findings, sir, bilateral opacities and the way the spread out.
Principles lecture, you need host factors, you need clinico-radiologic syndrome, and you need the mycological test. So this host factor has been called as an entry criterion by Paul Verwey in the context of influenza associated pulmonary aspergillosis. So if this patient can be proved to have influenza, everything is falling into place. So what did we do? We did the influenza test, which was positive. Okay, so H3N2 as well as para-influenza. So that was there. So now I have entry criterion. The patient has been admitted into ICU for a respiratory illness in the context of a viral influenza. So that is fully satisfied. The radiology is fully satisfied, and also you have now the galactomannan. So now there is no question. Now this host factor is increasing your pre-test likelihood so that your PPV of your galactomannan becomes very good. Otherwise that was not good. You are still scratching your head. Is it piptezo? Is it something which Atul said very much? So that is the important thing here. And also remember that IAPA can present within 3 days. IAPA can develop Pradeep within 3 days. The patient during the course of the same admission for influenza can develop IPA. Okay, so that is the important thing. Don't say that I want a long
So median time in one study was 4 days. Like so,
Correct,
4 days
correct.
of ICU hospitalization, IAPA was
Yes.
developed.
3 days is in that Lancet.
With oseltamivir therapy or without oseltamivir therapy?
वो तो अभी received all antibiotics. So what, I don't know what were the antibiotics, antiviral, everything. And I also told you that oseltamivir actually increases the propensity to develop that because of neuraminidase inhibition. So that is also one more thing there. So isavuconazole was chosen in this situation. She had recurrent very bad AFs and so on. So this comes as the other question. So can isavuconazole or posaconazole be considered over voriconazole as contemporary choices for aspergillosis? This is a question I am throwing open here. Maybe efficacy is good. It's non-inferior in these two studies. ADRs are less, DDIs are less. And I don't think it will produce more collateral damage also. So
Is there any study of isavuconazole? We are not having that data. Isavuconazole as the empiric.
but ये empiric नहीं है.
Means I am saying empiric means patient fever, patient जिसका इस तरह से है. In case of India, where we have got such high incidence of buford, can there be any way expert opinion recommend isavu as the empiric one when you don't have the diagnosis?
If you are ready to call me expert, then I would recommend. Yes. Yes. So cheaper option. True, but the patient has very bad arrhythmias. So QT prolongation is a very important factor in the choice of voriconazole. So looking at the drug-drug interactions is not so much. Adverse drug reaction is the main issue here, and therefore this has been shown to be non-inferior. We use that drug in this. So the diagnostic first had a similar respiratory illness in this patient. Even that can give a simple clue that this could be a viral respiratory infection. I mean, we have all things at our disposal, so we can do biofire, we can do so many things to find the viral etiology. But it is not an idle pursuit to try to find that etiology. It is very, very important for this diagnosis. Right. Okay, let's take this patient.
Rajiv, the cavitations and that is, I think that is unusual for IPA.
Cavitation नहीं है तो वो bronchus से दिख रहा है.
Okay.
Yeah, I'll show
because
you. ये जो
yeah, so lower lobe में yeah. Okay.
The halos and nodules are beautiful.
Yeah, that's beautiful. Yeah.
They are bronchi only. End on bronchi दिख रहा है. Okay, 58-year-old male pemphigus was treated with high doses of steroids, multiple courses of cyclophosphamide. He developed fever, cough, dyspnea, cytopenia. He was admitted elsewhere, again treated with various antibiotics. The fever increased and developed respiratory failure and was transferred to Jupiter Hospital. Have a good look, friends, at the scan. This is the coronal view. Have a really good look because the question is going to be based on this. Okay. One more view here. You want to see it again? This is it. Before that, this was the axial view, coronal view, one more coronal view. Okay, I have kept it here for your continued viewing. So referred for ID opinion. What from the following is unlikely? Unlikely, no? PCP, bacterial pneumonia, aspergillosis, or can't say. What is unlikely here?
So unlikely cannot say. So it becomes likely say.
Karo, your time is getting over. What is unlikely? Say something. Chalo, let's go to the experts.
So, sir, if you look at the host and if you look at the radiographic picture, definitely PCP would be in the differential. So that definitely I wouldn't say is unlikely. But you do see some nodular lesions as well, apart from the ground glassing. So I wouldn't rule out aspergillus at this point of time. And you can never say no for a bacterial pneumonia. So I would say cannot say.
Right. Anything else you want to have? What have you noticed in this scan? Have a good look again. Okay, so you have bilateral ground glassing. There is upper lobe distribution. There is fair amount of peripheral sparing.
Yes. Some crazy paving also.
So you can and crazy paving also, and you have got very good basal sparing. In fact, the lower zones are not even involved. So PCP is fitting in beautifully. Is there anything else which you should pick up?
The left side, I would be worried about a nodule.
The right upper lobe looks like a bird's nest sign.
No. Look at this.
Oh.
This is nodular ulcerated mucosa. Okay, you can see it here also. See this upper lobe wala. See how this picture is, and even here it is very irregular. So this is telling you that there is tracheobronchitis, and therefore look at this. This is the bronchoscopic image. So it's full of fungus. So this is obviously aspergillus, and it is showing both PCP and aspergillus. Okay, so bacterial pneumonia was less likely. So what should be used for treatment? Now you have these two bugs, TMP SMX, voriconazole, micafungin, clindamycin, primaquine, isavuconazole, TMP SMX, liposomal, or none of the above. Audience. Is it the right time, post lunch, pre, or what for this session?
You see that there is aspergillus. Which drug should be given?
A बोल रहे हैं. Let's see what the experts think.
Yeah, so I think we have
remember he is on cyclophosphamide. He has pancytopenia. That part of it is also very important.
But hope like the cytopenia has improved, right, by the time. So what was the WBC count? Now you have to tell me.
Very low.
Very low means less than 1,000.
Less than 1,000.
Okay. So here like probably like it is very difficult to use the standard drug, that is Bactrim.
Correct.
Right. So for PCP we have to use alternative therapy, and for alternative second line therapy, like you can use clindamycin plus primaquine. The efficacy is almost equal to the cotrimoxazole, so that is a one good choice. mica fungin has an excellent anti-PCP activity because of the high beta-D-glucan content of the cyst of the pneumocys. So keeping that will also help to take care of the aspergillus. And obviously, you need a drug which is mold active drug, that is isavuconazole.
Right, because I have thrown that here. So if you have to choose the alternative treatment for PCP, you'll have to choose this. Okay, so cytopenia is present. So that's why not standard high dose TMP SMX will be very difficult to use in this patient.
No, but 10 milligram per kg is enough for non-HIV PCP.
Correct. But even 10 milligram per kilo, it may not be very safe. It may be difficult. On the other hand, as you said, echinocandins work for the cystic forms, and but as non-fungicidal activity for aspergillus fine. Clindaprimequine is alternative treatment, not too bad. Isavuconazole covers most aspergillus and also mucor, and so maybe that we don't know whether there is additional mucor here. It is little bit difficult to say, but the smear did not show at least. TMP SMX plus liposomal amphotericin B, but cytopenia is present. Amphotericin B is roughly 15% inferior in the Herbeck trial as compared to aspergillus. Also, we know some of the species are resistant, such as Tereus and all that. So look at this now. So the bronchoalveolar lavage showed a high PCP PCR, and 2 aspergilli grew here. As you can see, it is fumigatus and Tereus also. And even the PCR has shown the same too. The patient also had CMV activation. So CMV Diagnosing like 20,500 copies per ml, as well as MRSA in the blood, and also Candida tropicalis in the blood. So all this, you can imagine the patient did not survive. He continued to deteriorate in spite of all the treatment, and relatives decided to limit the treatment. So risk factors often point to a particular opportunistic infection, but remember that many can be involved in a given patient. We have to carefully evaluate the entire radiologic findings. This was not picked up by the radiologist. So, there is a role for the ID physician to keep looking at the X-rays, not just go by the report. Interpret smears, special stains, biomarkers, PCRs, cultures, and choose the drugs based on the efficacy, likelihood of additional pathogens, and importantly, the adverse drug reaction profile of that drug treatment is very important. Okay, 14-year-old girl, apparently normal, schoolgirl from the outskirts of Pune. She was treated elsewhere for headache, drowsiness, and mental changes which kept worsening over 1 month. I have now not even written that she received many antibiotics because that happens. So these are the MRI findings, and I'm not quizzing you on that. So this shows T2 and flare, central hyperintensity, as you can see, peripheral hypointensity, which is black, and surrounded by edema. You can see it both in the coronal and the axial views. Okay, central hyperintensity, peripheral hypointensity here, and then lot of edema. Okay, then the diffusion weighted images are showing peripheral restricted diffusion. Okay, so this is a diffusion weighted image. So wherever there is restricted diffusion, there is going to be white color. Okay, so that is what is seen here. And the susceptibility weighted image, or also called as a gradient image, that shows central blooming. What does blooming mean? Hemosiderin or blood, altered blood. Okay, so there is this central hemorrhage there, right in the center. I think there is some mistake here. One of the cases. So what is most likely here? Is it, ये कुछ गड़बड़ हो गया, this is some other sentence, just ignore that. What is most likely? Is it TB? Is it aspergillus? Is it sarcoidosis? Is it something else? There are lots of microbiologists, so I know there is too much of radiology involved here, but that's how it is in medicine.
So I have conflict of interest, so I am not going to answer because we have written something which is very recently.
No, you can still try to answer. Remember that she's a 14-year-old healthy young schoolgirl from the outskirts of Pune. So that makes aspergillus a little bit less likely. I can understand granulomatous aspergillosis and all can happen in a young person, but at this moment it is somewhat difficult. So let's see others. TB, ring enhancing lesions, but hardly ever there is hemorrhage, so no blooming, and usually you would see some parenchymal lung lesions. Aspergillus, so this indicates finding of a mold abscess. That's all we can go up to. Usually in aspergillus there could be parenchymal lesions in the lung, but she doesn't have. Host factors are absent, but I recognize fully that a granulomatous form can occur in normal hosts, and usually that is due to flavors. Possible. Sarcoidosis, generally such mass lesions don't occur, so I just put it as I have to complete ABCD, no? That's why. So usually cerebritis as well as basal meningitis occurs in sarcoidosis. So something else. So let's look at what is something else. Nocardia, it usually produces not this type of lesion but ring enhancing lesions. Often they are multilocular, there is no blooming, and usually parenchymal lung lesions. Risk factors usually present. Scedosporium, finding of, yes, mold brain abscess, but risk factor is generally immunocompromised or a near drowning. That was not there. So comes to Cladophylophora. Okay, so Cladophylophora bantiana, so you will have findings of a mold abscess. A surprisingly high proportion of these patients are actually apparently normal individuals. The root is inhalational, but yet lung lesions are hardly ever found in them. Okay, so the first symptoms are neurological, and that is due to the intense tropism of this organism. This is melanized fungus, so it goes to places where there is a lot of dopamine so that it can synthesize melanin. Okay, so that is perhaps one of the reasons. So, and this melanin is also a major virulence factor. So all this is okay. Now there can be some deficiencies in immune system which can also predispose these individuals, but this is an interesting fact. Using metagenomics, they found that this bug is a colonizer of human dominated environments, particularly those rich in toxins and hydrocarbons. So what is there outside Pune? Lot of pollution. Okay, and there are also sugarcane fields, and sugarcane is an unexpected habitat likely due to osmotolerance. Okay, so this was something new which
all this we tried, we could not get
no, ये कौन है द हु है ना इसमें we didn't find.
Cases are still in India.
Yeah, still we didn't find this.
Cases we don't know what is the fungus remain.
We need to do the metagenomics.
ठीक है ना, वो मेटाजेनोमिक्स से सब निकाल आता है, जैसे तुम्हारा बायोफायर से सब निकाल आता है, कुछ नहीं फायदा. We need to see the fungus. Why we should not see the fungus?
But metagenomics में जो कुछ genetic signature आया, that can exist without the fungus being there.
But the thing is that there should be good quantity. तभी जाके आएगा. If I am having one, it doesn't affect. But so many cases in India. You need to know where is the source.
Anyway, but इसका biopsy किया, आ गया. Okay, so you can see the pigmented colonies. You can see the wavy, sort of beaded, lightly pigmented chains, and so this was found. So treated with voriconazole and all that, and decompressive craniectomy was done. Did not afford further treatment. So this is going to be now a difficult thing. So what other treatment can be given to this patient? And this is only coming from the literature. I don't know. So in this we found that there are low MICs to itraconazole also, posaconazole, and so on. The patient was just refusing treatment, so he did some extrapolative calculations, thought that posaconazole, itraconazole might have good levels in the parenchyma, not in the CSF, but in the parenchyma. And this is the global guideline which was also talked about in the morning. So here look at what is seen here. So phaeohyphomycosis, disseminated infection, POSA or VORI plus echinocandins plus VORI plus terbinafine, and salvage treatment, I cannot understand this, Aruna. See here, it is saying first line, and then salvage treatment is no different from first line. Isavuconazole or pusaconazole or voriconazole.
At that time, we don't have option. Now we have so many options, so it will be changed.
But how can this? इसमें से उधर थोड़ा.
Yes.
I don't know.
Yeah, that's true. Like.
So basically, what it means, suppose POSA is being given first
Hmm.
line.
Okay, then you change to okay, that way.
That is the
Okay.
So Rajiv, like for the immunocompetent host developing Klebsiella foramentana infection, the lung is one of the source, but the most common other source would be the cutaneous infection.
Yes,
so traumatic skin lesions, some ulcerations, which may not be recognized by the
Yes.
patients, and after some weeks, few weeks to few months, patient will end up with a CNS brain abscess.
Absolutely.
Acquired from the skin, yeah. So from traumatic inoculation. From the environment, absolutely, from the environment. So traumatic inoculation and then bloodborne dissemination, neurotropism leads to the brain abscess. Shiva Prakash.
वो अभी
Show-
तुम
show
लोग
in the soil.
तुम लोग ढूंढो
Sir,
बाबा.
as it is it's really very difficult. In the soil, hundreds of phaeophyomycosis will be there. We should find out an agent specifically to amplify this particular agent. Then at least we use the many other things to suppress aspergillus and only black fungus. But I also took many of the samples to Spain. So at least around 100 samples of soils to Spain, and I could not get finally. Yeah, that's what now we had to do, sir.
आजा. So, previously I had one more patient who was a renal transplant patient who was fond of gardening. She had a terrace garden with rose plants, and there was a thorn injury. So, I like to believe that gave her a cerebral cladophyllophora. That thorn injury may not be. हाँ, वो दूसरा एक पेशेंट है, वो राइनोक्लैडियल है, बट ये दूसरा भी एक है. So suspicion of this infection is needed even in apparently normal individuals. Radiology may help, but it will just help. You need a microbiologic diagnosis, and for that you need an invasive procedure. Identification to genus species level, MICs, breakpoints are not available. ECOFs can be used as I showed you there. Therapeutic drug.
Do you understand ECO?
Microbiologist है इधर.
Do you understand ECO? Huh? How it is being done?
Okay, so if you want a clinician to answer or you want a mycologist to answer.
Because he is going on saying ECO. What is the question? You know, basically what is there? There are wild strain and those which is acquired resistance. Now wild strain is supposed to be susceptible, isn't it? So the reason of this, when we don't have MIC breakpoint, because to have breakpoint we have many other factors need to be looked into, not only MIC. It has to be how many patients are responding to a therapy, and all those 4 criteria are there to go for a breakpoint. So in this scenario, what we generally try to do is that one solution, can we divide them from the wild strain with the modified strain or the acquired strain? And that's the reason, if you take 100 strains from the environment of this, you go on doing the MIC, what is the bimodal distribution of this MIC has been found. And then epidemiological cutoff from that has been found. And now it is so that's the way epidemiological cutoff.
Yeah. See, right now even the same thing is being used in the context of TB also. Okay, so there aren't proper clinical breakpoints. They still use critical concentrations proposed by WHO, which are based on epidemiological cutoffs. So the MIC distributions of the consensus wild type and the MIC distributions of those with mutations, those two are found out. The CPB should be it should not bisect either of these distributions. It should be somewhere in between. Anyway, let's go to the next. 27-year-old girl, lady, whatever, type 1 diabetic, CKD on maintenance hemodialysis. Diabetes was very, very poorly controlled. So on 10th of July, she was called from her native town, which is Akluz. Akluz is near Pune, but it's a small town. As a disease donor was available for a kidney pancreas transplant. So she needed heavy doses of ATG, prednisolone, followed by triple immunosuppression, and was also on various antibiotics. 7 days later, she had severe abdominal pain, distension, re-explored. Again, similar peripancreatic pus pockets with all this was found, and was on colistin, meropenem, tigecycline, linezolid, and micafungin, which was changed to fluconazole by the treating team after surgery. Now, this was surgery was on 10th. Severe abdominal pain and all these things were done on 17th, and on 28th, that means another week later, right-sided chest pain and dyspnea developed along with mild hemoptysis. This is the chest X-ray, and this is the actual view of the CT chest. A bronchoscopy also was done. The bronchoalveolar lavage fluid that showed galactomannan of 1.4, and 2 days later the patient was referred for ID opinion. So what are the diagnostic possibilities? Let's see what the audience thinks. Nobody's saying anything. Not okay. Let's see experts. Expert panel. You want any to go back? Yeah. CKD, MHD, bad diabetes, and has been plucked from the community, suddenly transplanted and heavily immunosuppressed.
Yes.
Okay, that is in a gist, and then these are the imaging features,
Right.
and there is galactomannan.
So although sir, the bile galactomannan is positive, but we see that many patients like this who undergo transplant, they can be colonized with other things, including mucor. So I would be mindful of that possibility. I mean, we've seen that especially in our liver transplant recipients, that patients going into liver transplants and suddenly having early post-transplant mold infections. So I would be mindful of the possibility of a dual mold infection here.
Shiva, any other comments? No,
uncontrolled. So the fungal infection is very likely because the opacity, right? The consolidation is a large nodule, and right now this is a first CT scan, but subsequent, like after a few hours,
Correct.
48 to 72 hours, you are
Yes.
going to get a
Yeah.
classical.
Correct. Atul, if I tell you that there is a suggestion of a reverse hello, you will believe
Yeah,
me.
yeah.
The radiologist will not believe.
मैंने देखा इसीलिए मैंने बोला कि subsequent मुझे CT scan चाहिए.
Suggestion of a
Yeah,
reverse.
exactly.
Okay, so yes, that made me sort of sit up and think कि ये कुछ हो सकता है. Okay, so now let's see what are the diagnostic possibilities. Let's not just look only at radiology. We should think of so many things else. So think of GPC, GNB, nocardia, aspergillosis, and mucor. And what are the findings here? So she had bloody sputum. Practically, it can happen in anything, but I'll just put a tick mark there. Nodule with early reverse halo sign. It can be here, but it can also.
You said, it's just you have just put a tick, but for hemoptysis is a very important clinical presentations of pulmonary mucormycosis.
Correct. It
So
doesn't
if your
help
patient
to.
is having a hemoptysis and pulmonary opacity like this with a high risk factor like uncontrolled diabetes, think for mucormycosis.
Correct. Not that it can't happen in others, it can, but mucor, I would absolutely correct Atul. Yeah, possible. Possible. हाँ. Chances ज़्यादा है. So nodule with early reverse halo, even that can happen sometimes with aspergillus. You can't really say that in anything, any of these things, but इसमें classical है. That's all. Now was in the community. So community में again all these three things could come from the community. Severe diabetes, So your greater relationship with mucor, also with nocardia, not that much with aspergillus. See, इसमें we always say not that much or more and all. It is not. You can't say just only on the basis of one simple thing. So severe immunocompromise, yes. So again, these are there. That doesn't mean that severe immunocompromise can have a pseudomonas pneumonia also possible. But remember, the patient was on anti-GPC treatment, including linezolid. So that makes nocardia less likely, GPC less likely. The patient was on anti-GNB treatment with colistin and meropenem. So that makes again GNB and nocardia a little bit less likely. Was on antifungal agents, micafungin as well as fluconazole. So that can actually alert you to the possibility of mucor more. And bal-galactomannan was positive, so you cannot, it could be positive. So IA was in the बराबर वो मैं GNB में पकड़ा है. So there again same thing कि meropenem was there, not colistin, but meropenem will have an effect against Burkholderia pseudomallei. So that is also one of the things. Coming from occluse makes it a little bit less likely. That area is not very well known for melioidosis, but it can have. So IA was in the probable category, or it would be in the possible category if this galactomannan is falsely positive. Then we will have to say that. But additional mucor was the most likely thing. We know that mixed mold infections occur in about 15%. So the likely scenario was she was in the community at occluse with severe uncontrolled diabetes, may have been inhaling mucor spores every day, but nothing had happened because she had not received ATG. Okay, so suddenly she underwent severe immunosuppression. So that is, I think, the likely scenario.
Your comment is very excellent. Go to the previous slide. Is that it can be in the possible category if the galactomannan is false positive.
Barabar. I'm that article is
ये जुगाड़
नहीं but सुनो ये आर्टिकल का इसके पास रेफरी करके आया तो उसका दिमाग खराब हो गया because the title is aspergillosis can exist even if galactomannan is false positive. Like I sometimes say, typhoid can be there even if Vidal is positive. Okay, so this is, I think we have discussed these points again and again. So, chalo jana do. I think we'll stop here. Anyway, what happened? Worsening occurred. This is it now, Atul. You can see the reverse halo nicely. उसका ये सब निकाला, but ultimately patient succumbed to the illness.
So what was the duration of first and second CT scan? Because I mean, just to know the rate of progression.
Yes, yes. एक मिनट में मिल जाएगा डेट. एक मिनट. 29 July 22. 6th August.
See in 7 days, disease has progressed so fast, like thick capsule has evolved, the central necrosis has also started. So within a 1 week time, there is and this is just because of IgO invasion.
Correct. Okay, we'll stop here. Thank you.
Okay, Ajab.
Thank you for an exceptionally engaging and insightful panel discussion. Your expertise, practical wisdom, and thought-provoking perspective have truly enriched our understanding of the diagnostic and therapeutic challenges in managing fungal disease in the ICU. Thank you, sir.
We'll now move on to the much anticipated workshop station. Our esteemed faculties for the workshops are here. Here, all of you will be having the ID card. Behind that, there will be a color. Can see this. So there will be 4 colors will be there. According to that, you will be.
Oh, you have already have the color. Excellent. So we have to divide you into 4 groups? Okay. So no, they have not divided. So what I said that the red color comes this side. In the front portion, yellow color go in the back portion. And what are other colors?
Green.
Green in that portion. And here another color? Blue. So red here, yellow there, green back. बाद में करते हैं, इन्होंने पहले कर दिया ना डिवाइड, हम सोच रहे थे. All red come here and blue here, yellow on the back and green on the back.
Can you make a circle?
We'll make this slowly. Try to make a circle. Try to make a circle, each of you, each of the group, try to make a circle. You are blue? Okay, blue. Blue. May I draw your attention now?
Anyone have a laptop?
May I draw your attention, please? Are you ready? Okay. The thing is that each of this group has to select one leader, and the leader will have the discussion. Will be giving you cases. The case could be all different. Each of this group will have separate cases, and the leader will discuss the case among the group. And leader's quality should be allowing everybody to participate in the discussion. And finally, after discussion, they will present the case. The leader will present the case there, and it is the other groups will try to pull him or pull her. So this is a healthy competition amongst the group. So this is the process we like to learn 4 cases. Okay? Any question? So faculty here would be just facilitator or observer. Faculty is not going to, the leader will lead the discussion. Okay? Any question? Okay, not. So how many are there? We 4 are there, na? 4 है ना, कौन 4 है? Atul sir, where is Atul? Rajiv, you take that.
Anyone from that group has a laptop? आपके पास किसी के पास लैपटॉप है क्या दूंगा? आप लिस्ट में चले जाओ. आप कौन से ग्रुप में हो?
So राजीव आप वो ग्रुप ले लो उसके साथ। शिव प्रकाश आप ये ग्रुप ले लो। अतुल आपका ये ग्रुप। ठीक है और मैं ग्रुप ले लेता हूँ। Any question? And this whole exercise to be finished by 20 minutes. And then you will have the tea and then the presentation will be there. Okay?
I would like to take a pause and have a discussion on this at this moment. A diabetic hypertensive male with a very poorly controlled diabetes with an HbA1c of 12% with a recent history of COVID-19 infection requiring steroids. So that would probably say something, right? So he would have probably had a severe COVID, mandating steroids. Any comments or any ideas from your side? Okay, yeah, there is uncontrolled diabetes with steroid use. Yeah, and acetate hyphae. No, but the thing is like there is a recent history of COVID and requiring steroids, so which means he would have had a pretty bad COVID also. So a recent hospitalization, somebody comes with fever and cough. So what are your immediate clinical diagnosis at this point? Forget about the sputum cultures and the sputum fungal smear and all those things. Somebody has come to you has with a background history of a bad COVID with a recent hospitalization, has come with persisting fever and cough with productive sputum. Okay, secondary infection. So what are the possible etiological agents would you want to consider? Okay, somebody said reactivation of tuberculosis, fine, okay. Fungal infections. Which specific fungal infections has the highest risk? Aspergillus and mucus. So we have Kappa and CAPM. Okay, so COVID associated pulmonary aspergillosis and pulmonary mucormycosis. Anything that you would want to broadly consider just for a discussion? What bacterial etiologies would you want to consider? Okay, melioid, good. Nocardia, very good, okay. So among gram positives, is he at a risk for an MRSA infection? Okay, so there is a recent hospitalization. So yes, and probably he would be requiring a lot of IV lines. He has an ICU stay probably because he has had a bad COVID with steroids. So MRSA is a risk factor. Then the conventional gram negatives. Any hospital acquired or a healthcare acquired infections you would want to consider the routine Pseudomonas, Klebsiella. And if we don't know whether the COVID required like any ventilator stay or anything, we do see a lot of NLFs like other NLFs like Acinetobacter. So all those kind of possibilities we'll have to entertain on top of like nocardia and like you said melioidosis in this area at least we can probably consider. Any other comments that you would like to take in this scenario? So is PCP a possibility? Diabetic, steroids, COVID. Would you want to consider PCP here? Pneumocystis. Okay, productive cough could be, yeah, probably one thing against PCP. Yeah, that's also true. And the other part of PCP is like the amount of dyspnea. We don't have a mention about of amount of dyspnea that the patient had. It's mainly fever and productive cough is what generally has been written. So PCP generally, do they become more dyspneic or is it something else? So their saturations generally tend to be disproportionate to the amount of dyspnea that they show. They may not be clinically appearing more dyspneic, but if you look at the SpO2 generally you'll be seeing a very low saturations, especially that is more in the immunocompromised PCPs that you see. The immunocompetent PCPs might not present in the typical way that we learn in the textbooks. So anyway, going back in front in this case, this sputum cultures grew Pseudomonas. Okay, suppose this patient came to the hospital at the point of maybe in the emergency department. I would like to ask you what are the antimicrobials or maybe what is the treatment that you would like to institute in this patient? Empirically, this patient has come. So let us say his saturation is maybe 75 with room air. He is having dyspnea, he is tachypnic. So what empirical treatment would you want to consider? A diabetic male. Come on, you are all treating. We have pulmonologists here, we have critical care physicians here. Yeah. Okay, meropenem plus clindamycin. Okay, so you are thinking in terms of okay, good and MRSA coverage for with clinda because mero itself would cover a lot of anaerobes. So okay, mero with clinda then. So anyway, you are given the antibiotics, so patient is not improving. Sputum cultures grew Pseudomonas and these the fungal smear also they are saying aseptate hyphae. So at this juncture, would you consider this Pseudomonas as significant? Or what are the possibilities that this could just be a colonizer and probably not representing the ideal etiology? So your patient is not responding on meropenem. Suppose let us say you hike to Casavi or maybe some higher end treatment for Pseudomonas also. If there is an NDM Pseudomonas or whatever, you given tried for adequate treatment, or maybe you have gone for some polymyxin based therapy or whatever, and the patient is not responding. Would you want to consider when would you consider this Pseudomonas as a contaminant or maybe a colonizer? than the Pseudomonas. So why can't be a mixed infection, a bacterial and a fungal infection? Yeah. Okay. If the procal is elevated, does that always correlate with the bacterial pneumonia, sir? Yeah. So, okay, suppose let us say the procal is high. So, at this juncture, since we don't know this differentiation, definitely I would also want to consider treating the Pseudomonas because that's what we have. But then, okay, so the sputum fungal smear has now shown aseptate hyphae. So, what are the possibilities that this could be a mixed bacterial and a fungal infection? Could be, because we can never say never, because obviously he has had multiple risk factors, and if you look at the host, there are so many, like diabetic male, other with a recent hospitalization, with a recent ICU stay, we can never say never. Absolutely, absolutely. Yes. Yes, that's one thing. So anyway, so we'll move on. So because I don't know, I have not managed this patient really. So the thing is like this is a scenario. So these are all possibilities that we could be entertaining. So anyway, patient is not improving, and in the meanwhile, fungal cultures are growing, both Aspergillus and Mucorales. So with this background, if you had started your treatment with a high-end anti-pseudomonal agent, maybe all those things, and if the patient did not improve, would you have considered adding an empirical antifungal upfront without these results? You would have empirically added. COVID. So do you think voriconazole has some Mucorales activity? No. So in that setting, would you want to have? But then COVID associated mucor is like, we had a huge burden with COVID associated mucor, right? So, and this setting, see, both kappa and CAPM are possibilities. So, when those two have an equal probability, if you look at the host, okay, COVID is, maybe you could argue about COVID associated mucor and aspergillus. What about the fact that the patient is diabetic with an HbA1c of 12? Does that become an independent mucor risk, like with steroids? Suppose he could be in, let us say he has a urine ketone positive, he has DK. Okay. So what, like? Okay, liposomal amphotericin B. Or in azoles? Okay, posaconazole. Okay, fine. So would you be empirically adding? Maybe at what time would you want to? Okay. Yes, sir. So now the imaging is showing a right upper lobe cavity and a consolidation. So at this point, if somebody can comment on the image. Okay, so for want of time, I will move ahead. So this patient was given liposomal amphotericin B at 3 mg per kg for 19 days, and he underwent a pneumonectomy also. And this was his biopsy findings. So yeah, more specifically in this image, anything that you could make out? Where? Which one? This. So these are. Yeah, so these are septate hyphae. So this is aspergillus. What about this? Yeah, these are the broader ones, and they are aseptate. So in this, the imaging is showing both aspergillus and mucorales. Okay, so this is one case where the patient had both a COVID associated pulmonary mucormycosis and a COVID associated pulmonary aspergillosis. But in one comment I would want to specifically entertain was whether this serum galactomannan of 0.45, what is the value that you would have given? And with that, would you have basically ruled out, is it sufficient to rule out a COVID associated pulmonary aspergillosis? Yes. So COVID associated pulmonary aspergillosis, the route of entry is mainly through the pulmonary route. So it doesn't generally cause an angio invasion, as the spread is not coming from the blood vessel. The source is not the blood vessel initially. It comes through in a respiratory route. So in such a scenario, the we'll have to depend on more on a bile galactomannan rather than a serum galactomannan for the diagnosis. So a serum yes sir. Yes sir. Yes sir. Yes sir. Non-neutropenic. Yes sir. Kappa, yeah. Yes sir. So finally, this patient had a diagnosis of diabetes mellitus, CAPM and CA kappa. So how shall we manage the case, and shall we modify the therapy after diagnosis? So this patient had received lipoampho for 19 days and underwent a pneumonectomy. So what would you do next? What are your options? Continue lipoampho, or you want to add something else, or you want to switch to something else? Directly switch to oral. So what oral agent would you want to? POSA. Sir, I'm not sure. So the thing is, like, with what I know is like POSA, if it is rhizopus species, the MIC tends to be high, and that's what I'm not sure, sir. You should be entertaining on that point. So if you look at POSA versus ISAVO, I would go for ISAVO here. But then, if the species is more mucorales, I would say generally POSA is good enough here at this point. Yes, either of these. QT prolongation or something. ISA would be good. Shortening the QT. Yes, sir. Yes, sir. No drug. Yes, sir. Yes, sir. Yes, sir. Start POSA, yes, sir. Achieving the steady levels, yes, sir. Yes, sir. Yes, sir.
Okay, can you go to the next? Any question to him?
3. Yeah, ideally I would have gone with a 5 mg per kg dose at least. Is at least what we do. But then 3 to 7 is, I think, is been mentioned in some literature also. So 5. I'm not sure of the data. Methylprednisolone. Yes, sir.
People are just thinking that oxygen is not there, so they went on giving
Steroids.
all those patients have come down.
Yes, sir.
Any other question you ask to him? If not, next book.
So can I just follow up one question? So if the patient is severely sick, what is your comment on combination therapy for this scenario at least? Because
Dr. Rajesh has already said there is no data available for data. Only thing, if you have seen our paper during the COVID-19 mucormycosis case versus control study, that particular study has shown that combination has
better receipt.
rather than this. But that study you cannot say that because it has not intended to.
Recently we
Sir,
found
the
this
same
particular.
thing in the systematic review in the 2023 by Dr. David Denning. He has basically put up data specifically on mucor. In his systematic review, what he says is the mortality in combination therapy was only 6%, whereas lipoampha followed by azole was 12%.
This is again a study which is an observational study.
Yes, sir. Yes, sir.
So observational study
We
picking
cannot
up,
come. Yes, sir.
in case of mucor, so many factors are there: site of infection,
Yes, sir.
severity of the infection,
True, sir.
all the factors, like suppose pulmonary mucormycosis.
Sir.
If there is a more, if you cannot do surgery, outcome goes
Obviously,
down.
it's going to be bad.
And
Yes, sir.
pneumonectomy you can do only if it is localized in a particular segment. Otherwise, you cannot do this. Suppose bilaterally it is being there. You
Yes, sir.
cannot do so. Those are the issues which are there in cases of deciding combination was good or not.
Yes, sir.
So I would not go with that particular study of David
Study.
Denning. I know about that particular
I know,
observation
sir.
study.
Yes, sir.
Okay.
So they generally say tissue is the issue in mucor. So as long as source control is not done, your treatment of mucor has not begun is what we generally keep as a dictum. So the source control, without source control, any amount of antifungals is probably not going to save the patient. So in that setting, yeah, that's a very fair point, sir.
Okay. After yellow, what is there? Green.
Yeah.
Blue. After that, what is there? Red was here. Yellow was there. Green. Green come. One of
Thank you,
them.
sir.
I hate presenting after Dr. Vasif, my senior in college. Only advantage I have is I have Rajiv sir's still presentation. So,
Are you Rajesh Suma?
I've sort of asked him permission, and he's given me this presentation. I've modified it a bit.
What is your name?
My name is Baker. Doing my residency in ID, sir, in Kottayam Medical College. This I'm sharing with you not from experience because I'm just second year. I'll just share with you what sir has taught us today, since it's not really visible. Yeah, so I'll start off. It's okay. Yeah, yeah. So while he is copying it, I'll start presentation. Has it been there for more than a week or not? Are there symptoms of UTI? Like, is there dysuria, flank pain and frequency and all of that? But, yeah. And in female patients, always ask for local candidiasis. You want me to wait, sir? Sure.
history-wise, so we need to see if it was a midstream catch urine. Was there any local candidiasis, especially in female patients where they have vulvovaginitis? How long the catheter has been in situ? Always ask for the symptoms, like was there dysuria? And if there's sepsis, always look for another focus as well. And there are certain patients who are at risk for developing candiduria, that is in neonates or low birth weight, neutropenic patients, patients who have undergone or are due to undergoing urological procedures, urological comorbidities, previous urological procedures, and on those who have been on multiple antimicrobials for a long time. And if the blood culture is also positive, that is a sign that it might. So the first case was actually a diabetic patient, hypertensive, post-renal transplant, had an indwelling catheter for the last 15 days, developed fever, and this urine culture has grown Candida tropicalis, which is sensitive to all agents. And yeah, so now should we treat or not is the question. So post-renal transplant patient with a catheter-associated UTI, should we treat or not is the question. Yeah. What should? All right. Yeah. So what should be the approach? Sorry. Right. So approach-wise, yeah. So first of all, this sample was taken from the urinary catheter, which was in situ for more than 15 days. So we are wondering, okay, could this be a colonizer or not? So the best approach would be to actually remove this catheter, put in a fresh catheter, and then obtain a urine culture from that. And if that also grows, we might have to take it as significant, but maybe the first one might have to be disregarded. A urine routine which shows pus cells could also be taken as significant, but yeah, and always essential to look for other causes of fever in such patients. Right. So yeah. So sir was also telling us. So if there is candidemia, that is candida in the blood, there can be two types. It can be ascending infection or descending infection. That is, ascending is basically a urinary source going up into the blood. Descending is from the blood, basically candida from other sources, blood, and then coming to the kidney and into the urine. So sir was saying 80 to 85% of cases are actually descending, which means there's candidemia followed by candiduria, which means infection is elsewhere. And it's only 6% where you have the urinary tract source as the source for candidemia. So whenever there is candiduria, look for other foci of fungal infection. Right. So we had discussed this earlier. So even though this patient was actually post-renal transplant, he does not warrant treatment because he doesn't fulfill the criteria. So whenever if we decide to treat patients for candiduria, what are the things that we should look at? One is the efficacy of the drug as such, and very importantly is
Suppose this
right.
patient is having candida auris, as you have shown.
Yeah.
So will you like to treat this patient?
Yes, sir. So I has a slide for that. Should I wait for that slide? Go ahead. Yeah. Okay. So yeah, the take home from this slide is fluconazole has good urinary penetration, so should use that drug. So this is the slide which I was saying. So even if it's Candida auris and if it was taken from an indwelling catheter and it does not have any other fulfilling criteria, we should not treat it. Only if the other criteria are met, should we treat Candida auris also. As in like, so if is the patient neutropenic, like or in neonates.
But the thing is that patient is not.
Yeah.
Are
So.
you going to treat Candida auris?
So if it was taken from the catheter which was in situ for 10 to 14 days, I would not, sir. I would reinsert a catheter and see if the urine culture grows again. And
Suppose the patient is asymptomatic candiduria is there, and there is Candida auris is coming.
yeah, need not be treated any more than any other Candida species, sir. I wouldn't treat it, sir.
You don't agree on that. You don't want to treat.
Suppose I say that I don't want Candida auris in my ICU.
Okay. Then I'll have to shift him out of the ICU, sir.
Reinforce your infection control center.
Right.
This is not
Okay.
because you hardly have any tools to do that.
All right, sir. All right.
That is also not easy to decolonize.
Okay. So, all right, sir.
How we decolonize Candida auris? Just right now. Chalo, first discussion.
Yeah. Right. So the second case was a 47-year-old man, again a renal transplant patient, but here the donor was a deceased kidney donor, and the recipient was on post in a lot of immunosuppression, and the recipient grew Candida albicans, which is sensitive to all agents. So can this be ignored is a question. So very similar to the other question, just that this is a deceased donor kidney transplant. So in this case, we should think of something called a graft site candidiasis. This is basically from the donor who has been treated with multiple antibiotics and his kidney was actually infected with Candida, and that has now come into the recipient. So in this case, this patient will require treatment because of the graft site candidiasis. Going on to the last case, 60-year-old man, diabetic, has a left ureteric calculi with obstruction, normal creatinine. Anyway, he underwent DJ stenting and stone was removed, and the proximal urine was sent for culture. You can see the hydrouretronephrosis and the DJ stent in situ in these images. So the urine culture eventually grew Candida glabrata, and it was actually susceptible to most of the antifungals, candins and azoles, and fluconazole was reported as 8-SDD, that is susceptible dose dependent. So in this case, what should be the treatment for this Candida glabrata? Anybody wants to take a guess? Okay, I'll discuss. Yeah, so so the answer is actually fluconazole, because yeah, it's all right. So it's not A because voriconazole does not have good urinary penetration. Again, even for me, micafungin, the urinary penetration is not good. The best urinary penetration is for fluconazole. However, the MIC is given as SDD. So in UCAST and CLSI guidelines, susceptible dose dependent means so that the susceptibility to the drug depends on the dose. So if you give it at a higher dose, maybe the organism becomes susceptible to that drug. And so when you look at the CLSI here, the break point for is there's no sensitivity or I intermediate. It's only SDD and resistance. So if the MIC is between 32 and 34, then it is SDD, and that drug can be given at a higher dose and not the usual dose. Yeah. Yeah, okay, sir. Below 30.
That is nothing but only SBD for all.
Less than 32, right? 0 to 32.
If you look at this, they are saying 0.001. Below than nothing is this.
Okay.
So in other words, there is nothing like susceptibility.
All right.
Different ways of saying the same thing. One is in English, one is in German. That's all. Now this particular case.
Right.
So you said you are going to give fluconazole.
Yeah.
Because of the higher dose concentration, because this is in kidney, fluconazole gets concentrated, so all these factors are there.
Yes, sir.
Suppose this particular patient, it shows resistance.
Right.
What drug will give?
Yeah. So for this patient, sir, so I was discussing with sir, and so the other options we have is no. He said echinocandins like micafungin. So the with flucytosine as combination. So he was mentioning. So flucytosine is taken up by the fungi through a channel called permease, and flu cytosis is converted to 5-fluorouracil, which is cytotoxic. Okay, right. Caspo. Okay. All right. Below. Sure. All right. I think last few things. So this patient Glabrata and Glabrata actually has biofilm formation, which actually and efflux pumps, and biofilm actually increases the MIC by a very great number, 256. So even fluconazole might not work in such a state. So how do we remove the biofilm? We'll have to take the digestion out. Yes, sir, from the digestion. Yes, sir. So we'll have to take the digestion outside. Yeah, I think we have discussed most of this, and yeah, closing thoughts. Yeah, basically. Thank you.
लास्ट वाला लाइन जो लिखा था this situation because every intensity will bother you to you have to stand up that is the meaning that is
diabetes and CKD who presented with fever of unknown origin since 6 weeks with 8 kg weight loss. And there was a slowly progressive ulcer at nasolabial fold with crusting and painful palatal ulcers.
So, Sita, after CT कर लिया इस patient ने. Patient is having CKD.
Yeah,
patient
so
is having fever.
Yes, so
of
this
unknown origin and 8 kg weight loss हुआ है. Slowly progressive ulcer. So, shall we go for CT directly or?
no, we'll have to go in for the yeah. So at this point,
looks like as if there was riots in this place for a long time.
could be a.
Anyway, so what is your differential diagnosis?
So at this point, so this is an elderly male with who's immunocompromised and with presenting with PUO at with weight loss, PUO since 6 weeks, history of fever, and weight loss of 8 kg. And he's having slowly progressive ulcer at nasolabial fold with crusting and painful palatal lesions. So at this point, I would like to think of considering our this thing. I'll think of tuberculosis first, considering the constitutional symptoms, and also I would like to think of HIV in an immunocompromised patient.
Very good.
And
excuse me, why would you think of HIV? Is this the HIV is the cause of this ulcer?
No.
No, so then
No.
you think of a
Immunocompromised host.
So that is fine, but first tell me the differential diagnosis of these 2-3 things in a patient who's got fever and 8 kg
That is the simple question.
Fever with weight loss, tuberculosis.
So one thing you have said tuberculosis.
No, again, could be a
No, yes and no. It is not very easy to say no. There is something called as tuberculosis orificialis, something. There is a name like that.
That's I was coming to it. I was thinking that what type of, is it that we Mycobacterium tuberculosis produce this type or something else produce this?
NTMs usually cause mucocutaneous, because this patient presenting with mucocutaneous lesions, non-tubercular, Mycobacterium ulcerans.
What else? How कोई DD हो सकता है?
Patient if is coming from
6 किलो वेट कम हुआ है 8 kg.
Yes.
बिहार से आया तो
और what is difference?
बिहार और राजस्थान में भी है आजकल.
और मणिपुर से आया तो.
But that will be an immunocom.
Can it be a
Yeah.
talomycosis case?
Yes, it could be a taloromycosis.
Talomycosis not the ideal presentation.
No, with this type
What
of skin lesions.
presentation is there? Talomycosis? It produces
Pulmonary.
molluscum contagiosum type of lesion.
That will be like a.
This is not the ideal case.
No. For this, no, molluscum, like if you're thinking of talero or molluscum, it will be kind of an umbilicated.
Leishmania.
Cutaneous leishmaniasis, possible.
Can it be leprosy?
Yes, it could be. No, but mucocutaneous, yeah, it can be, sir. But
Weight loss is
herpes, herpetic lesions, yeah. Yes, herpes simplex can cause. Hmm. Hmm. So the available reports that we have, they had investigated. So the basic counts, the basic CBC showed total counts of 3,200 and HP of 10.2. ESR was elevated, and HIV was reactive, and again HPSAG, HCV, and syphilis was again non-reactive. CD4 counts were to the lower side of 70 to the 78, and HIV viral load was very high, 2,56,000. And LFT was and the RFT serum creatinine was within normal limits, and electrolytes were also normal.
दिखा रहा था ना, वो तो दिखाओ. इससे पहले वाले स्लाइड दिखा रहा है ना CT का. तो इसमें क्या दिखा रहा है?
No, this is adrenals, enlarged adrenals, sir.
So what do you feel? Is it adrenal tumor?
No, at this point, yeah, adrenal. It's basically an enlarged tumor at adrenals. At this point, we can say.
No, I'm saying, can it be something of a malignant type of lesion of the adrenal gland?
Malignancy when just with the CT you're asking, sir? No, bilateral adrenal enlargement in an immunocompromised.
So no, I'm just wanting another thing. Yes, you are leading to histo, we all understand. But be careful. Sometimes I have shown you one Indian case, blastomycosis, which is also can present like bilateral adrenal tumor.
Yeah. Yes, sir.
Thus, cutaneous involvement is more with blastoma.
And that is also another important factor. Blastocysts having got more cutaneous involvement, more bony involvement.
Histo also has bony.
Histo has no bony involvement. Histo does not have bony involvement. Histo can have bone marrow lesion, but histo don't have bony involvement like that, which is seen in case of your blastoma.
fluids. चलो आगे.
At this point, the biopsy. So biopsy was taken from the palatal and the skin lesions. So and also serum galactomannan was done, which was found to be elevated of 3.48. So and the biopsy from the thing remained sterile for 4 weeks. And this was a histopathology report from the palatal ulcer showing the like we have both the silver stain and the H&E staining with the, as you can see here, that is the histoplasma with the halo, and here again silver staining showing the histoplasma. Considering the size of the histoplasma, that is around 2 to 4 microns, when compared to blast. It could be, but we don't know the emergomycosis. Again, could be, yes, sir. It could be.
Can it be leishmania?
LD bodies should doesn't. No, usually histo will be.
These are the things you have to see. These are
The halo.
Microscopic finding. What are the DD? One is the DD. Can it be this Candida glabrata? Smaller is Candida glabrata can be. Crypto to larger. Second है, can it be penicillosis or talomycosis? उसके साथ कैसे differentiate करोगे? They usually do the transverse septation.
Yeah, yes sir.
ठीक है ना? So ये सारे point आपको दिमाग में होना चाहिए. Why it cannot be toxo? ये सब ना आप करो. ये थोड़ा सा आपको माइक्रोस्कोपिक पिक्चर की डिफरेंशियल्स यू नीड टू नो. टॉक्सो की सिस्ट होता है, ठीक है ना? चलो टॉक्सो वहाँ नहीं है.
So how will you treat? So coming to the treatment side, usually for histoplasmosis, you treat with amphotericin B, and then you'll have an induction phase that usually lasts for around 2 weeks. And for disseminated histoplasmosis, the ideal duration of treatment will be up to 1 year, and it will be based on the clinical improvement also. So liposomal ampho-B induction and maintenance will be with itraconazole. And this was after 6 weeks of treatment where the lesions had resolved. Yeah, so ideally we should be treating the patient for almost a year for histoplasmosis disseminated. Which one, sir? He was from, sir, actually.
Geographical origin of the patient.
No. Okay. So that will be, so ideally we should be treating this opportunistic infection for 2 weeks and then start off with the ART regimens.
The patient is having HIV. Is it the ideal presentation of histo? This we see in non-HIV, this type of presentation. What is usual presentation in HIV?
It could be pulmonary histo or pulmonary lesions.
And then
disseminated.
It can be there and
two manifestations also.
It can have cutaneous manifestation, some of the cases, disseminated. You know, that's why it's a overlap whenever there is a type. Like suppose talomycosis and histo both are there. There it comes a problem in case of differentiation in these two groups, talomycosis versus histoplasmosis. Because histo produces similar type of skin lesion, molluscum contagiation type. Understand?
Umbilicated
So
lesions.
this is not a common presentation of HIV. HIV may, those are the disseminated histo, or there is acute invasive lesion in pulmonary lung, which is common. Not this type of presentation. Okay, carry on.
Yeah. That's it. This was the thing. Thank you.
So remaining red.
Hello.
Introduce yourself.
Good afternoon, everyone. I am Dr. Nirmal. I am a DM trainee resident from Government Medical College, Kottayam. So, infectious disease. We will be discussing today a common clinical scenario. This is a 36-year-old male patient who presented with fever of up to 100.6 degree Fahrenheit for 1 month, weight loss of 6 kg, weakness, progressive worsening headache since 10 days, visual disturbance since 3 days, vomiting since 3 days. This is the history of the patient. We are having a 36-year-old male who comes with fever of 1 month.
So what do you think about this particular presentation? 36-year-old man, fever है, 8 minus 8, weight loss है, 6 kg, weakness, progressive worsening headache since 10 days, visual disturbance, vomiting
So,
since 3 days.
So with no background history as we know now, this is an young male coming with 1 month fever and now has an acute worsening with features of raised ICT, intracranial pressure. That is, he is having worsening headache, visual disturbance and vomiting. So here we are dealing with a patient with probably acute to subacute meningitis, probably in the course of a subacute indolent cause. Anyone have any opinion on the differential diagnosis at this point? Acute worsening. Fever is present for 1 month. Maybe the acute worsening is in the acute or subacute cause.
Do you think in this case is acute meningitis?
No, subacute meningitis more favoring than the acute meningitis. Acute meningitis. It is probably a subacute meningitis. Or a subacute meningitis.
What is the difference between this acute, subacute and chronic?
Mainly on the duration and the presentation of the patient.
So what are the DD?
In an Indian scenario, the first DD that should be coming to our mind is TB, tuberculosis. I am giving the option to the audience.
They should answer, not you. I am asking you.
Yeah. After TB, we can have brucella, then syphilis, then maybe chronic viral meningitis like CME, HSV.
ये सारे इतना syphilis वगैरह इतना common है. उससे पहले तो ठीक है TB पास. Next.
Brucella.
हो सकता है. Brucella कितना common है? To have this type of presentation. उससे पहले जो है तुम्हारा क्रिप्टो बोल ही दो ना. पहले क्रिप्टो का बोलो.
But without a background history of immunocompromise?
Not necessarily.
Okay. Immunocompetent crypto can also be
now we are seeing that non-HIV crypto is quite common. It's not very unusual. At least in PGI Chandigarh, they are seeing now at least in a month 2 or 3 cases in this.
Sure, sir. So crypto can also be a common presentation.
Brucella is here, right?
Yeah.
What else? You say syphilis?
Syphilis.
Anything else?
Then chronic viral meningitis.
Chronic viral meningitis. Yeah.
Then fungal
Which
meningitis.
is chronic viral meningitis will produce? What are the cause of?
HSV. Then
Will it be herpes?
Herpes simplex.
No, I am asking you, what when you say virus, which virus?
HSV2 virus.
अच्छा HSV. चलो.
And rarely fungal meningitis can also present with subacute meningitis in an immunocompetent host.
Fungal meningitis means what are the fungal meningitis?
Predominantly endemic mycosis like histoplasma, coccidioids.
Have any one of these all has seen histoplasma meningitis in India?
No.
I am asking both Dr. Atul Patel and Dr. Rajiv Suman. होता बहुत इससे only thing had been seen in USA. It's not seen anywhere. So don't go by that. इंडिया में क्या होता है वो सोचो. So that's why when you say fungal meningitis में crypto, none other than this. Aspergillus meningitis is very, very, very rare.
Okay.
It's not common.
Okay.
Yes, histo and cocci, there are meningitis, but this is not seen in India. I have not seen yet any case. So these are the points you must remember about it.
So coming to the examination, the patient is sick looking with an agony of pain, a temperature of 99.6 degree, a pulse rate of 60 per minute, BP of 106 over 70 millimeters of mercury, anemia, and a few central umbilicated papular lesions over his forehead and face, extensive oral thrush, discrete bilateral cervical lymphadenitis, no necrogyity, right lower motor neuron, 7th cranial nerve palsy. Rest of the examination was unremarkable. He had no significant past medical illness or habit of tobacco smoking for past tobacco chewing for 10 years. So at this point, we are coming to know that this patient is immunocompromised. Basically, from the finding that he is having extensive oral thrush, which indicates towards candidiasis, oral candidiasis, and he is also having discrete bilateral cervical lymphadenitis, which can be due to immunocompromised state of HIV. Oral candidiasis can also be due to HIV. Now he is also having an additional finding of right lower motor neuron 7th cranial nerve palsy, which can be seen in cryptococcal meningitis also, and also in some other conditions like TB meningitis and the other fungal meningitis. Now coming to the investigations, his blood workup is showing HB of 10.4, WBC of 3400, ESR of 75, biochemistry is normal, HIV has now come to be reactive, CD4 is 64, CD8 is 566, X-ray is normal, USG is showing few enlarged retroperitoneal nodes with mild splenomegaly, HBsAg, HCV, VDRL and VDRL or syphilis is negative. Here the important point is he is HIV positive and his CD4 count is 64, which is very low for an HIV patient. Now coming to cryptococcal meningitis per se, the CD4 count is usually less than 100, and the chance for cryptococcal meningitis or disseminated cryptococcus increases very highly in patients having CD4 of less than 100. And now we will be proceeding with the further diagnostic workup and treatment. From the history, it is clear that the patient is having raised ICT or raised intracranial pressure. The first modality would be imaging the brain. We can go in for CT and look for any space occupying lesions or any mass lesions inside the brain. Here the MRI was showing meningeal enhancement, patchy meningeal enhancement with prominent sulci. Rest was unremarkable. So the next approach will be to proceed with a lumbar puncture study. The first thing to be observed in a lumbar puncture study is opening pressure. Here the opening pressure is 410 millimeters of CSF, which is very high as compared to the normal of 50 to 150 millimeters of mercury. And the protein is nearly normal. Sugar is on the lower side with 48 milligram per deciliter, and cells is 4 per cubic millimeter. So we are dealing with a CSF which is having high opening pressure with low to with high to normal protein and low sugar with a cells of 4, probably in favor of fungal meningitis. And the opening pressures direct towards cryptococcal meningitis with a 410 millimeters of mercury in an HIV positive host. Now VDRL CSF is negative, ADA is 4, which is also in the normal side, and the India ink is positive with multiple thick-walled yeast seen. And gene expert is negative. CRAG, that is CSF cryptococcal antigen, is positive with a titer of 1:320, and cryptococcal culture is positive from the CSF, which is growing Cryptococcus neoformans. Yes.
thick wall yeast, generally we don't see thick wall yeast in case of crypto. Thick wall yeast is seen in case of our blasto.
Okay. But her culture has finally grown Cryptococcus.
So,
And the crag has also come as positive.
I understand that, but how thick wall yeast is there? I was wondering this. Because you know, any thick wall has the concept of having the budding would be less. Any thick one. Whenever there is budding, it requires a larger budding. That's why in blasto, we see broad-based budding. Because it has to take from the thick cell wall going into this. So the small, narrow and budding would not be there. So that's the conceptually, in case of this, it's not thick wall, but it's a circular yeast. That is very common in case of crypto.
So all the tested drugs were having good MIC or lower MICs. Coming to the treatment part, cryptococcal in an immunocompromised or HIV patient is treated in 3 phases. One is the induction phase, where we go in for a high dose amphotericin B, which is usually 3 to 5 mg per kg, along with 5 flucytosine at a dose of 100 mg per kg per day. That can be given for 2 weeks. Then a maintenance consolidation phase with fluconazole of 400 to 800 mg per day, and then maintenance phase of fluconazole with 200 mg per day. Maintenance can be continued up to 1 year till the patient is.
Do you think that we should do something for this high opening
High
pressure?
opening pressures can be treated with lumbar puncture daily or CSF drainage till the pressures become around 150 millimeters of CSF, or the patient is symptomatic, we can do it
So how
daily.
much CSF we should take out?
We can monitor the patient, and usually we can take out around 25 to 30 ml of CSF per drainage.
Daily.
Daily. So and treatment can be continued, maintenance phase can be continued up to 1 year till the patient CD4 count is more than 100 and patient is having a non-detectable viral load for 3 months.
Suppose the patient is, though you are giving therapy, patient is not improving.
Improving in the sense that clinically failing, or a patient is having microbiological failure.
Patient opening pressure is coming down, no doubt, but there is a failure which is being seen.
We can go in for an alternative therapy, taking into account of drug resistance.
Shall we give in this scenario, like in TB, steroid therapy?
Steroid therapy is usually not recommended for cryptococcal meningitis treatment.
What it had shown, that is the study clearly. Study had shown that that is not giving
It is
any
causing
added advantage.
Maybe in severe IRS we can try glucocorticoids.
What is IRS?
Immune reconstitution inflammatory syndrome.
How you diagnose IRS?
We are having any other new infection, or we are having a worsening of the cryptococcal meningitis on starting ART.
No. What are the
Worsening
definition? Definition means I am going to diagnose this as IRS. What are the criteria it should have? Have you gone through IRS?
It should be an ART naive patient. He should be an ART naive patient.
ART naive patient is not the criteria for IRS. Yeah, Atul, ART.
So other management issues are drainage of CSF for increased ICT. Then duration of therapy is around 1 year. Then when to start ART is usually guidelines say around 2 to 10 weeks. Usually we can start after 4 weeks of therapy for cryptococcal meningitis.
Any question to him? No question? No other. Okay, thank you then.
Thank you, sir.
That marks the end of day 1. Tomorrow again we will be starting at 8:30 instead of 9, so that we hope that by at least by 1:30 we'll be able to wind up the sessions. So kindly note the change in time. For those who are missing, I'll put in the group also. And tomorrow there will be a post test. I'm extremely excited to say that at least we had a couple of people who have got 25, above 25 in the pre-test. So I'd like to see how much it goes. I saw marks of 29 also for the pre-test. So we'll see how the post-test there happens.
There are already more than 75. 75%.
Yeah.
Identify those, we may not come tomorrow.
Right. Okay, then thank you all.
Tomorrow we start at 8:30 instead of 9, so that we finish early.